हेलो 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 हेलो
ठीक अली। हाँ अली भाई।
हेलो। हाँ, आ रहा है आवाज?
हाँ आ रही है आपके पास, ठीक है।
हेलो। मुझे भी आ रहे, ओके।
चलो ठीक है।
ठीक है, ओके।
जाओ नाश्ता कर लो यार। क्या है? ठीक अली। Sir, can you pass the mic? Thank you so much. No, check. 1 2 3 4. Hello, check 1 2. Hello, check. Check 1 2. Hello, check. Check 1 2. Hello, check 1 2. Hello, check 1 2. Check 1 2. Hello, 1 2 3 4 5 6 7 8 9 0. Check. Hello, check. Check 1 2.
ठीक अली लॉगिन मार हेलो अली আমাদের জন্য अली
हेलो।
हाँ अली सुनाई दे रहा
हाँ दे रहा है।
क्लियर
हाँ क्लियर है।
एकदम क्लियर
एकदम क्लियर।
ओके डन अब यूट्यूब दोनों सिस्टम पे लगा के चेक करते रहना
अच्छा ठीक है, अभी तो ऑन है सब।
अरे हाँ मैं बोल रहा हूँ जनरली
हाँ
चेक
ठीक है,
करते
चेक
रहना
कर लेंगे। ठीक ठीक।
एक एक सेकंड हेलो हेलो
हाँ
हेलो अरे ये पीछे से नॉइज कहाँ से आ रहा है
अरे वो मेरा यूट्यूब खुला है ना, वहां से आ रहा है।
हाँ ठीक
सिस्टम
ओके
पे यूट्यूब।
फोन पे कनेक्ट है क्या
हाँ फोन से कनेक्ट करा है।
तो बाहर जा लिफ्ट के पास जा
एक सेकंड जा रहा हूँ।
तूने राहुल को जल्दी नहीं बुलाया
नहीं।
बुला लेना चाहिए
चलिए तो हो गया।
हाँ ठीक है
हाँ हेलो।
हाँ
हाँ अभी लिफ्ट के पास हूँ।
लिफ्ट के पास है ना
हम्म।
यहाँ पे कोई इको नहीं है
नहीं कोई को नहीं।
डन सही
check 3. Check 3. Check 3. Hello, check this. Hello. Hello, check 1 2. Hello, check. অডিওটা যাচ্ছে না, আপনার এটা অন জুমের আউট, যেটা আমি আউট দিয়েছি, যেটা প্লে হচ্ছে না, আমি বলছি তো, ভালো করে দেখে নিন আপনি। পাপাদা, পাপাদা, ঠিক আছে, হ্যাঁ এবার দাও শুরুশ্রী। হ্যালো চেক, হ্যালো চেক 1 2 3 4 5 6, হ্যালো চেক, চেক 1। হ্যাঁ এই তো,
1 2 3 4 5 6
হ্যাঁ একটু কাউন্টডাউন দাও, কাউন্টডাউন দাও।
হ্যালো 1 1 2 3 4 5 6
ব্যাস ব্যাস, অসাধারণ।
ঠিক আছে
10-এ 2, 10-এ 2।
10 এ 2 ঠিক আছে বাকি 8টা হয়ে যাবে
আচ্ছা তুমি আমাকে হ্যান্ড মাইকটা একবার দাও, এটা হয়ে গেছে, এটা ঠিক আছে, হ্যান্ড মাইকটা একবার দাও। হুম, আজকে তোমার কটায় স্টার্ট জানো তো? আমার ভয়েসটা ঠিক আছে তো, অসুবিধা নেই তো, কিছু বাড়বে কিংবা কমবে? না অ্যাকচুয়ালি মুখটা, আমি মাইকটা অনেকটা সামনে আছে, বা ডক্টররা তো এত সামনে ক্লোজে বলে না। দাও একবার হ্যান্ড মাইকটা দাও।
হ্যালো চেক চেক 1 2 3 4 5 6
হ্যাঁ ঠিক আছে,
ঠিক আছে
হ্যাঁ একটু, একটু আকসেস সেন্টটা একটু কমাও না এই মাইকটা,
আচ্ছা ঠিক আছে ওকে
নাহলে ঠিকই আছে, ছেড়ে দাও, ঠিক আছে, ঠিক আছে, ঠিক আছে।
Morning and time to start today's session, and I'm delighted to have our faculties from nationals, Dr. Anmol, Dr. Anoop. You know that the icon today you have a parallel session in IGCTO. Our endeavor was to introduce the local talents with live cases from our local hospitals, and we have online platforms too. We have CD presentations, and first time we have awarded, we'll be awarding 1% from the CD presentations who will be the winner, and will get a ticket to TCT 2023 San Francisco, up and down. Also introduced a technician quiz with a prize of 15,000. Nurses quiz with a price of 15,000. So there's a lot of enthusiasm. But nowadays, you know, if you introduced a virtual platform, people may not be willing to attend in physical format. So it is a mix and match. Even then, the time goes on, show go on, and I do not know what will happen to the future. So there is a stiff competition between a physical presence and virtual absence. Today, I thought a surprise announcement for the one for the stall and one for CD presentations. So CD presentations is going on, and once that is finished, we'll start a session here. So me, Soumitra Kumar and Pandey visited the local stalls, and we found SMT is the best, and SMT gets the prize. So I'll announce what amount of. Second winner is ALTS. And with that, I will go for the academic sessions, and I'll head over the session to our anchor person. Yeah.
So good morning, ladies and gentlemen, and a very good morning to each and everyone right here. And exactly, we're here with AII SICON, and this is 2013, and exactly this is the second day, and we're moving to the first session of the day, Verve in Verve. So I request all the chairperson to be on stage. I request Dr. Arunlal Datta, Dr. BP Pandey, Dr. Pankaj Manoria, Dr. Subha Banerjee, Dr. Abhishek Palsikar, Dr. Mustafa Jaman, and Dr. Raja Nag. And I request for the first session of the day, I request Dr. Anmol Sunaria. Sorry, I'm very sorry. I request Dr. Anoop Agarwal, sir, for the first session. This is AVR in asymptomatic severe in aortic stenosis. So where do we stand? This is the thing. Thank you so much.
Good morning, all. At the offset, I want to thank Dr. Hazra, CSI West Bengal team, and my good friend Anmol for giving me this opportunity. I also want to take just a second to express my condolences for the horrific accident that happened last night, where a lot of our fellow countrymen lost their life in train accident at Orissa. With that, I'll start my today's discussion. This is aortic valve replacement in asymptomatic severe aortic stenosis. And I think this is a very relevant topic in the current era of low risk AVR, be it surgical or be it transcatheter. And are we good? Okay. And just for the sake of discussion, in the spectrum of structural valve disease, this is stage C1 that I'm referring to today, which is asymptomatic severe aortic stenosis. We all understand the pathophysiological and hemodynamic implications of severe aortic stenosis, all at the level of microvascular, myocardial, as well as the aortic level. I won't go into the details of it. Now, the current modalities of when to approach or when to offer therapy relies on symptoms. And as you look into the cascade of the progression of severe AS, you see symptoms is one of the very late findings, and a lot of damage has occurred before that. That's probably one of the reasons why even after AVR, these patients, they do not live, they do not match their age-matched peers in terms of their longevity and also in terms of their outcome. And that's probably the reason why we should start looking at, can we intervene early on these patients? When you have patients with severe AS in your clinic, about 50% of them will not report any symptoms at the time of diagnosis, but are they truly asymptomatic? They typically present in two different aspects. There may be a gradual decline in function status. So they may pretty much adjust to it, thinking that it is their normal aging rather than a disease. Remember, AS is a very unrelenting, it's a very chronic disease. And you know, when you grow, let's say 60 or 70, you don't have an experience of how it feels to be 70. You think it's all aging when it is not. We all follow the very age-old dictum that Dr. Braunwald and his colleagues initially described in 1968, where the onset of symptom was pretty much addressed on. You understand it's a study from 1968, it's a postmortem study with about 64 patients. And remember, at that time, we didn't have echo. So we really don't know what we are getting into. So what we do these days is for asymptomatic severe AS, at least what the traditional practice had been, is to do watchful waiting. May not be the best option in the modern era. We know that eliciting true symptoms are very difficult, as I elucidated earlier. Longitudinal follow-up is flawed. We don't know when to bring them, how frequently to bring them, when they come up to the clinic, what to do with them. Should we keep asking symptoms? Should we do some investigations? Progression of AS is unpredictable. There is a certain cardiac death risk, the annually rate of which can go up to 3%, maybe even higher in high-risk subset. Any intercurrent illness, they get COVID, they get UTI, they get whatnot, that lands up into cardiac ICU, that cannot be asymptomatic. Surgical risk is age-dependent. You do AVR at age 65 versus you do AVR at age 75. There is a lot of difference between the two. Definitive therapy later do not match the longevity that you expect, and watchful waiting is associated with higher mortality. This is a more contemporary data where you see that all these patients with severe AS who are asymptomatic, if you watch for them for the symptom onset, 75% event rate over 5 years. That is definitely different than what Braunwald curve showed. So if you look at these observation versus surgical, early surgical AVR in an unselected asymptomatic severe AS patient, observational arm is associated with 3.5 times higher mortality. Now, these are unadjusted, these are observational data. I'll show you some of the randomized data as well. So when should we offer therapy? Symptoms may be too late, but too early, now we have got surgical risk. So how do we find the optimal timing? And this is where some of the indices, they do help us. Treadmill test is a very good tool. We know there are concerns associated, but we also know that those asymptomatic patients who fail TMT, there is 6-fold increased risk of mortality in those patient subset. There are treadmill protocols which are established, which are available. I won't go into the detail, but you can incorporate that in your hospital, in your practice, and you should be able to elicit some of those symptoms, which can help you dictate which patient should go for early AVR. We can also differentiate severe AS from very severe AS, and these are the patients whose aortic Vmax is more than 4.5 or 5, and there is now reasonable data to suggest that very severe AS have very high incidence of sudden cardiac death, maybe higher than 3% per year. And with the Vmax, you can also get aortic valve area or indexed aortic valve area with less than 0.4 centimeters per meter square, definitely associated with much higher incidence of sudden cardiac death. These classification can be very easily made through your routine echo assessment. Recent recovery trial, which was published a couple of years back, that showed that when you do surgery in these very severe AVR who are technically or quote unquote asymptomatic, it is leading to a much better outcome as compared to those patients whom you choose to go for traditional conservative approach. Along with the Vmax or the aortic valve area, you can also look for valvular arterial impedance. There are established formulae of how to calculate that. And more than 4.5 millimeters of mercury with the indexed data, it is associated with worse outcome, and these patients should be offered early therapy. We all have learned how to look into the flow state. We establish patients on normal flow or low flow state. All those patients with severe AS who are in low flow state, they tend to have much worse outcome. And these are the patients who benefit the most with AVR. Ejection fraction, while we consider 55 or 60% as a normal ejection fraction, there is evolving data which suggests that ejection fraction less than 60% may be attributing to early myocardial dysfunction in those severe AS patients. And the rate of progression of severe AS is another marker. If you do end up longitudinally following these patients, and if their AS progresses more than 0.3 meters per second, that is the aortic velocity per year, they may be early progressor who will benefit from AVR. Aortic valve calcification has become a very routine tool in the CT tower protocol where we do, and there are cutoffs which are defined. They are kind of arbitrary cutoffs, but it does get the point across that patients whose valve are severely calcified, even if asymptomatic, they tend to have worse outcome. Global longitudinal strain and myocardial late gadolinium enhancement on MRI, they all are surrogate to show that there may be early myocardial involvement in severe AS patients who otherwise are asymptomatic. There are various cutoffs defined for GLS and also for myocardial fibrosis on MRI with a T1 mapping where the highest T1 tertile associated with worse outcome. So all these criteria, even in the absence of symptoms, tell you that the myocardium is asking for help and we should be offering therapy on them sooner. There are other high-risk features which includes biomarker positivity and many other entities which are less well validated. There are evolving data set which are coming in a randomized fashion, which are looking at the role of early TAVR, a low-risk AVR procedure in these patient subset, whether that is going to improve the clinical outcome or not. So as for the guidelines are concerned, in asymptomatic severe AS, if they are going for any kind of open chest wall surgery, then if their EF is less than 50%, any concurrent surgery, you should go for aortic valve replacement. That's a class 1 indication. All others criteria that I mentioned over here, some of them made it to class 2A indication, but as a general, they are still not strongly recommended for the lack of randomized data. All the values that I have presented to you have been summarized in this table. These data set, as I said, a lot of which are validated, but has not made the class 1 recommendation yet. I quote a phrase from a surgeon from 1965, that if you have a low hospital mortality with AVR, it can justify a policy of doing surgery early. So it's not a matter of that severe AS asymptomatic is not bad, or it is acceptable. It has to be matched to the surgical mortality that is there in your hospital. And if you are able to offer a low-risk AVR, I'm not talking particularly for TAVR, if you're able to offer a low-risk AVR, which can beat the sudden cardiac death risk that an asymptomatic severe AS patient has, it may be worth going for it. So I would summarize my discussion by saying that please beware of the masked symptoms. Take help of all these ancillary tools that I have mentioned over here. AVR in asymptomatic AS is allowed in certain subset that I mentioned. And if you can perform AVR in your hospital with low perioperative mortality, it may be a way to go. And there are trials underway where TAVR, which has established itself as a very low risk AVR in this subset, may be the way to go, but we have to wait for the data. Thank you so much for your kind attention.
Thank you for your nice presentation. Actually, you have demonstrated nicely, especially in asymptomatic severe aortic stenosis. And already you have demonstrated the natural history if the patient is actually undergo untreated, and which time the time of intervention. And again, you also mentioned that some evolving indication and emerging indication also. So first I welcome the audience. If any question, then we'll discuss, please.
Thank you, Dr. Anup. That was a wonderful deliberation, and you have made it very clear about when is the optimal timing for operating on a asymptomatic severe aortic stenosis. So we see these patients in our clinic regularly, and once the patient is told that you have a valve disease and that needs to be replaced, they almost go into a shock, saying that I do not have any symptoms. How can I have this problem? So the only way to convince them and also to find out whether they have achieved a stage where they need operative procedure is to go ahead and do a simple TMT, which I do in my clinic. And that will make everything crystal clear whether they are in need of surgery or they can be managed medically for the next 1 year or so, and keep them on a regular close follow-up. And the other question would be, like, these patients who are asymptomatic, having severe AS, what kind of surgery would they qualify for? Whether a surgical replacement or a transcatheter heart valve replacement? If you can throw light on that.
So, sir, TMT is definitely a very established tool. I just want to highlight that there had been a lot of concerns regarding putting these patients for treadmill with severe AS. There is a concern for sudden hypotension and syncope. That is true. So that is why TMT is contraindicated in those patients who have symptoms and severe AS. So before we subject them for TMT, we have to absolutely be certain that they are functionally active and they do not have any symptoms to the best that we can elicit. As far as your second question is concerned, so currently, whatever recommendation that the societies make for AVR in asymptomatic severe AS, they make it for surgical AVR. They do not make it for transcatheter AVR. That data is evolving. Nobody stops us from offering TAVR to these patients, but understand that that is not what society guidelines suggest. At the end of the day, you should be able to offer a low-risk AVR. For a low-risk patient, it has to be a low-risk AVR. We can't have a high-risk procedure for otherwise low-risk patient.
It's a brilliant lecture. I just want to know, because we have to subject this patient, for example, asymptomatic severe aortic stenosis for treadmill. So is there any standard protocol or steps that you follow? Because most of the patients are elderly. So what standard protocol we should follow?
Yes, sir. I did mention standardized protocol, both the one that I follow and there is one that societies mention. It was there part of in my slides. I will be happy to share it with you. Those protocols are very well established. The only thing I will add to that is these TMTs, they are symptom limited. And second, a healthcare professional needs to be there in the room, amongst other steps that needs to be followed.
Patient is mostly old age, so sometimes it's very difficult to do TMT or ETT. And because some symptom is sometimes maybe masked because the symptom and asymptom, the angle is very narrow. So we can, another options instead of TMT, DSC or others, we should evaluate the ischemia. That is important, but it is very difficult to ischemia. That's maybe due to aortic stenosis or coronary event. It's very difficult.
No, we are not looking for ischemia here. We are just looking for symptoms. These are symptom-limited exercise tests which we conduct to find out if the patient is symptomatic for his severe AS.
So if patient can do TMT, that can do, but sometimes there may be chance of complication in the table. So sometimes we avoid the TMT.
So yeah, dobutamine stress echo has been amongst all the parameters that I showed you. DSC is the least validated of all. So I don't think that even if we do DSC, we do not have cutoff defined very well. So I do not think particularly DSC will answer the AS question. It will answer the overall question. A very simple thing, if there is a concern for TMT, particularly elderly age and whatnot, a simple BNP is a very good idea. If you can exclude other causes of why BNP is elevated, simple BNP can also guide you through that. There are other parameters. As I said, I mentioned a lot of them over here, which had all been validated. One can refer to these pictures. And then the question of TMT protocol, there is actually a very good TMT protocol, which is listed. I have summarized some of that. And this TMT protocol can also be used. But echo, as I said, it's not validated that well.
Right. As usual, brilliant talk. If you look at the conduction system and aortic stenosis, if you have pacemaker, LVB, those patients are out, even they are asymptomatic with severe stenosis. Can you have a patient who's got RBB with asymptomatic aortic stenosis vis-a-vis normal ECG with aortic stenosis? If you tell them to undergo TMT, the chance of sudden cardiac death, do you think, like if you have RBB and do a TAVR, they're going to complete R-lock. If you do not have those, they can escape with the high implant of the TAVR. So any idea if you have RBB, should you also send them for TMT?
I have not come across this precise question, sir. If a situation like this comes to me, I will try to use other ancillary tools which I can. But if I have to go for a TMT, that's okay, I can go for it. But as I said that with any deviation from normal, I have other tools that I can use before I subject to TMT. I can still subject to TMT. The important point is the physician needs to be there. We need to be very vigilant in what is going on. And sir, one more thought about elderly patients who cannot go on TMT. If there is an elderly gentleman who cannot go on TMT, there is a very good chance we are dealing with MAST symptoms in that patient. So in that subset, you probably don't need anything. You have a diagnosis with you. Thank you so much. Thank you, sir.
Thank you. Next speaker, Dr. Anmol Sonovan, bicuspid aortic valve and TAVR.
Welcome back, Anmol, again.
Very good morning, everyone. And thank you, Dr. Hazra, sir, for having me here and giving me this opportunity. And thank you, panelists. I think I'm going to talk today on this TAVR in bicuspid aortic valve. Where are we today and what we know till now? I think this topic is really very relevant for India as well as the Asian continent, where the bicuspid aortic valve incidence is extremely high. In India, it is as high as 40 to 45%. What do we know about bicuspid aortic valves? There are conflicting reports of efficacy, no randomized data till now. Still some uncertainty with procedural conduct and little hesitation about treating high and intermediate risk of bicuspid patients. Surgery, well, it still have a role in some patients, in very young patients or patients who are requiring Rose or mechanical valve, patient with significant aortopathy, hostile LVOT calcium and anatomy, and unicuspid aortic valves. The concerns with bicuspid aortic valve, the annulus is extremely large, eccentric, elliptical. The ceiling zone is whether it is annular or it is supraannular. Positioning, whether you have to place them at the annulus level or supraannular level, whether they will anchor, they will not anchor. Severity of bicuspid aortic valve depending on whether it is a type 0 or type 1 with calcified raphe, without calcified raphe. Asymmetric aortic cusp, non-circular deployment. Coronary occlusion in spite of coronary heights are good. Heavily calcified leaflet, they are extremely heavily calcified valves. Calcification with left ventricular outflow tract and aortopathy. This is very important. The people who are treating TAVRs and aortic stenosis, they should know this classification very well, because that will help you to select your patients. Type 0, which is no RAFE. Type 1, which is 1 RAFE. Type 2, it is 2 RAFE. It has been subclassified again in type 1 is subclassified again into 3 types: type 1A, 1B, 1C. 1A being the commonest, in which the left and R cusp is fused. Anatomical consideration, if you see, it is a heterogeneous cusp, sinus morphology, heavily asymmetric calcification, long commissural distance, aortopathy, angulation, and coarctation association. But we have to remember one thing: bicuspid aortic valve has been excluded from all the RCTs, whether it is a surgical aortic valve replacement trials or whether it is a transcatheter aortic valve replacement trials. So this is very important. There is no randomized control trial in bicuspid aortic valve till date. Sizing is little different from tricuspid, but almost in 80 to 88% of the times, the sizing is on the basis of annular, because most of the times it is either tubular anatomy or a flare anatomy. Only the anatomy where it is tapered, the sizing can be done with the supraannular measurement. Otherwise, almost 90% of the times, the sizing is based on annulus. There are not only the sizing and selecting a valve, you should always try to do and analyze the bicuspid aortic valve with the circle method, in which you can, whatever the valve you are trying to use, you can use it into the trementio and see how that valve size is going to behave with the whole aortic root complex. That will give you an idea, and that will prevent major complication like annulus rupture or coronary occlusions. What evidence says? In 2016, there is a study which has been published comparing 546 patients compared to tricuspid aortic valve, and what it shows: aortic root injury, aortic rupture, second valve implantation, paravalvular leak, and new pacemaker were significantly higher in bicuspid aortic valve TAVRs compared to tricuspid aortic valves. Even the success rate with the earlier generation is significantly lower. It is 78% compared to the tricuspid aortic valve. Even with the latest generation and the new generation devices, the aortic root injury, second valve implantation, and paravalvular leak has gone down, but still it is numerically high. The 1-year mortality in this comparative analysis shows it is similar, 11.4 and 11.2% between bicuspid and tricuspid aortic valve. But is it true? Have they considered all the bicuspid, or they were selective in selecting their bicuspid data? Even STS registry, TVT registry shows the conversion to open heart surgery, annulus rupture, second valve requirement, and even all stroke and pacemaker were significantly higher in bicuspid aortic valve TAVRs compared to tricuspid aortic valve TAVRs. And the limitation for this registry, the bicuspid aortic represents a heterogeneous anatomic cohort, and it is possible that the operator has selected the most favorable anatomies, not all anatomies. So it is a biased. So does bicuspid aortic valve morphology plays a role in TAVR outcome? Yes, let's see about it. There's a beautiful study which has been done by Dr. Yoon and Makkar in US, which they classified the bicuspid aortic valve depending on RAFE, calcified RAFE, non-calcified RAFE, and a leaflet calcification. And they compared the outcome in this patient with earlier generation and the latest generation devices. They classified its calcified RAFE, non-calcified RAFE, or no RAFE, and combination with excess leaflet calcium, whether mild leaflet calcium or excess leaflet calcium. And what they found, the all-cause mortality is 15% at 2 years in this subgroup. The all-cause death, according to RAFE, the patient, bicuspid aortic valve patient with calcified RAFE, the 2-year mortality is 20%. So it is significantly, and it is very high compared to the patient who are having non-calcified RAFE or no RAFE. The all-cause mortality, according to the leaflet calcification, is at 2 years is 20%. So this is extremely high. So calcified RAFE and excessive leaflet calcium are independently correlating factor for all-cause mortality with bicuspid aortic valve TAVRs. They studied it more detail, and what they found, if those patients who are having calcified RAFE plus excessive leaflet calcium, that subgroup, the 2-year mortality is 25%. It is very high. Even after a successful TAVR, the 2-year mortality in a patient with calcified Raphe with excess leaflet calcium is 25%. What does that mean? Every out of 4 TAVRs, one patient is not going to make it a day at the end of 2 years. So is it right? Even if you see the procedural and 30-day outcome according to the bicuspid aortic valve phenotype, the phenotype with excessive calcified Raphe and excessive leaflet calcium has significant PVL, aortic root injury, major vascular complication, and 30-day mortality was significantly higher in this group compared to a patient who are having either calcified Raphe or calcium excessive leaflet or none of the above. Even if you see with all-cause mortality, even with the latest devices available in the market as of today, the phenotype with excess leaflet calcium and calcified Raphe, the 2-year mortality is as high as 23%, nearly 23%. So what are we offering to our patient? Bicuspid aortic valve are really young patients. And this kind of subgroups, even if they are low risk, as Anup has rightly pointed it out, still there is a scope for surgical aortic valve replacement, remove those calcified leaflet and take them out and put a new valve with a root enlargement. If you see the outcome with this subgroup, even with the latest device, the paravalvular leak, aortic root injury, major vascular complication, and 30-day mortality, even with the latest device, is extremely high with a subgroup with calcified Raphe and excess leaflet calcium. So this is the anatomy and this is the phenotype which is really not suitable for TAVR as of today. The all-cause mortality and aortopathy has some slight significance. The aortopathy, the all-cause mortality at 2 years is 18%. So what are the learning points, what we learned out of it? The calcified Raphe and excess leaflet calcium were independently associated with increased procedural complication and 2-year all-cause mortality. The high-risk bicuspid aortic valve phenotype, that is the patient who are heavily calcified Raphe and excess leaflet calcium, was found in 26% of the anatomies, and they are associated with 3-fold high mortality. So I still feel this is the subgroup which is still not suitable for TAVR. These are the subgroup where we should excise those leaflet, put a valve, surgical valve, and offer them and further future option of treatment. The impact of bicuspid aortic valve morphology on outcome was consistent in low surgical risk patient as well as the patient who undergo an TAVR with the latest generation devices. What is the clinical implication? The CT assessment of morphology in bicuspid aortic valve stenosis helps in assessment of anatomical risk for TAVR. And in the absence of randomized control data as of today, the approach to bicuspid aortic valve patients will be should be on a CT-based anatomical assessment to identify which are the favorable anatomies for TAVR and which are non-favorable anatomies for TAVR, and then we subject this patient for SAVR or TAVR. In order to conclude my talk, not every bicuspid aortic valve is suitable for TAVR. I would like to highlight this very categorically. In India and in Asian subcontinent, the bicuspid aortic valve incidence is as high as 40 to 45%. And we treat this, the dedicated bicuspid aortic valve randomized control trial is a need for time. Thank you for your patient hearing.
Thank you, Anmol, for making it so crystal clear for everyone about the indications of TAVR in bicuspid aortic valve. And I would let the floor be open and ask questions from the audience if there are any.
Thank you. Thank you for your nice presentation and brilliant presentation. Already you have mentioned everything. So my question, all the bicuspid, we always do not treat TAVR or SAVR. But my question, when you do the TAVR, suppose balloon dilation is mandatory or not in bicuspid valve?
So I think this is an excellent question. Every bicuspid, whether the leaflet calcium is excessive or mild calcium, the bicuspid aortic valve needs pre-dilatation and it is mandatory. it makes the, you have to prepare the bed properly. Otherwise your valve tracking across the annulus will be much difficult. And the more you will struggle with your device across the annulus, you increase the chances of stroke. That is the reason the stroke incidence in bicuspid aortic valve is almost double compared to tricuspid aortic valve towers. But it is very rightly said, the pre-dilatation is mandatory for every bicuspid aortic valve towers.
Thank you. I think
is there any role for native bicuspid valve basilica? Like if you can make it tricuspid again, there is chance of aortic regurgitations. If you think that the TAVR in bicuspid valve is really very challenging one and complications rates are much higher. So basilica is usually meant for your TAVR in SAVR. You slice those valves by basilica. So can you consider or a kind of palliations of the aortic stenosis by bicuspid valve by true cut, kind of controlled true cuts? So you cut the valves, or a lithoplasty balloon, you break those calciums and make these valves little more pliable. So what's your thought on that?
So I think extremely good question. First of all, the basilica is mainly used to prevent and coronary occlusion in a patient with TAVR, mainly in surgical post-surgical aortic valve replacement patient, to modify the leaflet modifying therapy. The native bicuspid aortic valve are invariably extremely heavily calcified valve. To cut through with the current basilica technique and tear those calcified leaflet, I feel it will be too much to expect from that therapy for native bicuspid aortic valve towers. Leaflet modifying therapy is the need. There are a lot of research going on, like even the lithotripsy balloon. Important thing is whatever we'll do modification, leaflet modification at the aortic root or aortic valve level, you have to be careful about a distal protection, the cerebral protection, because all these whatever you are going to modify will going to go into a distal circulation. So we have to be really careful about protecting the brain. You might modify, but there is a lot of chunk of calcium might embolize and go to the cerebral circulation, which can cause disasters. As of now, no trial has really proven a benefit of protection. The BAV, what are the struggle, what we do it at the aortic root level, what are the microemboli can cause. No device has been proven 100%, which can be beneficial to prevent the cognitive dysfunction or a major stroke. But I still feel, looking at the data in bicuspid aortic valve, the stroke incidence is almost double bicuspid aortic valve towers compared to tricuspid aortic valve. So leaflet modification is a need of time, plus it should be associated with much more protection at the distal level to avoid a cognitive dysfunction as well as major strokes.
Dr. Anmol, just
Okay.
one.
So one question really important, in case of the bicuspid valve, majority of the calcium which invade the conducting tissue, okay,
Yes,
that is responsible for the vesicular block, RBB or LBB. In that group of patients, you see, when do the TAVI, in that case, is chance of complete heart block definitely higher.
Absolutely.
Number one. In the one Chinese report there, all cases bicuspid, when their vesicular block pre-existing, they used to little higher up position of the valve. What is the opinion there?
See, so the deployment of higher 0 or 1 or 2 millimeter or nearly in bicuspid, they say the coaptation is supraannular and you can deploy at the 0 level. It has been proven, but still, if you see in bargain to deploy the valves higher, we have really increased the incidence of valve embolization and valve pop-outs. Second thing, if you see all the trials, the membranous septum, even the minimal height of a membranous septum will be 3 millimeter. If you see all the guidelines, if your conduction system and the pacemaker rates are increased, if your depth is more than 3 millimeter or 4 millimeter. If your depth is 2 millimeter or 3 millimeter, I don't think it really makes any difference in pacemaker incidence in those patients. But aiming for 0 and 1 millimeter, I still, in my opinion, I don't feel it is really right. A 2 to 3 millimeter depth should be really ideal for any TAVR device, what we treat with, according to me.
Thank you. Thank you very much for nice presentation. We must give the big hands to our speaker of the session. And now we'll move the next session. And thank you all again.
So the next topic is, I'm sorry. So our next speaker is Dr. Dilip Kumar. We're getting him online actually. So the topic is lifetime management. The topic is lifetime management of aortic stenosis. So I'm requesting all the technicians to get him connected.
Sir, can you hear us?
Yeah. So, good morning, everyone. Can you hear me?
Yes, we can hear you clearly, Dilip.
Okay. So, my apologies for not being there in person, and instead of playing a role of host, I'm playing as a guest. I really feel a little bad. Okay, so I had commitments to fulfill here in IJCTO, but my special thanks to West Bengal CSI, Prakash Da and Dr. Anmol, and we witnessed brilliant lectures, Dr. Anup and Dr. Anmol. So my job is to discuss lifetime management of severe aortic stenosis. And not long back, 6-7 years back, when a TAVR was done, the operator used to feel the patient should be through the procedure and he should survive the procedure. But now at this moment, at this juncture of time, once we do a TAVR, we look at how the patient is going to behave after 5 years, 7 years, or 10 years down the line. And that is why a lot of talk about lifetime management. But at the outset, I must tell, all the literature which is there from Western world may not be applicable to our Indian scenario, because our life expectancy is less and we have more of bicuspid aortic valves. We just heard Dr. Anmol about the challenges we face among bicuspid aortic valves. 30% of our population has, the TAVR going population has bicuspid, anatomy, and they are really, the outcome is not the same as what we see in the literature. So to begin with, these are the recommendations. A patient who is less than 65 years and life expectancy of more than 20 years, a SAVR is recommended, and that is, there is no dispute there. But 65 to 80 years, and if the patient has a favorable anatomy for transfemoral TAVI, and then we strike a balance, and it's a shared decision making between the patient relatives, and the patient's life expectancy and valve durability. We decide which way the patient should go. More than 80 years and the life expectancy is less than 10 years, and there is no anatomical contraindication to transfemoral TAVI, we go for a TAVR as a preferred option than surgical aortic valve. So what we see here in managing the patient and looking at the lifetime management of the patient, the best would be putting a one valve, be it a surgical, be it a transcatheter aortic valve, and it stays for the patient for life, but it doesn't happen. We have a kind of 10 to 15 years durability of valves, and that is why 2-3 things especially pop up when we decide. One is life expectancy, how much the patient is about to live, and second is valve durability. And then there are some nuances like the small annulus, the bicuspid anatomy, and then coronary access, and then how the pacemaker patient is going to behave after TAVR, or acquired LVV patient, how they are going to behave. So we'll talk to about them separately. So tissue valves are basically outsmarting, and this is getting more and more popular nowadays, and even younger patients, they are opting for tissue valves because they are free from comedoine, stroke, and bleeding risk is less. And tissue valve, this is the surgical tissue valve data, where they have shown around 75 to 80% valve durability at 10 years. Hopefully the same goes through and apply to our experience of transcatheter aortic valves as well. And I will discuss about these data. And the native valve and the bioprosthetic valves which is deployed, they are different, because a native valve can self-repair itself, and a bioprosthetic valve which is deployed can't self-repair, and it is a treated valve, so the degeneration is faster. And that too, some of the challenges which are unique to TAVR is the valve's leaflets in transcatheter aortic valve is thinner. So it's 0.25 millimeter as compared to 0.4 millimeter. So a thinner valve, there is apprehension that how it is going to behave with such a shear stress. And second, the valve is crimped on a platform, and sometimes TAVI frames are oversized to minimize the risk of paravalvular risk, regurgitation. So there are these are challenges and apprehensions which were there, and that could lead to valve dysfunction, structural valve deterioration. But it's not all structural valve dysfunction is structural valve deterioration. These are good number of PPM patients, patient processes mismatch, and sometimes thrombosis, endocarditis, they also play a role. So here we have to decide which valves needs to be given so that the patient prosthesis mismatch is less and patient's longevity is higher. So WARC 3 has given a defined criteria for the structural valve deterioration. So these are some data about how 5 years, 7 years different valves behave, but the most prominent and only randomized controlled trial till now in valve durability assessment is a NOTION trial where self-expanding platform core valve was compared with surgical aortic valve, and it was really promising. At 5 years, all-cause mortality, stroke or MI was similar, and even less than 4% STS risk. Again, TAVR and SAVR, the 5-year mortality, stroke and MI were similar. So in high risk, intermediate, low risk population, these all they have the same kind of trend. And this is the aortic valve performance. The aortic transcatheter aortic valve performed better. There was a high and more effective orifice area, and mean gradients were less, and that was even up to 8 years. So transcatheter valves, TAVI, outperformed surgical aortic valve in NOTION trial at 8 years, and that is where we are, banking on. And we believe that if not better, at least they will behave like a surgical bioprosthetic valve. And these are various trials which says the similar, story. Besides this valve durability, we had the apprehension, and now we are getting this apprehension mitigated with all these evidences. But there are many factors which needs to be taken care of, like how about the coronary access? A patient who is 66 years falling, with a intermediate or high risk for surgical aortic valve and low risk for transcatheter, you definitely go for transcatheter aortic valve. But what happens after 6 years if the patient has acute coronary syndrome? So these are data on coronary access following TAVI. So no way it is going to match the surgical aortic valve, and then we are going for a TAVI, coronary engagement and coronary procedures. These are something like normal patients we are going ahead. But in TAVI patient, this is, even though we have come a long way, newer platforms are there, but still the risk is there. So you see, even though diagnostic angiography is usually successful, unselective coronary engagement is more common with long stent valve frames, and even with short valve frames, sometimes it's a challenge. And we have seen the ReAccess study where self-expanding platforms behaved very difficult in coronary access. And here the commissural alignment, which we are looking at, that could reduce the risk, and the coronary engagement and coronary intervention, we feel that it should be a kind of a normal kind of work, but it's not like that. The main goal of this entire commissural alignment is not a perfect commissural alignment, but to avoid commissural misalignment. So we are never perfect with this, although we try to be on a safer side. And with this coronary access, we have to understand that if we deploy valves early, chances of coronary involvement can be there, and how to deal with that. We have to choose the valve platforms accordingly. Coming to new bundle branch blocks and pacemaker implantation, we are aware that these patients, severe aortic stenosis patients, many of these patients have got afterload mismatch. And many times we see on table, once you put a transcatheter valve, the heart function of the patient recovers. And many patients, there is a reverse remodeling happens in 3-4 months time, the heart function gains up. So 30% DF goes to 60%, sometimes instantly on lab, sometimes in 3 to 6 months. And this reverse remodeling is severely affected, especially midterm remodeling. Reverse remodeling is severely affected if there is a new bundle branch block or a pacemaker is implanted in these patients. And that is why 1 year all-cause mortality, heart failure hospitalization is high in new bundle branch block patients. And obviously these patients have a high permanent pacemaker implantation. So we are giving a problem to a patient after removing a previous problem of that patient. So that is something which we need to see and consider when we are choosing a device, lifetime device for a patient. And that is where we are doing, left CSP in all our transcatheter aortic valve patients. We have done till now 4 pacemakers in our post TAVI patients, and last 2 were CSP, and this kind of ECG we are giving. Probably they will not lead to heart dysfunction long term, and also should not be interfering with the reverse remodeling process. And the last word is small annulus. Small annulus is one area where a lot of long-term resurgery or re-intervention we expect, and that is one place also where self-expanding supraannular implantation can be a better choice. Among that, we have got multiple options now, not one, and we have to choose as and balance the risk of giving a higher effective orifice area. Also look at the coronary access and pacemaker implantation. So with these 3, we decide and choose our valve make. So with this all developments, there is also a development on surgical bioprosthetic front coming with Resilia bioprosthetic tissue, where the calcification is very less, and they expect a mean durability of 20 years. And probably with this all developments, this field is really getting a lot of crazy excitements. And hopefully the dry tissue technology, the development in improvement in TAVR valve leaflets technology, it's going to be a very, very exciting, interesting area in next 10 years. So summarizing, we expect 10 years for TAVI. Surgical aortic valve after TAVR is not an easy job. So we should not feel that once we have done TAVR, explantation and new surgical valve can be implanted after 5, 6, 7, 8 years. This is a very difficult job. In all surgical registry, it is being shown. Valve in valve is a good option, but we have to plan at least 20 years for a patient. So we have to choose the device well, considering the patient profile, the anatomy of the aortic valve, and the risk assessment. Thank you so much for the patient here.
Thank you, Dr. Dilip Kumar. There will be one question from Professor Montosh Paja, sir.
Dilip, excellent presentation. We observed, particularly when the cast overlap, chance of all the complications less, number 1. What is the reason? Number 1. Second question, if particularly the valve in valve, when putting, again, is that all complication is lower? Either fascicular block or paravalvular, everything lower. What is the reason? There are 2 questions.
So the first question I couldn't get, sir. What was the first question?
No. First question, that is, if there is some overlap alignment, if there is some overlap of the valve, that case is all the complications lower. That's the PCR they presented. They observed it, one of the study.
Yes, sir. So I think brilliant questions. One is comment. So once there is a commercial alignment, which we are ensured by most of the valve makers nowadays, and there you have to see how you go inside the hat marker and C-tabs and Medtronic and the knobs, different knobs and different platforms. We can assure at least non-commercial alignment is not there. We try to go towards commercial alignment, and the future coronary intervention becomes much favorable and results are better. Second is valve in valve platform. This valve is already there, surgical valve, and which is quite opposed to the valve, and that gives you most of the protection, and that gives you, and the measurements and everything is precise. You know about what valves was deployed, what measurement was that, and then you can pre-plan things in these situations, and that is why valve in valve is a little more controlled kind of intervention than going for a bad high-risk transcatheter valves.
Thank you, Dr. Kumar. Thank you, Mantosh Paja, sir. So we will conclude this session here and move on to the next session of live case transmission. Thank you. I call upon the chairpersons and the next session moderators to take the dais.
No, not like that. This is not ending over here. The one people is already here. Is the Amit Kumar Chaudhary. Hello. Okay. Okay. The session not end right here. So we have one more speaker right here. So I request all the honorable guests to be on stage once again. This is my humble request to all the.
Sorry, Dr. Amit Chaurasia, are you online?
So
Okay. He is on venue. Sorry.
So our next topic is conduction abnormalities after TAVR. So we are having Dr. Amit Chaurasia right here.
Presentation পরে
was already there. I think some connection over there.
It has to, it's mirroring.
No, it's okay, you did tell me that it. Okay. It's not mirrored. It should have come by now. There's some problem up there.
Shall we do the live and then live?
Can we go live? HL Center? Roshri,
You need
Hello?
to change your connector.
Suneep and Sojato,
Check করে নিচ্ছি।
the panelists, live case, Shantanu, Jainak, Jayanto Saha, Deepankar Mukherjee, Indrani Dev, Sanjeev Sengupta, Hakibidin Akhtar. So over to you, Sojato, please present your case. We are here.
Dr. Purua,
Yeah, hi. Hi.
who else is there in the lab? On the podium?
On the podium, we have another Barua, Dr. P.K. Hajra, Supradeep.
So one meeting from Kolkata Hatan Center. And we are a newborn baby in this city. My colleague, Dr. Sujata Chakraborty, is doing a case, which is a case of secondary vascular lesion. This patient had a cirrhotic coronary artery disease onset of angina on the background of diabetes. And in 2015, when this new TSRT master came, we put in left-handed artery. Yesterday, we had 3 sessions on how to precisely place is changed in oxygen. And we actually don't know see. So probably it was because Govinda was presenting and he suggested that do a image and try to come up with the like probably for better future. But anyway, in 2014, I did do it this way. I came one of the start in the POC, and now this patient has there was another stage in the ICOR. So let's see this angiogram. Please read the angiogram. What does it earlier? Okay, earlier there was a I show you the right system, but this patient has been taken for angioplasty of the circumflex, and it was paid 2 weeks back. So he had an enormous division MRI with high BNP troponin. We stabilized on SGLT2 inhibitor and then also creatinine is one. And this is the elite trial. So what we have done, can you show the lower side, please? So we try to do as much as possible trans-radial, but as the radial there. As this radial was being used recently, so we went trans on the light sheet. Could really and we need also the some reversal. Please focus on the areas. So again, the circumference could be innervated up to segment A only, because the protein go there, and you can you see the. If you see the.
Can you make the IBUS bigger and the angio smaller? IBUS on the main screen, yeah. Yes, beautiful. A nodule there.
There's a nodule.
Get back. So I think this.
So what's your plan?
It's such a classified vessel. I'm not, let's you all humans agree that the ability is a speed. You all agree?
Yes.
Yes, fine.
There's a calcified nodule also that.
Yeah, nodule is there.
Yes.
So are you using Cangrelor or routine antiplatelet? Well, Oak already has undergone PCI on other side.
Now we can debate, we have to do another case actually, like for, so this is a 2.5 millimeter balloon. Again.
So make the angio bigger and IVUS smaller. Yes.
There's still something to be done. So they still maintain the further we like say. So a lot of calcium is there, the balloon still hanging on to, or just open.
It's not open nicely. Some still some indentations.
So I think I have a following 2.5 K. So
Yes, cutting balloon. Or you can use nowadays the very high pressure balloon, ultra high pressure balloon to prepare the crack the calcium nodule. So what do you think?
Apart from the balloons, you have any other strategies for this modification of the calcified nodule?
If you had the luxury of IVL would have been the best. What do you think of?
and you yes.
Any comment from Sojato?
So I think try to point out I think the point that I think that's the point where we are obstructed and the standing. So that's my total also tolerance. According to the regulation, because it's in the group. So that's where we are 3,000. So we have to do something to modify the plan. We were getting of maintenance. So one of the things that we are so we are getting around 180 to see. Responsible and as possible.
Because just opposite to the calcified nodule, the segments seems to be healthy. So whatever the balloon expand, that will always go to the eccentrically. So I think we need to have some other devices like IVL.
Balloon is not a very good choice for a calcium nodule, and it is better to have some kind of atherectomy device for this. And balloon is a good choice for concentric calcium.
Agree, like orbital or rota or IVL. But all calcium nodule do not behave in similar fashions. You may see nodule, but it could be easily breakable. I mean, they may see a nodule which has got a flat top. And Jayanto, please come. Flat top, and it's very difficult, not of like a Himalayan top, but still it is very difficult to treat those kind of nodules. So all depends on the thickness of the, yeah. No, it's not yet nicely open. There's some half dog boning. It's not a complete dog boning, but there's half dog boning. So this is another 2.5 going for high pressure. So there is visible calcium. Visible calcium is seen only in 30% of angiogram. And then you have to take help of IVUS. So you may not see anything on angiographic, but can be a lot of features of adverse calcium like calcium nodule. So imaging is important nowadays. Imaging is a must, almost all cases.
doesn't give the full story. But when this is, we are not able to kind of linear element which is still present, but still it is so badly behaving in taking out the devices. But I am happy that I am able to guide them in the support role. This is an angle not climber.
So nowadays we have bioadapters in calcified lesions. So what are the bioadapters? Bioadapters do not have any links. And bioadapters 3 years data has been presented in PCR. So bioadapters are like they are glued with the polymer, the links, and once the polymer is absorbed, the stent becomes larger and larger and larger with time, and they can take care of the residual calcium behind the stents.
So just Dr. Panya here, at this moment, because still not proper expansion in spite of the NC balloon, this is the right moment to you can use the Volverin. I think Volverin easily can negotiate. It is possible to cut the
So
calcium.
Dr. Panja is suggesting a cutting balloon here at this moment.
I think 2.5 into 10 will be ideal in this lesson.
2.5 into 10 millimeter
Wolverine.
cutting balloon Wolverine will make it further weaker. Yeah, Wolverine.
So this is the concept of the second part. 0.5 is moving part. Now this is real body of calcium. So if you see categorically that are you okay? So yes. So if you see categorically that we have innervated the vessel as much as possible. And nowhere there is a 360 degree calcium or something. But the nodule which is hiding behind definitely is a matter of body. Now we have to think about the cost involved in those intravascular lithotripsy. Let's go simple and old age fashion, and I take opinion of our teacher, Dr. Maya, and we are taking a Wolverine and let's see it today. So you know you can go to the other lab or we come back.
Yeah. Keep working on this, and we can go to Dr. Chorasi lecture is here. Amit is here? No. Please call Amit here.
You can inflate the cutting balloon at the even at the 14 or 16 atmospheric pressure. There will be no problem.
Dr. Jaman is here. Please call Dr. Jaman. He wants to deliver his lecture. What type of coronary wire you are using? Is it Sign Blue or BMW?
Not for us.
I didn't get you. You said Sign Blue?
Sign Blue.
Okay. Yeah, it's nicely behaving. Yeah, not only rotations, slide up and down so that it cuts at different.
So again, I can just read from Pova and refer safety. I think that will the maximum thing which can happen. So still there are something which needs to be done. Let's see. This is the last engagement.
Okay, so if you're asked to choose type of stents in unyielding coronary artery, would you go for a stent which has got high radial strength? That means thicker stent, vis-a-vis a thinner stent for lesser metal in the coronary. You can go up to 18. Jaman, are you ready? Yeah, his lecture is ready. So you can deliver his lecture in between, then we'll come back. Yeah. So you keep on working on your case. We'll come back to you. Yeah.
Podium size.
Thank you. And I must thanks to Dr. P.K. Hazra and the organizers for giving me the opportunity to be here. And this is a Bangladesh session. I'm Professor S. Mustafa Jaman, President of Bangladesh Cardiovascular Research Foundation and Professor of Bangabandhu Sheikh Mujib Medical University. Nice to meet you all. And though I used to come Calcutta many times, but this is actually the second home. So I always enjoy just like my home country. So I will present how to deal with non-true late main bifurcation. And every day we're facing this type of problem and in our cath lab. So this is very important, true and non-true bifurcation, though still a gray zone in bifurcation. And still now we're watching the live case also and a lot of presentation by your young cardiologist in the morning I've seen. And this is the area is we call the different animal. So a lot of factors associated with the late main, osteal LAD and osteal LCX. So this is a gray zone and more prone to atherosclerosis, some area you already have seen. And so it's very difficult and case to case variation when we treat in our cath lab every patient. So a lot of evaluation, you can see the guidelines. So ultimately ESC guidelines and SCCHA guideline is SCA guideline. From 2005 to gradually it is increasing and ultimately ESC guideline class 1 indication very late and CINTA score is less than 22. PCI is recommended patients with late main disease. And in 2021 also SCC and HA guideline also class 1 indication, but before that it was not the class 1 indication. And what is true and non-true? And we have the Medina classification. I must thanks to Alfonso Medina. And you will see the 111, 110, 101, 011, 100, 010, and 001. All the 7 to bifurcation lesion and proximal distal lesion and with side branch we always face. And the 3 lesion actually true among the 7 types, 011, 111, and 101. So you always, most of the time, true bifurcation lesion we are saying, but sometimes non-true bifurcation lesion we have faced, and how to deal this bifurcation lesion. I will share our knowledge, but I know a lot of senior cardiologists in cardiology here will share our knowledge, especially kissing balloon inflation. Is it mandatory or not? Where we'll do kissing balloon inflation or not? And a lot of issue we'll discuss in the short time. The rest are non-true bifurcation. Already I mentioned that other than 3, all are non-true. So this is also creates problem when we treat this patient. You'll see the non-true. I'll take time because all the CD will not come at a time. So all are non-true. So some we will see the CT also LED total occlusion from ostium of the disease. So with how we'll deal this patient, you will see the patient only late main disease, but the LED and LCX also good. And here also you'll see the only ostial LED disease. So here also only LCX. So lot of things that we can share. So real world scenario of non-true late main bifurcation, some practical issues. Again, I mentioned that is so in general, whatever true or non-true, provisional philosophy is the call of the present time. But always we can't say that one stent is best, better than two stent. So sometimes 2 stent needed, sometimes 1 stent needed. So we'll see the RCT among the 2 stent and the 1 stent, and the provisional stenting versus systematic double stenting in late main bifurcation lesion, and the MACE, all-cause mortality, CV mortality, MI, stent thrombosis, target lesion, revascularization. There's a comparison. You'll see the 19 here, systematic double stenting and provisional stenting 16% MACE. All-cause mortality is 9.5%, provisional 9.3, CV mortality 4.6, 5.8, MI 8.3, this is 8.6, and stent thrombosis 2.3% and 2.8%. Here is some greater in comparison, target lesion revascularization 11.1% versus 7.7% in provisional stenting. So very important slide also this is, and you'll see that that angle very important. One is the angle between late main to LCX, angle between LED to LCX, and angle LED to late main. All the angle is very important when we decide which strategy we should follow. And the assigned side branch, this is very important because there's maybe disparity of the LED size and LCX size also. And so there's maybe changes of the proximal and distal segment also. So it is very, very important. So EBC 16, they mentioned the assigned side branch, that means changes of the distal vessel and changes of the side branch. This is depends on anatomical and origin of the distal vessel and side vessel also. And when we this may called assigned side branch. And I'll not go elaborately because the live session is going on. So we'll discuss live session also. So IVAS is very important because the strategical follow-up and which strategy and how to manage this patient. IVAS is very, very important in here. And though it's not the class 1 indication, only 40% we can do IVAS use. And you'll see the IVAS, how can help us in taking decision in this scenario. Let's see 001, 100, 110, 01, 101 cases. The scenario 45 years and height of the angina, and some scenario late diabetes mellitus, dyslipidemia, smoker, ECG, you will see echo, everything. So CAG findings was here. You will see the 100 and is it CABG or PCI? I don't know how many actually cardiologists here they will say CABG or PCI, and what should be the strategy. So I'm going to next slide. So thus IVAS assessment is mandatory, and because maybe it's simple, but not always simple. Always it is very important to take the decision, single stent, and when you go crossover stenting, let me into LED, that may be a chance of osteal stone actually create problem on the osteal L6 also. So may I go, let me into L6. So it is very important. So that may IVAS may help also in this take decision. So we will see the L6 to LED where both wires should be both vessels should be wired. Then we'll take the decision. This is the thumb rule. Which one will be the assigned side branch? This is very important. In EBC 16 they told me, and this is a big dilemma. Maybe let me into LED or let me into L6. Can you raise your hand? Which let me into LED? How many? Let me LED, and let me into other, let me into LCX. So there we will see that the diameter is LED and the L6 is a little different. IVAS will help us, and then both vessels should be wired, and IVAS should actually L6 to LED is 2.75 and the LCX is 3.5. So let me into LCX because diameter, again, you mentioned that the disparity of the diameter of the LCX LED and the changes of the distal vessel and side branch, and this is called assigned side branch in 16 EBC line. So it's the biggest question now, final KBI or not to KISS. So again, maybe a dilemma also, somebody told kissing balloon inflation needed or not. And if actually eventual kissing prevents fenestrous restenosis if we do KBI, and so somebody will take the will do the kissing balloon inflation, but not necessarily somebody, but because the Nordic 3 did not suffer the routine KBI both in true and non-true bifurcation, and Corvis 3 similar outcomes. Even EBC main mandated KBI even in provisional standing by protocol. So it is also big dilemma also. Without KBI, you will see this also good result also. So let's see a case of 0-1-0 Lettman bifurcation lesion. This create problem in the cath lab. How will overcome this scenario? Especially we'll do the only LED, but all distal Lettman may be involved. And when I put the stent Lettman to LED, so lot of question maybe what should be the, so this how will overcome plan again. So a real world scenario simple, but not a simple again I mentioned that. So I was again help us to take the decision. So crossover stenting prevention study is the plan, and how will overcome this situation. And again, I was help us. I will take little time because a live session is going on. So you will see the Lettman has a mild plaque extension, LED diameter looks 3 to 3.5 millimeter, and LCX and ramus osteum are disease free. So you'll see Lettman to LED and pot also. So now the trickiest question for this case is that SBs, even though TIMI 3 flow was there, and KBI again important to open the jail stars in the SB. So this question is going on in the cath lab every time we are facing this type of problem. So report also done, post-port IVAS also done, and final picture. Controversy is 0-1-0, and strategy should be maybe different. Operators discretion and hard team may be sometimes needed, and true carina shifting, plaque shifting, to be or not to be KBI. Again, this dilemma. Let's see the another 010 Lettman bifurcation, this time with CTO LED. Already I have shown the first picture, this CD, and 010 Lettman bifurcation with CTO LED from this is ostium. The senior is 65 years, male, diabetes mellitus, hypertension, prior MI, anterior 2 years back with unstable angina, LV of 50%. You'll see. Where is the LED ostium? CTO proximal cap is nowhere, and dual injection also given. So this is create another dilemma, and two challenges: open the CTO and handle the 010 Lettman lesion. I was again guided us. So could you open the CTO, what to do for 010 Lettman lesion? I was have no question about the role, and only ostial LED stenting without involving Lettman disease possible or not. Again, angle is important because again, first the previous slide already I've discussed in this regard. We'll see the final peak. Are you happy with the scenario? So yes, what about the most controversial 001 lesion in Lettman bifurcation? Non-diabetic, normotensive, young, 9 years old female with non-STMI. Angiographically, Lettman looks okay, though mild plaques are there. Basically, this create a lot of problem in the cath lab. How should we overcome? On the morning, I've seen the previous one presenter actually presented only ostial LCX. This population, somebody told the only DCB. Somebody tell just forget about the lesion, about the ischemia and risk stratification. A lot of things, clinical judgment also. So again, if you see the 70 to 80% stenosis in the ostial LCX, and may have a higher diameter discrepancy with a Lettman with the other two vessel. Angiographic angulation is very important. Ostial miss or floating. So there's a lot of question and a lot of answer also, and a lot of plan also you will see. So apparently 001 lesion, ostial LCX lesion is a deep pain for an interventional cardiologist. I'm telling this repeatedly. So I was again. So vessel bed preparation, important. We'll see. Don't bother for KB or report as IVAS looks good. And this is hard talk is that is if L6 were a smaller caliber with acute angle with LADU, where ostial positioning of a stent is not feasible, what would be the management for that pathogenic 001 Lettman bifurcation lesion? Some answers are evolving, and you will see the contemporary management of isolated ostial sideburns disease and evidence-based approach to Medina 001 bifurcations, and treatment of corona bifurcation lesions. Part 1, implanting is the first stent in the provisional pathway. The 16th expert consensus document in European by EBC. Obviously not yet to be class 1, and 001, especially for non-interventional management. Again, I mentioned maybe the interventional management, balloon angioplasty, and leave nothing behind. So flush ostial technique, bailout to stent technique, inverted provisional technique, a lot of decision may be taken by the interventional cardiologist in the cath lab, and take a message, non-true and true Lettman bifurcation lesion to be judged by the IVAS, POT and KBI to do when SB looks suspicious. Future of DCB in bifurcation lesions needs more data. And though I mentioned case-to-case variation may be needed, and non-true Lettman bifurcation may turn into bailout to stent study, or we may remain well with GDMT. Thank you all for question sharing.
Super presentations, and really a good basket of good cases, and a very simple way to present a very difficult situation, and Lepman, the fear we had during our student days is not there anymore. And you have given a lot of confidence in my mind and others' mind that it can be done safely, simply, and imaging should be the part of Lepman. Ritu, any comments?
Yeah, all the cases are very educational and highlighting all the points regarding the tricks and the tips and the techniques and the usefulness of the IVAS. And I just want to my curiosity. So in your experience, so is there any disparity that you see between the Finet's hypothesis, how the size of the left main according to the sizes of the LCX and the LED and the IVAS estimation and sizing?
Yes, earlier I was maybe sometimes OCT maybe somebody can use also, and in cath lab every time actually we have all size of stand, all the actual armaments sometimes actually not get. So every day we are facing this problem. I think every cardiologist and your question also like this. So we always overcome the difficulties, challenge. So ultimately, the judgment by the interventional cardiologist actually that is better. And again, I mentioned in the cath lab maybe sometimes so you should take the leadership when you do, and you must be confident to do this type of challenge. And ultimately, it may be go for you and may not be sometimes. So this is some challenging cases. But a lot of cases we have also sometimes we not actually overcome like this. And the position of the stent very important, because if little when you do the only ostial in situ cases, only ostial LED, and if it may come to in the late main also, then that may cause also problem of the LCX also. So a lot of problem may be happen. But ultimate, the result was very good in this scenario. And thank you again for giving me the opportunity. I must thank the PK Hazra. And I'm coming from Bangladesh, and this is a good relation, Bangladesh and Calcutta. Again,
Thank you. Come again.
Long live.
Come again. Come with Illis fish for me. Hilsa. Bag of Hilsa for me next time. Thank you. Stay with us. And now we go to Dr. Amit Chaurasia. Amit is the first one to do TAVR in Eastern India, not me. Actually, he was the first proctor for TAVR. And then one day we did 2 TAVR, and there's the first time in this part of the country. One was TAVR in Savar, one was the native valve. So it gives me immense pleasure to be here with him. And Amit, please.
So now we are having Dr. Amit Chaurasia on stage, and the next topic is conduction abnormalities after TAVR. Now it's over to you, sir.
Thank you, sir, for reminding that those 2 cases, and those 2 cases were not so easy cases, but we ended up having a good result. I still remember those 2 cases. One of them was having severe renal dysfunction as well, if we remember. So conduction abnormalities after TAVI, and if you remember the last Sunday, Dr. Dilip would have delivered this talk in a different way. He would have told like what are the patients who develop conduction abnormality, and if I have to tell you, then those are patients with RBBB, those patients with severe calcification on the annulus, those patients with calcification in the NCC, RCC region running into the LVOT. These are the patients who go on to develop conduction abnormality, if you see from the anatomical point of view. But if you see from the procedural point of view, then the depth of implantation matters. But I'm going to talk on a slightly different I'm going to present this topic in a slightly different way, because we need to understand like how things have changed in the history of TAVR. So this was the first successful TAVI patient, and we all know Dr. Crivier, who did this case, extremely high risk patient, but turned out to be a successful TAVI, which after this, there was a series of first in human trials, and then after those trials, we went on to do the randomized control trial. The partner trial saved the future, in which it clearly showed that in a prohibitive risk patient, you could get a good result of around 25% mortality only. Now, mind you, these are prohibitive risk patient, and you could extend the lifespan of the patient by 33 months. Extremely gratifying result. And in a high risk patient, TAVR was non-inferior to SAVR in this subset. The co-valve extreme risk trial also showed the similar result, and TAVR was better than SAVR in this. As we move on, then we moved on to the CERT TAVI and the partner 2 trial, which were intermediate trials. So now, if we see both the high risk and the intermediate risk, what are we looking at? We are just looking at the all-cause mortality, the stroke rate, and major mortality. What is missing in this? What we are missing is the point that I'm discussing at present. We are missing the conduction abnormality in these patients. So if I have to tell, the goal of this trial was not to look at conduction abnormality. The goal was to establish the therapy. So establishing the therapy means that you are going to have a successful implantation of the valve with less gradient, less PVL, and that will define the success, which means that the mortality is going to be less and the stroke is going to be less. And the same thing was followed up in the intermediate trial as well, because here the goal is to establish the therapy in intermediate risk patient. We are not looking to look at the secondary outcomes, which is a conduction defect also. So again, if you see the CERT TAVI, what we are looking at again is just the primary outcome of all-cause mortality, disabling stroke, and nothing else. No conduction defect has been looked into these trials. So ultimately, the goal of the trial was fulfilled, that it went into guidelines, and TAVR became a class 1 guideline in a prohibitive risk patient. In a high-risk patient, you could go for TAVR or SAVR. In a low-risk patient, still SAVR was favored, and intermediate risk 2A or 2B, TAVR or SAVR, you discuss with the patient. Even the ESC guidelines changed after that. Subsequently, we moved on. So as we move on from prohibitive risk, high risk, intermediate risk, now we wanted to try TAVI in low-risk patient. And all the credit goes to Lars Sonnegrand, who actually did the first low-risk trial way back in 2011. And he showed that in low-risk trial, you could have a good result. So that was the point. Okay, we can move on to a low-risk trial. And again, what we are looking at is the primary outcome of all-cause mortality, death, and disabling stroke, and nothing else. Same thing with partner 3 trial. We have not still looked at the conduction defect. And that is the reason why we never thought about pacemaker. So if I have to tell that we finally fulfilled our goal with these trials, we got the guidelines changed, and we said that, okay, 80 years and above, TAVR, no SAVR at all. 65 to 80 years, if you have a life expectancy of 20 years, discuss down with the patient, sit down with the patient, discuss, and go with the patient, whatever he says. Less than 65, SAVR still holds true. Now, if I have to say the goals, until then, the goals was prohibitive high risk, intermediate valvular leak, vascular bleeding complication, stroke, and then minimalistic TAVR. Now we have moved on to a low risk TAVR, and our goals have changed now suddenly. We are looking at durability, we are looking at pacemaker rate, we are looking at leaflet thrombosis, we are looking at bicuspid aortic valve and its outcome, we are looking at valve-in-valve TAVR and minimalistic TAVR as well. Now the goal keeps on changing over a period of time. So when we have come down to see that, okay, if a patient gets a pacemaker, the mortality increases, then everything changes. Now we want to look at mortality and the pacemaker, and it was clearly seen from all these trials that if a patient gets a pacemaker, the mortality also increases over a period of time. It's not only the mortality that increases, but hospitalization also increases. So we went back and we started analyzing what is happening in these patients in regard to pacemaker rate. And we saw that the self-expanding valves have a higher rate of pacemaker than the balloon expandable valve. And then we started looking at why is this happening? And if you see this one, then you will come to see that when we look at the annulus, then we found that, okay, NCC and LCC, okay, there is a conduction system that runs over there. And of course, apart from all those factors, the anatomical factors, if you're going to go too deep, implant the valve too deep, maybe you will compress upon the conduction system and you'll get the conduction abnormality in these patients. So way back in 2014, they did an analysis and then they found that, okay, if the depth of implantation is more, you get either a pacemaker or a left bundle branch block. But what was the cutoff point? The cutoff point for left bundle branch was 8.81, and for a pacemaker, it was 8.9. Look at the depth that they found in 2014, 8.9. And today we talk about the depth putting the valve at 3 millimeter. So there is a lot of discrepancy you will find in these things. Slowly, over a period of time, when the valve improved, the self-expandable, also the pacemaker rate came down as we started implanting the valve at the right position. That is, we were able to control the depth because we were able to recapture these valves. And so we were able to put this valve at 3 to 5 millimeter, and the pacemaker rate came down from 35% to 22.3%. And what made the difference? The difference was made by cuspal overlap technique that Hemal Gada has invented. And what I say actually is like, it's just a standardization of all the technique. We made everything standardized so that everyone follows a particular way of implanting this valve, and you can control the depth, because in a cuspal overlap technique, what you are doing is you are forwarding the LVOT, as a result of which you know how deep exactly to go and place the valve. And the S curve, of course, helps us to find out the exact angle at which you are going to implant the valve, particularly in the cuspal overlap technique. And with this, we are able to control the depth at 3 to 5 millimeter. So with the advent of cuspal overlap, we saw that the pacemaker rate suddenly decreased. And you will if I have to say, Hemal Gada pacemaker rate with the self-expandable valve is 1.9%. If you see Michael, his pacemaker rate is 4.9%, extremely low. It all depends upon how many cases you have done and what your understanding is regarding the implantation of the valve. And this makes the difference. Now, let me just show you this data. What about the surgical valve implantation? What is the actual pacemaker rate in that? So if you see over here in a surgical aortic valve implantation, at the end of 1 year, you have a pacemaker rate of 6.6%. And we are talking in the pacemaker rate in a TAVI as 3 to 8% these days. So the question here is like, can we bring down the pacemaker rate any further? Because we have already come to the rate of pacemaker similar to a surgical valve replacement. I don't think that we are going to go any further down. So if I have to tell what is the exact depth at which you need to implant the valve, I would say that 3 millimeter is the best depth. Even if you go to 3 to 5 millimeter, you may avoid a pacemaker implantation, because that 2014 paper, which I showed you, clearly showed that 8 millimeter is the sweet cutoff point, where you may not get even a LBBB or a, or a pacemaker at all. But keeping all those things in mind, I think 3 millimeter is the sweet point where we should decide. Thank you so much. I hope I was able to put my point forward. Any questions?
Dr. Amit, it was brilliant presentations. And important is that the the location where the implanting the valve, and it is also nice to see that over the time, the rate of the pacemaker implantation coming down with self-expanding stand also. So any questions from the house?
So either the audience have understood. Or
I just want to know, to highlight that what are the pre-existing ECG evidences that can detect that
Yes.
this patient might require pacemaker implantation?
So all trifascicular block, you may expect a pacemaker. If a patient has a RBBB, when you implant the valve, the patient is going to develop a LBBB. And these are the patients who are going to have high risk for a pacemaker. If you have a LBBB, first degree AV block, you can expect to some extent that this patient may go on to have a pacemaker. Atrial fibrillation, I say that it doesn't matter at all. If you go to anatomical factors, as I told, the amount of calcium, the calcium running between the LCC and the LCC and the RCC, the amount of thickness of that calcium, all these things matters. So when you are counseling the patient, rule of thumb, high calcium, you tell the patient, okay, he may have a pacemaker. RBB, you give directly like, okay, he may have a pacemaker. You have a trifascicular block, you tell them he may go on to have a pacemaker. One notion I have seen, like I have gone to various labs and I have seen that people tend to think that if you are doing a valve in a valve, you may have a pacemaker. It's not that way. When you are doing a valve in a valve, the valve frames does not allow the TAVI valve to touch the LVOT. So these are the patients where you may not have a pacemaker despite anything. So you need to understand the anatomy well to answer these questions.
I know, reducing the depth to less than 3, would it not increase the chance of dislodgement of the device?
So that's a very, very good question. And I have always been telling that no need to implant a valve at 0, 1 position. 3 is the best position. The reason is if you implant a valve at 3 to 5 millimeter, even in a low risk, with a self-expandable valve, even accessing the coronary is going to be easier than if you implant higher. The reason is you are forming the neo-LVOT of the valve above the coronaries if you are going above. But if you are going below, the neo-LVOT is going to go below the coronaries. So, accessing the coronaries with a guide is going to be much easier. So if you are not going to have any pacemaker at 3 millimeter or 5 millimeter, why do you want to go above that? There is no point in going above that. Hemal Gada puts at 1 or 2 millimeter, but he is more experienced operator and he knows exactly where he's putting it. His lab, everybody knows how to access the coronaries. We are just learning about it. So I always say that go to 3 millimeter, just put it and feel happy about it. That's the point.
Stay back for your second lecture. You can join here. So let's go back to Sunip's center, Heart and Lung Center. This is the first transmission from my friend, my batchmate. Congratulations for the center. I mean, this is one of the state-of-the-art center in eastern part of our city. And me, Subro, Sunip, Urunangshu, Soumitra Rai, Dr. Pandey, all cardiologists from the same batch, Amit. So Sunip, can you hear us? Sunip, yeah. Sunip? Rejoin. Yes, loud and clear. Yep.
this is what for heavily and next. And now we are almost cured. So it's good actually. We have developed the skin. Physical feeling, in one step in the outer, good back.
You have stented all the way to the ostium of the left main almost.
You can see that the ostium is still, but the maximum calcium where it was, that's very nice. So the greater reduction all nice. So what we have done, we have taken a 3 millimeter HCl, we did post-dilatation after this. And now we have taken a 4.5 balloon for what we are going to have a PC balloon, AAT and LCX. If we think that it's 5 millimeters, so 0.65 into T1 if we calculate, so we take 3.5 in AAT. And 3 millimeter balloon in circumference to APC, followed by the final part. We may be bit unhappy about the residual in the LCS ostium, but I think yes.
Right. So you have to show us the IVUS now. This is time for the IVUS. Yeah.
Our technician, Victoria, sister, Sarada, the most youngest sister in the captain, I must say, and then Mr. Reddy, who is really from Taliban, but now he's there for the
Right. So all the best for your new venture, and I wish the God is with you, and my wholehearted best wishes always there with you for your future success. And I will leave you there, and really very thankful to your participations, contributions, and your presence and guiding us as organizing secretary of CSI West Bengal chapter. Now we'll go to the next session, Siddhartha Mani, if you're here, but we'll finish Dr. Amit's lecture. Then we'll take up the next session that is on zero contrast PCI by Dr. Mani. Amit.
So I was supposed to deliver this talk in the evening, but since we already analyzed we analyzed a piece of data in one way. Now I'm going to analyze the same set of data in a different way, because I'm not going to talk about conduction system more in this talk, but I'll be talking about the low risk TAVR, when and why. So again, the same first patient, I'll just skip that. The partner trial, we all know that in the partner trial, extreme risk patient, the average age of the patient was around 84 years. And of course, if you see 84 years, having a 33 months of improvement of life in patients where nothing was working out, with a good quality of life, that's excellent. Again, what we analyzed here was death from any cause, hospitalization, no stroke or stroke, and all those things. But mind it, here it was a prohibitive risk patient. We moved down to a 2-year follow-up, and with a good result, we saw that partner both 1A and 1B had a good result in comparison to surgery. Either it was equivalent to surgery or it was better than surgery. We then saw that, okay, another platform of valve, that is a self-expandable valve, was doing as good as a balloon expandable valve, and this added confidence to the therapy. We also saw that the effective orifice area and the gradient were lower with the TAVI valve than in comparison with the surgical valves. And the 3-year follow-up was extremely encouraging, and that led to the intermediate trials. In the intermediate trials, we showed that the TAVI valve was as good as the surgical valve. But again, what was the age group of the patient? The age group of the patient was again 82 in these patients. We are talking about intermediate risk, where we talk about the STS score being as 4 to 6%, and still the age group is 83. Now, if you look at a lot of patients in this intermediate group and the high risk group, they are 83 years. Now, if I have to tell whether the valve will outlive the patient or the natural history of the patient is going to outlive the patient, of course, we all know that natural history is going to outlive the valve. That is, the patient is going to die of the natural history after the valve implantation rather than degeneration of the valve. So it is more natural to have 25% mortality or a 12% mortality or a 6% mortality in these patients. But we are talking about intermediate risk, and we want to have a mortality less than at least 6% in these patients. And that is what the Partner 2 trial and the SORTAVI trial showed to us. Guidelines changed, as I told in the previous presentation. We moved down to low risk trial, and when we moved down to low risk trial, we knew that we cannot have a large number of patients in this trial. So what we did is we used a Bayesian analysis, wherein we are able to predict the same outcome with a low number of patients at 2 years, 5 years, very confidently in comparison to surgery. And in the low risk trial, we could see that TAVR was better than surgery. Now, we should also look at what is the difference between the intermediate and the low risk trial in regard to a self-expandable and a balloon expandable valve. And in both intermediate and the low risk trial, the self-expandable valve, if you see, did better. In a sense, if I have to tell that at the end of 2 years, in an intermediate risk class, in a balloon expandable valve, the SAVR patient had started doing better than the TAVR patient. Here, in both the class, it was TAVR valve. But if you go into a low risk patient, you will see that both balloon expandable valve and the self-expandable valve had done equally good in this subset of patients. Now, if you see, we changed the guidelines completely. And now a TAVR is a class 1 for 80 years, more than 80 years. For 65 to 80, you may discuss with the patient and all those. So if I have to tell what was the difference in the low risk patient, why a balloon expandable valve came up so well in comparison to a self-expandable valve, then you see in a low risk trial, in a balloon expandable, that is the Partner trial, it was all S3 that was implanted. But if you go towards the low risk Evolute trial, then you'll find that 1/3 of the patient were still the second generation valve. A quarter of these patients only received the present generation valves. And that could be one of the, one of the bias point in this trial as well. What you see in this trial, the rate of permanent pacemaker implantation, and you see in Partner trial, that is with the self-expandable valve, you have no difference with the surgical valve in the rate of pacemaker implantation. But if you see with the Evolute low risk trial, okay, there is a huge difference. Now, that we all know that a self-expandable valve, we slowly learned how to put a self-expandable valve at a higher position, at a 3 millimeter position, and we got the pacemaker rate down. And this is what this slide shows. This slide clearly shows that if this is the center of Hemangada, where the pacemaker rate was just 1.9%. This is somewhere like Michael Radian, where the pacemaker rate was 4.9%. This is another center in US. The operator volume does matter, and the operator understanding does matter with regard to the pacemaker. And now we have come down over a period of time after using the Kurzweil overlap technique. What we have come down in 2020 after the introduction of Kurzweil overlap technique, even with the self-expandable valve, the pacemaker rate is just 8.5%, extremely low. I do understand that with a balloon expandable, it is 6%, but still we can see that there is no difference. The low risk trial in the case of balloon expandable can clearly be seen that the gradient went slightly higher than the surgical arm, as well as the aortic valve area went slightly higher. Whereas in the evolute arm, the TAVI valve did better than the surgical valve. If you see this trial done by Rebecca, you will find this is the all-comer trial. She was the main core valve analysis person in both the trials. So she found that in SAPIEN, if you implant a SAPIEN, the effective orifice area is going to be 1.66%, 1.66 centimeter square with a mean gradient of 11. And if you implant a Evolute R, it is going to be something like 2.1 plus minus 7 if you go to the gradient. Rahimtullah clearly showed that there is something called as patient prosthesis mismatch, but his definition was quite different to the present day definition. And the present day definition comes from this trial. And this trial clearly shows that if you have a effective orifice area, indexed effective orifice area less than 0.65%, your gradient is much higher than if you have at 0.85. And that led to this definition of PPM, wherein you have no PPM if the indexed effective orifice area is more than 0.85. You have severe PPM if it is less than 0.65. In between, it is moderate. And this has been clearly shown that as the effective orifice area decreases, the gradient starts increasing. And with the increase of increasing patient prosthesis mismatch, the mortality also increases. Now, this beautiful trial clearly showed that in 60,000 patients, low risk, because it's 65 years old patients, surgical patients, if these patients have any degree of patient prosthesis mismatch, the mortality increases. And this is quite evident. This trial also showed that if you have patient prosthesis mismatch, your structural valve deterioration is going to be faster. Now, if you see the survival and the structural valve deterioration, then the only one factor matters, that is the patient prosthesis mismatch, where if a patient has a patient prosthesis mismatch, both the survival as well as the structural valve deterioration is higher. Now you can clearly see the patient prosthesis mismatch is almost increasing by two times in the case of surgical versus the Evolute platform, whereas the patient prosthesis mismatch is higher in the Patron trial, that is in the balloon expandable trial. And this, we all know the reason for this particular thing. Now, let me analyze this beautiful data. You have a younger patient. At a normal rate, even in a younger patient, if he doesn't do anything, that is, his aortic flow doesn't increase, the gradient is going to remain the same. And so the valve deterioration is not going to be high. And this is the case if the patient age is more than 80 years. But if you have a 65 years old patient, he's going to run around, his aortic flow is going to increase. And when his aortic flow is going to increase, his gradient is going to increase and mortality is going to increase. So if you want to give a valve to a younger patient, please keep in mind the patient prosthetic mismatch subset of these patients. Even we can see that the 6-minute walk test, at the end of 1 month, the TAVI valve had a better 6-minute walk test in comparison to the surgical valve. It is clearly seen. That may be because of the surgery. The patient has undergone surgery. He doesn't want to move around. But at 1 year, you will think that, okay, that should catch up if there is no difference. But we don't see that at 1 year. We don't see that at 2 years. We don't see even that at 2 years. So what has happened? Basically, TAVI has done better than the surgical valve in these regards. So do I mean to say that all low-risk patients should undergo TAVI? No, it is not that way. In those patients who selected group of patients who underwent that trial, those patients subset TAVI is better than surgery. But there were a whole subset of people who were excluded from the trials. The bicuspid aortic valve, patient with significant coronary artery disease, patient with unfavorable anatomy, associated other procedures, or patient who is suitable for mechanical valve, they all were excluded. So you cannot just say that I'm going to put a TAVI valve in this subset of people, because this subset of people have never been studied. So let me show some data. Bicuspid aortic valve, younger patients have a higher chance of bicuspid aortic valve. Earlier generation valve did worse than the present generation valve in regard to bicuspid aortic valve. But let me show you this this low risk bicuspid aortic valve trial, and you'll see that these patients did equivalent to surgery, and in these patients the result was similar to the tricuspid aortic valve. In fact, the paravalvular leak surprisingly was lower than the tricuspid aortic valve in this trial, and that surprised me quite a lot. What about people less than 65 years? If you see both the low risk trial, the age of the patient has still been, the mean age of the patient has been around 73, 74 years. We have not still looked into 65 years or lower than 65 years. In the partner trial, lower than 65, only 7% of the patient were less than 65 years. In the Evolute trial, 65 years, 6%, similar. Less than 60 years, 1.3%. But please don't go by that. These were the patients who were given TAVI valve due to certain conditions of the patient, not because that the patient had to get a TAVI valve. Now, if you see, what about the anatomy? Too large anatomy, you may not be able to put a TAVI valve. Now we have extra large valves, so we can do a TAVI in these patients. Too small anatomy, like 15, 16, are you going to put a TAVI valve? No, you are going to have a large amount of patient prostatic mismatch. It is better to give to the surgeon. The surgeons have learned over a period of time that you need to enlarge the valves. What may be the reason that in intermediate risk trial at 3 years, both the surgical risk and the surgery patient as well as the TAVI patient, the surgery patient started doing better? Because we made the surgeon feel that you need to learn how to enlarge the valve, and they learned that, and they started doing root enlargement, and that result showed in the intermediate trials. So too small anatomy, you can still give it to the surgeon and say that, okay, you can do a root enlargement and that will be better. Excessive alveolar calcification has been ruled out from all the low risk trials. So please don't consider that those subset of patient in TAVI group, because this subset of patient are going to have a higher pacemaker rate, higher paravalvular leak rate, and of course the mortality is going to be different in these patients. Now let's see the two trials. It was told that it is all comer trials, but see the amount of screen failure in both the cases. 1/3 of the patient had screen failure in partner 3 trial, and around 15% of the patient had a screen failure in the case of Evolute trial. It clearly shows that it was not an all-comer trial, but it was these patients were put to a particular committee, and the committee decided whether to take the patient or not. So it was a biased trial in comparison to surgery. It clearly shows that. What about syntax and coronary artery disease? If you see partner trial, clearly excluded syntax more than 32. Evolute, it was said that more than 22 should be excluded. What was the reality? In reality, in syntax score more than 7, hardly any patient had syntax score more than 7 in Evolute trial. That means we had extremely excluded all kind of coronary artery disease. We have not tested in coronary artery disease. So we should not think about giving these valves in a low risk patient with a coronary artery disease. The surgeons will say that, okay, our valve is going to last 10 years. But if you see what is the number at risk, you see 40 patient you started with, at the end of 10 years, you are analyzing only one patient, and you tell that our valve lasts for 10 years or 15 years. Even if you see at 15 years, what is the number at risk? Number at risk is extremely low. You started with 1,000 patient, known patient with a number at risk, 11 patients. These trials are extremely flawed trials to tell that the surgical valve is going to last 15 or 25 years, because you need to consider all the patients that were enrolled in that trial. You cannot say that at that point of time, only this much patient came, and I'm going to analyze only these data. We also know that certain surgical valves fail over a period of time, and trifecta is one which has shown degeneration even in 1 year time. So this kind of valves should be taken out of the trials. We have seen that the durability of the TAVR valve has lasted quite a bit, and 5 years data of all these trials are available. And these 5 years data have done better than surgery or equivalent to surgery. The NOTION trial is the a holy grail of durability trial in all the TAVI valves, and it has shown up to even now 10 years data is available. I'm just showing you up to 8 years data, and all cause mortality, SVD, everything was lower in the TAVR valve. But finally, when the NOTION trial 5-year was analyzed, it was seen that the pacemaker rate was higher in the TAVI group, and atrial fibrillation was higher in the surgical group. Surgical group atrial fibrillation has not changed over a period of time. NOTION trial started in 2011. By 2016, we saw that, okay, the pacemaker rate is higher, and we learned that how to bring that down. We have already learned how to get our pacemaker rate down, but the surgical atrial fibrillation rate has not changed over a period of time. PVL is the Achilles tendon of TAVR, but then again, with the advent of newer valves, PVL rate has come down extremely low. If you are going to give a TAVR valve to a patient, make sure that the PVL is less than mild, that is trace to mild, not more than mild, because you are going to increase the mortality in that patient over a period of time. As I told, over a period of time, the PVL rate has come down extremely low in TAVR group in comparison to the SAVR group. So to conclude, if you are going to give a TAVR to a low risk patient, consider the patient population that you are treating. You are treating a bicuspid, you are treating a heavily calcified. Slightly, you need to be cautious about it, because no trials has shown any kind of outcome in this. And we need to give a better trial to say that, okay, this valve population can be treated with a TAVR valve. Consider the anatomy, what you are dealing with. Alveotic calcification and bicuspid aortic valve. Please think about SAVR in this low risk patient. Consider patient prosthesis mismatch. If you have a very small annulus, please give it to the surgeon. They are going to do a better job by root enlargement. Of course, they also need to learn how to do a root enlargement, and then only they are going to improve their result as well. Consider the chance of pacemaker. As much as possible, try to come out of the lab without any kind of pacemaker in this subset of patient. Consider the chance of paravalvular leak. When you come out of the lab, you should have a patient with less than mild paravalvular leak on the table. And also consider, like, if this valve is going to fail, what am I going to do with the patient? Now, if you see the guidelines, it clearly says that the patient should have a minimum life expectancy of 1 year for TAVR. And if the patient has a life expectancy of more than 20 years, then you will have to sit down and discuss with the patient, because the TAVR valve is ultimately fail because it is a bioprosthetic valve. In the previous talk, it was told that the difference between bovine and pericardium, bovine pericardium and the porcine pericardium. Now, if you look at the bovine and porcine pericardium, the halt, that is the thickness, increase in thickness is more in bovine than in porcine pericardium. Now, if you look, most of the surgical valves are bovine pericardium. So the halt is going to be higher. The rate of thrombosis is going to be higher. The rate of valve degeneration is going to be higher in these patients. Now, if you ask, why haven't the companies changed those valves to a porcine valve then? After all these years, the reason is, if they are going to change the material, then they will have to go through all those FDA trials again. And doing that is going to be a huge task. Probably we need to see and find a sweet point where we need to decide that TAVR or SAVR is going to be a better solution for this patient. Thank you so much.
Thank you, Amit. Beautiful. And you know that what we are looking for in future, the longevity and durability, lower pacemaker rate has already been achieved. So last frontier will be the longevity of the valves. We have Resilium, we have on our tissue calcification management on the surgical valve implanted on TAVR. So philosophically speaking, the younger patients, they degenerate faster than the older patients. So younger patients, they have a higher blood volume, higher heart rate, higher metabolic demand, they do exercise, that they are tachycardics. So would you consider like no valve is biomimetic valve, though there are biomimetic valves has been introduced 2023 in PCR, and we have to wait for that. And you know, if you use beta blocker, if you keep their heart rate at lower level, or the paced beats, though the pacemaker post-TAVR, they don't do well. But if you go into the physiology, that patients who has got a less stroke volume, less heart rate, older patient, their longevity of the valve is higher. So would you consider a routine use of beta blocker keeping their heart rate at lower level post-TAVR to increase the longevity?
So beta blocker and heart rate, of course, you'll bring down the heart rate in these lower age group patients, but then this lower age group patient gets a valve for quality of life. These patients want to go for hiking, they want to go for cycling, they want to play basketball. And in any way you give beta blocker or not, their heart rate is going to go high, their aortic valve flow is going to go high. So in whatever you do, the valve deterioration is going to happen. And as Anup had told, that native valve regenerates, but these valves are not going to regenerate. These valve once degenerates, they are going to degenerate. Surprisingly, if I have to tell, in a low risk trial, what I was expecting from an intermediate risk trial, a balloon expandable valve should have done better than the self-expandable valve. But here we found that there was no difference at all. And probably the reason is because the balloon expandable subset, they understood that you need not put a smaller valve. You should always go for a larger valve. Now, there have been enough trials that if you're going to put a 25 and above valve, you put a balloon expandable or you put a self-expandable valve, nothing makes the difference. It's only the subset of people who are less than 25 that difference is there. Otherwise, there is no difference at all.
Subra, yeah.
Yeah, thanks for the wonderful talk. See, if there is a potential for patient prosthesis mismatch in a younger patient, say 65, 67, then would you normally prefer a self-expanding valve? I mean, that's what I thought I understood from your talk, than balloon expanding.
So a lot of there is a lot of misconcept about coronary access with the two different kind of valves, and coronary access is the only thing that a balloon expandable people will be telling that it is easier for a coronary access, but it's not that way. Now, even if you take the valve frame in a what is called as a balloon expandable valve, if it goes above the coronary, it will depend upon if the strut is coming directly in front of the coronary or not. And the same thing applies for the self-expandable valve. So if you have put a self-expandable valve at 3 millimeter or 3 to 5 millimeter, the difference is not going to be there. So if you want to give a better hemodynamics to the patient, of course, you go with the self-expandable valve. And like, if you ask me, everything is in favor of a self-expandable valve if the size is less than 25.
Except the coronary access in certain cases,
Eh,
perhaps, yeah.
Yeah.
With the coronary
Yeah.
height is short.
If the valve frame goes below, then it is just like a surgical valve. But I can tell you, in many of these patients, usually the strut will reach slightly there, but there is no skirt over there, so the flow is maintained. The strut will be there, but there is no skirt, so flow maintains. But if that strut is right in front of the coronary, the only way to access the coronary is you put the guide, float the guide, wire it, you put a guide liner inside and make the guide liner turn this way. I have done once or twice, and I was like, this is the only way you can get over there. Otherwise, it's not possible at all. So that is why I tell, like, the present day residents should know how to access these coronaries, because the number of cases are definitely going to go up. And believe me, in my OPD nowadays, patients 40 years, they come down and they say, we don't want surgery. I just look at and I say, I can't say. In fact, last patient, 62 years, very mobile. He says that no matter whatever you do, I'm not going to have a surgery. He has his own subset of reason. And you cannot say that I don't want to do anything for you, because he's going to die anyway. So better you do one and finish up. That's it.
Thank you, Amit, for a wonderful talk and these discussions.
Thank you.
We are moving ahead for the next sessions.
Hello. Okay, firstly, I'd love to thank Dr. Chaurasia for such a lovely presentation, such a lovely presentation. Thank you so much. I guess we all should clap for this. And exactly, we are moving to the next session, which is do no harm approach. We'll have back-to-back sessions, but before that, I'd love to invite all the chairperson on the stage. The honorable chairpersons are Dr. Rabin Chakraborty, Dr. P.K. Dev, Dr. Anup Banerjee. So I request the honorable chairperson to get upon the stage. And of course, we'll have Dr. Madhumita, Dr. Mausumi Kundu, Dr. Manoj Lodhia, and Dr. Nabaru Roy as a panelist. So I request each and everyone be here. And after that, we'll have back-to-back sessions like zero contrast PCI. Definitely we'll have a cutting balloon, and definitely after that, non-crossable listen. So we'll definitely start with zero contrast PCI. I request Dr. Siddharth Mani to get on stage for the presentation. Thank you, sir.
Okay, yeah, thank you. Yeah, well, I think let's go ahead with the first speaker. Since there's no other chairperson or panelist, I'm just taking over. So zero contrast PCI. Over to you, Dr. Bari.
Thank you. Good morning to respected chairperson and all the delegates. First of all, let me thank the organizers for inviting me here. And I will be talking on a topic that is zero contrast PCI, which is really getting a lot of importance in the present days, because also we are getting newer insights every day, and newer softwares being developed on this to aid zero contrast or ultra low contrast PCI. So let us begin with the relevance of this zero contrast PCI. It is mostly relevant for the contrast induced AKI incidence, and the incidence of contrast induced AKI is quite high. It is to the tune of 3 to 15% in different studies. It is associated with increased net adverse clinical events, and it has both short and long-term mortality, ranging from 30 days mortality to an increase in the 3-year mortality as well. So contrast-induced EKI is independently associated with higher hospitalization cost, because you can guess that there will be a prolonged stay and the patient may need dialysis support. So that will obviously increase the cost. Now, how we can determine the risk, or how we can eliminate the risk, that is very closely associated with the contrast volume to the creatinine clearance ratio. See, the contrast volume to the creatinine clearance ratio, if it is more than 2, it has been shown to be an independent predictor of this complication, that is CI-AKI. And particularly this is true in patients who have a compromised eGFR of less than 30 before the procedure. We consider ultra low contrast PCI when the contrast volume by creatinine clearance ratio is less than 1, and normally a low contrast PCI, which is our target, it is to keep the CV by creatinine clearance ratio to 1 to 3. And today we will be talking about zero contrast, which is basically not using contrast at all during the procedure. This CI-AKI incidence depends on the baseline creatinine, obviously, and if the baseline creatinine is more than 1.5, then you can see in diabetic patients, the incidence is to the tune of 33%, and in non-diabetic patients, it is not very low, it is almost 12%. If the baseline eGFR is more than 45, the chance is really less, and it generally doesn't occur. If the eGFR is 30 to 45, the incidence is 1% higher than the non-contrast group, but the incidence markedly rises when the eGFR is less than 30. This term renalism has been coined in recent times, and renalism means that due to the risk or due to the apprehension of this CI-AKI, the intervention or the invasive approach is taken in lesser number of patients. So the patients, if we divide the patients into those requiring invasive approach, but because of their higher creatinine or because of their higher risk of developing CI-AKI, they are not being taken to the cath lab. So that is called as renalism, and that is obviously altering our results, the outcomes of the patients. Now, there are definitely certain other advantages of zero contrast PCI also, because we know that contrast is a myocardial depressant because of its related hyperosmolality and because it causes a functional hypocalcemia. And particularly in elderly patients more than 75 years, where the renal reserve is obviously less, so they can tolerate this contrast agent even less. So there are certain situations where ultra low contrast or zero contrast is beneficial, like the CKDs. We know patients taking nephrotoxic drugs, cardiogenic shock, patients having risk of acidemia or hypovolemia, and spontaneous coronary artery dissection. So here, the more you are using dye, you are increasing the risk of dissection extension. And so probably we need to control or reduce the volume of dye. So another set, like the CHIP patients, the high risk but indicated procedure patients, the CTO patients, where we need a longer procedure time and much more injection. So there also the risk increases. Now, what is the real feasibility of this zero contrast PCI? Because most of the studies with zero contrast PCI or ultra low contrast PCI ultimately used a final check angiogram. So it does not remain a zero contrast. It ultimately becomes a ultra low contrast. And most of these studies, they were done where, they excluded the CTOs, the multivessel patients, the multivessel disease patients. But in the real world, if you see the CKD patients, they have more chance of developing a multivessel disease, and many of them will require rotational atherectomy, left main bifurcation, or CTO. So how much this is really applicable to do a zero contrast PCI in such patients, that is really doubtful. Now, coming to the procedure and some of the tips and tricks of the procedure. For the access, a femoral access was preferred in most of the cases. Radial artery should be preserved for future dialysis because there is risk of AKI in these patients. And the larger sized catheters should be used because we need imaging devices, physiology devices. I will come to those in my later slides, and we need multiple marker words. So preferably a large bore catheter should be used. So the access should be made in that way, and USG guided punctures were preferred. Now we have to take a diagnostic angiogram. This is angiogram. This is not the PCI procedure. So for the angiogram, we should take a small catheter 5 to 6 French without side holes for better opacification. We should minimize the number of projections because there also we need to minimize the dye load. And to visualize the left coronary artery, the epicranial and epicaudal projections are best. To see the RCA, the LAO oblique cranial views are probably the best. So if you can minimize the imaging by 2 or 3 images, that will reduce the dye. And you have to avoid panning, use low magnification, because these angiograms will be later used as a roadmap. Diluted contrast often, we prefer diluted contrast, but that is a wrong notion, because if you, that may hamper the opacification or visualization of the arteries. So that will ultimately affect your roadmap. So that should not be done. It should not be at the expense of luminal opacification. Using higher frame rates help the operator to maximize the visualization of the coronary anatomy to help detection of calcification. So use higher frame rates in such situation. When there is a doubt regarding the physiological significance of a lesion, rather than taking different views at different angles, use other techniques like intracoronary imaging or coronary physiology to ascertain whether your lesion really needs intervention. If PCI is required, it should be preferably performed as a staged procedure after 7 to 10 days, if possible. Now, during the PCI, we have started a zero contrast PCI. So first thing is to engage the guide catheter. For guide catheter engagement, we have to choose larger catheters without side holes, again to accommodate multiple wards and imaging catheters. Coronary calcium can be used as a guide to identify the ostia and the silotes. And whether our catheter has been engaged, we can confirm by infusion of 10 to 20 ml of 0.9% NS, a cold saline, through the catheter. That will induce some STT changes. Sometimes it can cause a T wave inversion, or sometimes it can cause a increased T wave amplitude as well. Now, word navigation. When the coronary anatomy is already known from the angiogram, from the diagnostic cine images, they should be displayed in real time on a separate side-by-side monitor during the PCI, and that can be used as a roadmap. The dynamic coronary roadmap is a software which is developed by Philips, and there are certain other softwares by other companies as well. If your cath lab is installed with that, that will help you to see a dynamic roadmap. Multiple guide wires will be used to recreate the coronary anatomy by wiring the main branch and the important side branch, and ultimately creating a metal silhouette. Use guide wires without hydrophilic coating and try to give a shape to the tip so that once it crosses the lesion, you can easily knuckle it or form a loop, and that will not damage your distal coronary bed. So this is how a dynamic coronary roadmap looks. So you can see on the right-hand panel, the dynamic roadmap, and through that dynamic roadmap, it is easy to pass your wire. And this is how a metal silhouette is done. You can see main LED being wired, and you can see there is a septal, a major septal, the LCX is being wired, and you can see a major WEM and its side branch is being wired. So if you are going to stent the in between the mid segment, so you can easily place your stent from the proximal wire to the distal wire, and that will be quite ensuring to cover the stent. If you are going for aorto-ostial lesions like the RC ostium here, if you can keep a wire in the aortic sinus like this, so that can help you identify the aorto-ostium, the RC ostium in this case. So the marking wire technique aids in determination of the proximal and distal landing. This is a slightly different technique where you are using 2 guide wires via double Y connector, I will show you, and a 7 French guide catheter. The main operating wire goes to the distal bed, and the other marking wire is inserted from the side port. And this marking wire, the radio opaque portion, that will act as a guide to identify the proximal and distal marking zone. And that has to be ascertained by IVUS, and IVUS will confirm the distal landing zone. The marker wire will now be pulled back to the level of that landing zone, and by by closing the connector side port, the side Y port which we have taken, and if you apply a torquer tightly just outside the side port, so there is no risk of dislodgement of the or the displacement of this marking wire. So this marking wire with the radio opaque portion will show you the area or the landing zone, and accordingly you can place your stent. The lesion length and proximal landing zone determined by IVUS, and when the stent is advanced, you have to pull out this wire before you implant. So this is how it is done. See, this RCA has a tight lesion in the mid part, so you have done a IVUS to ascertain the landing zones, and you have placed a second wire, the radio opaque portion, the proximal and distal tip going into the proximal and distal landing zone, and you have taken a double Y connector. See the torquer there. The torquer is fixing the second wire from the side branch so that it does not move, and then you can place the stent and deploy it. Now, intracoronary imaging and physiology has to be integrated in such procedures in order to perform a zero contrast PCI, and that helps to perform the PCI safely and optimize the result. And the studies have shown that use of IVUS and intracoronary physiology is associated with lower rate of MACE. IVUS has traditionally been the intracoronary imaging here because OCT is not possible, that requires dye, so we have to rely only on IVUS, and then we can from IVUS we not only ascertain the landing zones, we can assess the plaque characteristics, the lesion length, the stent length, the vessel sizing, and obviously after PCI we can optimize the result. So what is done, this is called co-registration of the intracoronary imaging and physiology. This is a separate software which is available by some companies. The mostly known software is SyncVision Precision Guidance System by the Philips Volcano, and it is currently commercially available. It integrates the data of IVUS and IFR, and what they do is they plot certain yellow dots based on a 0.01 IFR unit of step. So when you are doing a IFR pullback across the vessel, the each 0.01 in step up in the IFR is plotted as a yellow dot. I am showing you in the next slide, and that plots, if you join, you can assess the area which you need to stent. So this is how the dots are placed, integrating the image of the IVUS with the IFR pullback. You can mark the points where you need to land your distal and proximal marker of the stent. This is another example of how this co-registration technique, the wire marking and co-registration, helps you to exactly identify from where to where you have to put in a stent. So by integrating all these techniques, you ultimately lead to a successful PCI. And how do you assess that whether it is optimal, your procedure is have attained optimal results? So for that, again, we rely on IVUS. The criteria standardly used is MSA of greater than 80% of the mean stent area.
You have to wrap up a bit.
Yeah, just one minute, just last slide. So proximal and distal reference lumen, if they are available, more than 80%. Only the distal reference lumen, if it is available, then MSA has to be more than that. And the stent area, we know about this 6, 5, 6, 7, 8 rule at the left main bifurcation. We have to see for no dissection, edge dissection, or malapposition. And there are also criteria for the significant edge dissection, like it has to be more than 60 degree and more than 2 millimeter of length. Significant malapposition when there is a gap of more than 0.4 millimeter with at least 1 millimeter length from the adjacent wall. And this is important. What is CI-AKI? It is defined as an increase in serum creatinine by 0.3 within 48 hours of contrast medium exposure, or a 50% increase within 7 days. This is the KDIGO working group definition. So obviously we have to combine all these, the techniques of engaging guide catheters, the IVUS co-registration, the physiological assessment, the wire marking techniques, and ultimately we can land up into a good end result. Thank you.
Thank you, Dr. Mani. I think it was a very comprehensive talk. And what essentially is like, there is two things. There is nothing as zero contrast, perhaps, but anyway, ultra contrast, because still, you have to make the final judgment after that, taking a shot. And secondly, it's just not one way. There are many ways to do it. Some systems offering this dynamic flow mapping, this actually is quite helpful. We don't have that, but I've seen the demonstration. It's quite helpful. But again, at the end of the day, it's not just that alone. So you can use IVUS and all, but that makes a little bit cumbersome,
Yeah,
it takes a lot of time to do a PCI.
Obviously.
Yeah.
So, but there are customized techniques by different operators, and we have to mostly rely on the side branch positions that gives us the precise location.
The one thing I would say about the dynamic roadmap we have uttered, and also just normal side infusion to see the ostium with ST depression. So just we do prefer about the dynamic electrocardiogram or dynamic roadmap in seeing the coronary anatomy at the beginning.
No, dynamic roadmap is a beautiful technique, sir. We also have in our cath lab that dynamic system, and you can easily, I mean, while wiring, you can almost see the coronaries because that is just superimposing the coronary images of the angiogram images. So, I mean, it is more or less flawless.
When tools are not available, we can use the saline infusion with the dynamic as we change.
But saline infusion will only ascertain the engagement of the guide catheter, but you have to negotiate your wire to the distalmost bed. So there you need the roadmap.
Yes, thank you.
Thank you, sir. Thank
you. Next speaker.
Thank you so much, Dr. Mani. Okay, so the next topic is cutting balloon. I love to call Dr. Oyon Kaur to have some discussion on this topic. Thank you.
So first of all, thank you to all the organizers for giving this opportunity to present in front of this august audience. So keeping in with the theme of the talk, and that is a no harm approach. And so I think a very important tool to have in your armamentarium as an interventional cardiologist is a cutting balloon. And so I'm sorry, I will miss out on a lot of probably data. I won't be showing you a lot of, I'll show you probably the way to use conventional, or rather I would show you out of the box uses of cutting balloons, and probably leave you to think also in certain places where you could probably decide that cutting balloon probably could be the future. So a brief introduction for the unversed. I think there are very few in this hall, but nevertheless. So as you know, this basically is a balloon. So there are two different kind of balloons conventionally we work with. One is the Wolverine, the other one's the Angiosculpt. And one happens to be a semi-compliant, the other is a non-compliant balloon. And what you have these micro blades on top of these, fixed on top of these balloons. In case of the Angiosculpt, it's kind of a spiral. In case of the Wolverine, it is a longitudinal blade. So what it does basically, instead of just pressing across the plaque and making space for a stent, what it really does is it modifies plaques, and that is what is important. So for having better stent apposition and for making better bed preparation, it is important that you modify your plaque. And so this is probably the cheapest tool in your armamentarium to modify plaque. Of course, the other ones that come sequentially are generally quite expensive and difficult to procure and not always available. Of course, it's easier to deploy than a rotablation or an orbital or an IVL. Of course, it's cheaper and less steep learning curves. The cons typically is probably the stiffer delivery profiles. So what is the concept? So concept is, it's very important to understand again for people who are new to a cutting balloon. I'm sure there are not too many in this room, but nevertheless, for postgraduates who are there and might want to understand. So so what we do in case of a non-compliant balloon is we basically stretch the vessel, we just displace plaque, and we are making way for a stent. But when you use a cutting balloon, what you're really trying to do is you're trying to modify the plaque. So as you can see, we are trying to make small cuts in the plaque, and thereby we are actually modifying it. And we are doing this in a very controlled manner. So remember, these are controlled dissections compared to an uncontrolled disruption of the atherosclerotic plaque that you do with a normal non-compliant balloon. So the words to really emphasize is the controlled dissection, reduced endothelial injury, and thereby what you're actually preparing the bed for a good stent apposition. So types being the cutting balloon, the scoring balloon. So of course, things where it really doesn't work probably is calcific nodules and gross stent under expansions and in-stent restenosis, which can be very difficult to deal with. But in general, this is a simple tool and it can be used quite comprehensively. And for beginners, I think it is something that you should always be happy to use because it's easily available. So if we were to actually look at the plaque modification devices available to us, so it starts with a non-compliant balloon, goes with a cutting balloon next. I mean, this is with the intensity of plaque modification. Of course, this would be followed by an OPNNC, followed by a ROTA, then an IVL, then a ROTA plus IVL, and lastly a laser. So this is what is the intent when you really want to modify plaque. Use-wise, so where do we really use them? We are typically looking at aorto-ostial lesions. I think we've been seeing some cases being done with aorto-ostial lesions, and it is always very important that when you're doing with aorto-ostial lesions, so ostial left main, looking at the proximal ends of SVG grafts, ostial RCAs, typically which are isolated ostial RCAs or isolated ostial left mains. Remember, these are generally fibrocalcific, have higher elastic recoils, higher rates of ISR, frequent geographic misses, and you always have poor bed preparation. So these are things which can be easily tackled by one device, and that is a cutting balloon. So this is data from our center. So we are looking at, this is published in the Journal of American College of Cardiology, and we have shown that this is actually a very important adjunct as far as good bed preparation is concerned. And this leads us to believe that cutting balloon is a very valuable adjunct in complex subsets, specifically where POBA, that is plain old balloon angioplasty, has failed. Of course, issues remain with the fact that the delivery profile of this balloon is on the larger side, and hence in cases of extreme tortuosity or very tight lesions, it might be very difficult to deliver. So you might need other devices to handle those kind of lesions. If you look at in-stent restenosis, so we generally talk of two types. We're talking typically of new intimal hyperplasia or new atherosclerosis. So specifically, we do not want to put in another DES. So if you are looking at the theme of this session, and that was a no harm approach, I think a cutting balloon really fits the game here. And so you can just go in, use a cutting balloon, make sure that you've made good dissections, which are controlled dissections, and you can possibly follow it up by a drug-eluting balloon. And I think this is likely to generate good results in the long run, because if you look at the data, the more number of stents you put, the higher the risk of restenosis in these kind of patients. Of course, this I'm going to show you some data which is probably medieval or very, very old, but it is something that is really nice to brood upon. This is from Antonio Colombo's lab, and I always go back to this data because it actually shows you a head-to-head comparison between something that we do on a regular day-to-day basis. And so it looks as cutting balloon, it looks as road ablation, it looks as stent in ISR, as well as plain old balloon angioplasty in ISR. And what is a no-brainer is probably that the MACE rates were the lowest in the cutting balloon arm. The next was in the ROTA, and of course the stent had the highest. So it tells you that typically ISR is best dealt with without further metal. One more subset, which I think, again, you would want to look out of the box, is probably coronary artery ectasia. So these kind of patients, you'll always find it very difficult to size your stents. You wouldn't know how to put, because your distal diameter probably is 3, your proximal diameter is 5.5. Stents are available to do that, but then it's always not easy because you'll have some malapposition at the proximal end. So I think these are places where you can probably just deliver a cutting balloon, ensure that you don't have significant dissections, probably do a DEB and come out. At the same time, you're actually delivering good therapy. Of course, beyond this, it's guideline-directed medical therapy. Alternatives in high bleeding risk patients. So patients, typically elderly, patients who are known to have high bleeding risk, prone for falls, who may not be able to tolerate dual antiplatelet therapy, or where you want to interrupt DAPT quickly. These are patients probably where you should think of cutting balloons followed by a DEB. And of course, all these patients, in order to deliver this therapy very accurately, intravascular imaging is a must. So tips and tricks while using, so always use imaging if it is available, size your balloons well for optimal results. Of course, be prepared to use further adjunct atherectomy options. That could be an IVL, that could be a road ablation, that could be something else, whatever you're conversant with. Prepare for complications. So when you use these kind of devices like the cutting balloon or the OPNNC, there is a high chance of perforations, etc. So you should always have covered stents available in your lab. Supporting wires, guide catheter support is very important to ensure that you're able to deliver these balloons because the crossing profiles of these balloons are a little on the higher side. Thank you, and I'd be happy to take any questions, if any.
Thank you, Arijit.
The thing Oyon has, Dr. Oyon Kaur has highlighted is that aorta-ostial lesions, you should be preparing your bed in a precise way. Because we often see that the stents have been deployed in the LMC ostium, but it remains grossly underexpanded. So an aorta-ostial lesion is bound to be a fibrotic one, and so a cutting balloon of proper size, if possible, a 1:1 size should be used for bed preparation. Once you put in the stent, you are nowhere. So a 1 ounce of prevention is better than treating the whole thing. So the other point that I want to make is day in and day out, we try to keep on underestimating some lesions, especially in the distal part of the LAD. You find that you have stented, but that portion of the LAD is quite fibrotic. And as we are keeping on doing intravascular imaging, even yesterday, that live cases that we demonstrated, there was an underexpansion in the distal part of the LAD, which appeared to be inconspicuous. In those segments, it is better that you go by a cutting balloon and prepare your bed properly. So Oyon is, as usual, at his best. A wonderful deliberation, and thank you for.
Only one question about the degenerative saphenous vein graft.
Yes, sir.
Will you prefer using the cutting balloon or something else?
So we have data specifically in degenerated saphenous vein grafts. I think we have published data in JACC, and we've shown that actually a cutting balloon is always better. Of course, I mean, it depends on what kind of lesion you're dealing with. As I said, always look at your IVUS, look what kind of lesion it is, and accordingly then decide on your atherectomy device, whether you're going to use a cutting balloon or probably a rotablation or an IVL. Of course, degenerated vein grafts using rotablation is not easy. They're definitely very difficult sometimes, but I think IVL and cutting balloon is probably not a bad idea.
Okay.
Yeah. Larcos balloon.
I've never used one, so I've of course heard of it.
So a lot of new data on Larcos, the different kind of cutting mechanism. As if it is like a cheetah, when a cheetah runs, they keep their head down, and it's the penetrations of the force they generate because they reduce their profile. So Larcos balloon is one of the newer generation cutting balloon, but we have Flextome, we have scoring balloon. Now we have also high pressure balloon.
Yes, sir.
Like OPN. So if I ask you to choose one versus another, like there is a controlled expansion of the fibrotic lesion by OPN balloon, maybe 0.9:1 or 0.8:1. It should not go almost 1:1 because there's a chance of perforations. So what is there an advantage of choosing OPN versus cutting balloon in fibrotic lesions?
So I think sometimes, so it's definitely not such a practical choice always. It has other ramifications too, sir. But we generally feel in fibrotic, I think cutting is always better. So OPN is typically for lesions which do not yield. Because it causes definitely some amount of injury to the vessel wall as far as the OPN is concerned. That is not there as far as the cutting balloon is concerned. Cutting balloon, very controlled dissections. You know what you're dealing with. Chances of complications on the lower side. Problem with OPN I have faced, I'm sure you have faced also. Delivery profile is definitely larger than that of the cutting balloon, number one. Number two is getting that balloon back is a bit of a difficulty on standard workhorse wires that we use. Of course, I think
OPN balloon is difficult to take out from the system.
It's sticky, but then
it hugs the corner.
But then it's never been a very big problem, but it is a problem.
It's a problem. If you do not have access to particular size of the Flextome or scoring balloon, you can take out the newer generations balloon can go up to 30 atmosphere. We have this company that's a small pod balloon they have up to.
Yes, sir.
Anyway, thank you very
sir.
much. Peter is waiting from UK, so there is slight change. Arijit will come, and Manoj Chopra will come after Peter O'Kane. So we have a beautiful session. We're going to watch your laser technology. Can you connect to Peter?
Good morning.
Hi, Peter. Can you hear me?
Hi, yeah.
Yeah, hi.
Good morning.
Yeah,
Can
we
you
saw
hear
you
me
in PCR, your beautiful presence. And your contribution was tremendous in last peace year, what we watched physically over there, virtually from India. Thousands of Indian cardiologists watched your program. So then I thought, why not, Peter, come to our local station, the Calcutta, where the British started their journey in India. It's the oldest city in our country, and we're so proud to have you here. So I'll request you to tell us about the laser technology, what's new, some case example. Over to you, sir.
Oh, thank you very much. It's a very kind introduction. Thank you for the invitation. I'll just share my screen. Well, it's going to be a similar talk to the one I gave in Paris. And let me just pull it up. Hopefully, it will stimulate some questions. It's early in the morning for us here in the UK, so apologies if I'm still a little bit sleepy. So I'm going to talk about laser and how it works in the coronary system. And this is the overview. So I'll just start really with talking about what laser is in principle. So light amplification by stimulated emission of radiation is the absorption of light that we're really interested in. And as that gets absorbed into tissue, that energy is used to break down the material. So within the laser system, which Philips is the only FDA approved one, we have the xenon chloride gas, an excitation mechanism, which is electricity, pulls those molecules apart, produces the photon, and that process is repeated continuously and allows us to generate this light energy. It's not just the light energy which we will use, as you'll find out as I go through. This is the actual hardware itself. So the laser machine is quite a bulky device. This is the first generation machine. This is what we had in our catheter labs for many years. This principle is the same. We take a catheter, we calibrate the machine first of all, and then we calibrate the catheter, and then we're ready to use. And this particular catheter is a 0.9, very thin, very easy to use. That pictures of the next generation, but this is the very latest model. It's fantastic. It's really small compared to the previous one, much lower footprint, and you can see the weight reduction is about 26%. Calibration is identical. You hold the catheter against the machine, but now there's a touch screen which really facilitates much easier moving around from different energy settings, which I'll talk through in a second. In terms of the catheters, there's obviously not just coronary work, but there's lead extraction, which you'll hear about later. The coronary catheters, there are 4 catheters. The 0.9 is the only one to worry about or think about. It offers the maximum energy and the highest laser settings. You get 10 seconds of lasing versus 5 seconds rest. The 1.4 is a 6 French compatible, but has lower energy settings, 1.77 French compatible. And then the largest catheter is 2.0 and is 8 French compatible. But those all have lower settings in terms of power. How laser works? First thing is the light breaks up the molecular bonds, and this is quite important. So we have to allow the light to penetrate into the tissue. So it's a very slow process when we're delivering laser energy. So as the laser light goes into the tissue, it starts to crack these molecular bonds, and that weakens the tissue. Now the laser itself is ultraviolet light, so it's very sort of shallow penetration depth, about 50 microns. So it's very small, and it doesn't damage the adjacent tissue. It just focuses really on the area of interest. Once it starts to break up the bonds, then we can get into the next phase, which is really the sonic wave, which is emitted from the catheter tip, which breaks up things further and penetrates out from the tip of the catheter, a little bit like the way that the shockwave system works. This will penetrate into the deeper tissues and will help to break up the more fibrotic tissue and potentially calcium, which is maintained in that lesion. The third step is you have this cavitation effect. So this formation of the vapor bubble is creating this sort of sonic energy to mechanical energy, and it's clearing into the tissue and breaking down these products. They're broken down into tiny, tiny particles, which are absorbed in the reticular endothelial system. They don't really get any problem with no reflow, sometimes what you might see with rotablation. So those are the sort of 3 mechanisms described, but they're all working at the same time, and they're all working in a very short period of time. Now, the thing about laser, it's a very easy technique to learn. The first thing is you have to just move things very slowly. I've said that the light penetrates to shallow penetration depth, but you just move it incredibly slowly into the lesion, and that gives you the biggest lumen gain. If you move it too fast, it hasn't got time to work. So in this situation, we go slow to finish fast. Power settings, there are two basic sort of settings you can go for: the lower settings and the higher settings if you've got more fibrotic tissue. Now, using it in saline is very important because that reduces the risk of penetration into deeper tissue and reduces the risk of dissection and perforation, as you can see in this test tube model. If you use it in contrast, you get.
So how we do it in this lab is we set up
explosion.
with the three-way tap. We have the saline put onto the side of the three-way tap. Then I disconnect the contrast and I put that on the top of the three-way tap, like so.
So that's just how I set up in the cath lab, but you don't need to do it that way anyway, as long as you're injecting saline as you're lasing. Now, the laser, you can change the frequency. So this is the second number. The first number is the power. The second number is the frequency, and you can change that if you've got more complex lesions. This is just a useful paper for people starting out in laser. It's a 10-minute read, and it gives the tips and tricks and gives some of the indications. Now, I'm going to talk about how we use it in clinical situations, and the three I've picked where I think it's most useful is in non-dilatable, non-crossable lesions is the first real group. This is where I really first started using it. Restenosis, I think, has got some good applications because of underexpanded stents plus neointimal hyperplasia. And lastly, thrombus, it works very effectively, and I'll show one example of that. And as I've alluded to, you can change the settings of the device to allow you to deal with this more different range of indications. So if you've got soft plaque, you don't need so much energy. So you can go with lower settings. You might go with 25 and 40. But if you've got hard material like calcium, you've got CTO, then you're going to go with the higher settings and go with that right at the very start. It's much more efficient. So if you have a non-dilatable lesions, we know there are several options of treatment that we can offer. We can go from cutting balloons, scoring balloons, and so forth. And in this situation, I think imaging is very useful. But of course, at the start of the case, you may not be able to get the imaging catheter down. Doesn't matter, I don't think, whether you use IVUS or OCT, gives useful information. So in this particular case, this was the CTO of the LAD, as you can see. It gets wired, true to true with I think a miracle wire. So it's quite an old case. But that balloon doesn't expand, very focal lesion. And we've got different options, but we're going to use laser in this instance because it's very straightforward. It's on the same wire. We don't have to change wires. Any 0.041 wire will do, and it will deal with an uncrossable and non-dilatable lesion very effectively. So only about 4,000 or 5,000 pulses necessary. Here's a more recent case: 68-year-old patient with a calcified right coronary artery, has a mitral valve in place, and has severe renal impairment. So this is ultra low contrast PCI, as you've heard before. Here is the anatomy. You see there's a tight lesion in the right coronary artery mid-vessel. Balloon does not expand. It's quite clear. So we go straight to laser here, 80-80, deliver 15,000 pulses, which is quite a lot to get through, actually. It's quite a resistant lesion. But then the same balloon then expands. And at this point, we can then pass a IVUS catheter through the lesion. And what we see on IVUS is a bulky plaque, significant calcification as you come back into the proximal vessel. And we see some modification in the lesion. And that's probably been caused by the balloon following the laser, but obviously we couldn't get the balloon to expand before laser. Then we put a biofreedom stent in, and we get a good result angiographically. And again, we use the imaging to confirm that we have good stent expansion. So I think laser fits in really well into the toolbox when you have this type of stenosis, which is resistant to normal balloon technology. What about if you cross with a wire, but then you can't get anything else to follow? This is not an infrequent occurrence, particularly in the CTO work. Clearly, balloon technologies here are going to be ineffective, scoring or cutting or shockwave. And most atherectomy is tricky because you cannot get a microcatheter to cross. Laser here is a really good, obvious choice. But if the microcatheter crosses, then of course you've got options. You can use rotor, you can use orbital. But if it doesn't cross, then rather than going through multiple balloons, I think the best thing to do is to use laser, because I know it's going to work. So in this particular case, we wired again, fairly true to true, straightforward CTO. A small balloon that we had at the time did not cross, and neither did a microcatheter. So we use laser, 5,000 pulses, and we get the case done. So you can see laser really is just a step to get the case completed. So this sort of technique of not crossing or not dilating the lesion. We go straight with laser, it works, and then we get a good result with our stents. This is a more complex scenario. We have a patient who's got an impaired left ventricle, ejection fraction less than 35%. That's the anatomy, a tortuous calcified right, which is looks very unattractive for PCI. A left system with a severe circumflex and severe LAD stenosis. The patient has an overall high jeopardy score in terms of the coronary anatomy. MRI shows that most is viable, and we do a CT up front to look at the peripheral circulation because we're thinking about an impeller in this case. And in fact, this is a trial we're doing in the UK called the CHIP VESIS-3 trial, randomizing patients to impeller or not impeller for these complex cases. This patient qualifies on the basis of a high jeopardy score and high burden of calcium, so we have to modify. And this patient is randomized to having PCI with impeller up front. So I get my colleague, I don't do TAVI in our centers, I get my colleagues come across and we do this large bore access together. He's a TAVI operator and we get good results. So here's an impeller being implanted into the left ventricle at the start of the case. And this is the actual easy bit of the case, because what follows is more tricky. When we start the PCI, we're 6 French, we've got an EBU 3.5. I can't get anything to cross that circumflex stenosis. No balloon or Corsair, nothing will cross. It's very tortuous and calcified. Now, this is not the easiest case for laser because it's tortuous and calcified and maybe a relative contraindication, but I use the laser here just to get me through about 75% of the lesion. And that's enough to modify the situation. And then I can get a balloon across, which then is really safe. And then I can get my microcatheter down, which was, even despite the laser, is still quite tricky. But once I get that past the lesion, I can switch out for a rotor wire and I can use a 1.5 millimeter burr. This is clearly a very calcified lesion and we need to get good results for these patients, particularly in the trial. So we use a 1.5 burr, we get good debulking. We switch out for a grandstand wire for extra support. And with GuideLiner, I'm able to deliver 3 stents and get a reasonable result in that circumflex. The LAD is much simpler, doesn't require laser. We just put a microcatheter down, switch out for a rotor wire, 1.5 burr, ultimately go on and perform shockwave as well, because you'll see the calcium burden remains high despite the rotor on IVUS. It's 360 calcium, not that much reverberation. So we feel this is probably deep wall as well as superficial. So we go ahead and use the 3.5/12 shockwave. So an expensive case in terms of equipment. Clearly we've used impeller, rotor, laser, and shockwave. But we get a good result in these vessels. That's the procedure data, so tiny troponin rise and the patient goes home the next day. And this is all part of a clinical trial, so it's good. Now, when we combine these technologies, laser and rotor, we call that RAZOR. We first did the case in 2008 and published it in Neurointervention, and that's why we coined the term. Here's a more complicated case, an 86-year-old patient, again, with a poor ventricle with an acute coronary syndrome. And this is the left main into LAD. You can see it's a complex lesion with a high burden of calcium and nodule, and it's a very severe stenosis. And this is really the last remaining vessel. So we did this without any hemodynamic support, and it was a challenging case. So we're 7 French from the left radial artery. We get a wire into the LAD, we get a wire into the circumflex. Microcatheter will not travel into that circumflex. There's no real option, into the LADs. There's no real option to rotablate at this stage, even though that was my initial intention. Tried a variety of different mechanisms to get down into that LAD with microcatheters, including balloon anchoring in the circumflex. So this is clearly a laser case for me. So we take a 0.9 laser, but in fact, again, we're having to push quite hard in this calcific lesion, and you just keep going there, keep maintaining the pressure. Don't over push, because that will potentially then shoot forward and cause trauma. So you're just pushing gently up against resistance and allowing the laser to do its work. Now, after about 10,000 pulses or so, it starts to make some good progress. When it meets a lot of resistance, I then stop in this complex type of lesion and then take a balloon back. I don't keep going with laser to get 100% through the lesion. All I'm trying to do is modify things so I can get other equipment through. So that's what I do at this point. When I get too much resistance, I think, well, I'm not going to push it any further, take the laser catheter out, switch for a balloon, and then we're able to make some space. So once the 2O Sapphire then crosses and then able to get the wire down, you can see there, wire was kind of stuck in the lesion, wouldn't go any further. Obviously having a distal wire gives us more support for the lesion. And once we're able to then deliver the 2O balloon, I'm feeling like we're making progress, and the balloon actually does start to expand, but not fully. I take a bigger balloon, I'm not convinced it's fully expanding. So we go with our original plan and we use a 1.75 millimeter burr to rotablate through that proximal lesion. And then at this point, we're able to do some intracoronary imaging. And actually what we see is that there's still a very significant amount of calcium. I haven't shown the imaging here, but you can see on the fluoroscopy, there's a huge burden of calcium. So it does require shockwave as well. But we get a very good result, which I think, given that this was an important vessel, was an important aspect to get right. So sometimes you have to combine these equipment. And when we've combined all three, we've given it the name Razor Shock. I mean, none of this matters, but you can just see it's all about using the tools. The restenosis, why is it useful for restenosis? Well, I think there's two potential mechanisms here. First one is you have an underexpanded stent. And secondly, if you want to clear all the material. Now, I first had experience of this back in 2009. This was the patient I was treating, 80-year-old. It initially came in with a calcific LAD, pressure wire was positive. I treated with a 2-burr strategy because that's what we had. In 2009, we used rotablator a lot, at 1.5, and then a 2O because the balloon didn't expand in between the burrs. Now, after that 2O burr, I took more devices because it still wouldn't expand. I took cutting balloon, I took non-compliant balloons, and I could not get this lesion to expand. The imaging told me that why this was, because it was clearly a napkin ring calcific stenosis. And I made a mistake at this point because I thought, well, if I put a stent in, I'll be able to go to high pressure with an OPN balloon, and I'll probably be able to resolve this. So that's what I did. I put a bare metal stent in, which clearly was not the best thing to do. And despite going up to 40 atmospheres with OPN, I still had an underexpanded stent. So I brought the patient back 2 weeks later, had some phone calls with colleagues in the US. Not many people had done this treatment with laser for underexpanded stent. You can see the IVUS shows, again, the napkin, but this time within a stent, which is clearly a very dangerous situation for the patient. We took 2 laser catheters, a 0.9 and a 2.0. I think the 0.9 did all the work. And then the same balloon I'd used previously went up and it was magic. And it was one of those moments in your career when you think, well, something's really different here and this device has worked. And nothing else I don't think would ever have worked. So for me, laser for underexpanded stent works quite well. You don't have to use it with contrast as that's off-label. You can if you've got very resistant lesions, but a lot of the time you can do it just with saline. So there has been some publications in this area. This is the registry from the Milan group, and they did use contrast in their population, relatively small number of cases, and they got very good results with it's obviously a very high recurrent population come back with MACE. There's been more case reports, and I think this is quite a nice paper in neurointervention. It shows that how laser works really is by affecting the peristent calcium and fractures it, and the tighter the lesion, the more gain you can get with laser. So in this short talk, the final indication I think for laser is, for me, is thrombus. We did a lot of cases with thrombus in the early years when we had primary PCI. One of the reasons it works well is because a thrombus naturally will absorb light of this wavelength. And these are some very elegant experiments done by, I think, the real hero for laser, which is Professor Onto Powers in the US. He's published huge amounts on this. And he took platelets and that were exposed to collagen and ADP aggregation and showed that basically laser light inhibited that aggregation. It prevents the platelets from sticking together, and that obviously is a very useful thing. So in this situation where we have a previous stent, a taxa stent and a stent thrombosis presenting very late, we do some ballooning, we get very little flow in the vessel. We perform some imaging, which really tells us that there is multiple mechanisms at play here. There's clearly underexpanded stent, positive remodeling, but within the stent, you can see there's lots of thrombus there. And this is tricky thing to resolve. If you keep ballooning, you run the risk of distal embolization, and you may not get any benefit in any PCI here. Sometimes you might give just drugs, so we might give a 2B3 inhibitor and wait. But there was quite a lot of mechanical issues, I think, that needed resolving here as well. So I didn't really want to stop and do that. So the plan here was to use laser. So we gave it 2B3. You can see the angiographic thrombus, which fits with what we see on IVUS. I open up that PLV initially, and then I move to laser. And I use a 0.9 catheter. You could use a bigger catheter, but you'd have to use sometimes a bigger guide. You go with 1.4, I guess, with 6 French. And then after lasering, we laser from proximal to distal. And I think there is a bit less thrombus, perhaps. I haven't measured it, haven't quantified it. But importantly, the patient obviously is very stable. We have TIMI3 flow. We haven't got any embolization. And that's a good situation to be in when you're in this type of setup. So then I am able to then, having I think cleared most of that thrombus, to put some new stents in, because these are first generation stents that were there before, and we stent from the distal vessel back to the proximal vessel, and we get a great result. And when I've used laser in this situation before, I generally get very good results. So my summary table, these are the different devices in comparison. I think laser is not the best for heavy calcification, but it's good for moderate. It's perfect for underexpanded stent, and it's unique in its use in thrombus. So I'll stop there. I think that's exactly 20 minutes. And I can take any questions.
Yeah, thank you. Thank you very much, Peter. If you have a Cypher stent, we have few patients still left with Cypher stent. They have a long life here, got Cypher stent at very young age. And the problem of DAPT comes back again and again. Do you think you can shave off the polymer, permanent polymer, and make it like bare metal again?
Good question. I mean, we don't know how it works on the polymer. We know that it's very safe on the stent itself, because there've been experiments in benches and I think in animals where they've used laser in stents and it doesn't get hot or doesn't damage the stent itself. But the effect on polymer, I think, is unknown. So I think, because like a Cypher stent, you have a pretty much the polymer is across the whole stent, is abluminal and luminal. I suspect you're not going to get to the abluminal polymer, so you're not going to get rid of it completely. So I don't think laser will work in that situation. Plus, it's very difficult to get that pinpoint accuracy, I think, with laser catheter, because you're only really applying it in a sort of more spatial area. You're not really pinpointing exactly where it's going to be. So I don't think it would work in that situation.
Dr. Peter, I am Dr. Manoj here.
Hello.
You talked about the thrombotic lesions, and initially now we have only a medications and the thrombus aspiration catheter. I think this is a new indication of the laser, and that really works well. And most of the time in young patients coming with a STEMI, very large thrombus load, or if there is a lot of time spent in a cath lab, we find that some of the times it's a resistant thrombus, and we lose patient because of that. So that's the area where I think the laser is going to work very well, and that's the one area. Second thing, what you talked about is undilatable and uncrossable. Whenever there is a specule or nodule, it's very difficult to cross the lesions, and I think the rotablator is playing an important role here. So what do you think that how do we select it's a laser or a rotablator in these specules and nodules where there is an uncrossable lesion, and does rota scores over here or a laser? Because 2-3 live cases, what I see that they started with a laser because they wanted to demonstrate the laser, and there was a comment that if we would have taken a rota, we could have succeeded or got a better result. So what is your experience?
I think that's two fantastic questions. I mean, first of all, I agree with the first one. And in fact, I think India is the perfect country to do a study with laser and thrombus, because it needs a big study. But I think you have a population where you definitely see a lot of thrombus in young patients, so it'd be perfect. In answer to the second question, I mean, when we first started with laser, we didn't have all the brilliant microcatheters that we have now. So laser was therefore, a very good technique up front. But now with microcatheters, I think my answer would be, if you can get a microcatheter across easily, you're probably better off going with either rotor or orbital, because it probably will work more efficiently. If you can't get a microcatheter across, then laser is the perfect indication. And that's I think is a general kind of rule. So that's how I now use laser. And consequently, my laser numbers have gone down for that indication, but I think it's the most efficient.
Thank you, Peter, for being with us, and we have learned a lot. We'd like to see you here in India sometime in the future. That will be physical. It will be much more pleasurable to meet you personally. Thank you very much for your.
Thank you very much indeed, and thank you for the invitation.
Thank you.
Have a good day. Bye-bye.
Bye-bye. Right. We'll next go to lead management, and Professor Manik Chopra, my friend, he has come all the way from Pune. He is the robotic man, robotic PCI man. Though he has his own brain, but he uses robot's brain and his beautiful pair of hands to make the perfections, to make the life better, easier and simpler. And we have a lead management by Professor Visitie Oswald from Belgium. She's one of the pioneer in lead instructions. The original idea came from Cleveland Clinic. And that time they started with laser sheath, the stent inside. So today we are going to learn the lead management, which is very relevant in this part of the country, where thousands and thousands of patients are living with pacemaker. And this is the pacemaker hub of India. And we have Brady, Tachy, we have CRTs, LVP pacing. All these devices can get infected. And how to remove these leads elegantly by a laser, we're going to learn from Visitie. Over to you. Over to you.
Thank you very much for this very nice introduction. I'm very happy to be with you in Kolkata, even if I'm sitting here around. Nevertheless, it's really for me also an honor being invited in a session which is about PCI, because this is a first time for me. I will share with you my my presentation, and it's also very nice having Peter in beforehand, because he already gave you some insights of the technique itself. Lead management is a little bit different on one way, but it may be also similar in some ways, and I'll show you something about that. I'll talk about first the similarities, second about the differences, and about practical aspects about laser lead extraction. And I know many of you are already going for laser lead extraction. I've been in India. I did have the big opportunity being there someday. So if we start with the similarities, you do see here the pictures which Peter already presented. And this is exactly the same action of mechanism, because we are just having the same, I would say, big tool, which means the laser application is just done with the same machine. However, we're using different sheet. So we are also dealing with light pulses, with acoustic pressure wave, and with cavitation bevel, which you already have seen. So there are also further similarities according to the sheet. And you see the fibers are in parallel to the sheath, or parallel perhaps also to the lesions. And this is the same in the coronary setting. You see it here. There are several lines of glass fibers heading into the tip of the sheath. And this is also true for the laser sheath, which you see on the right side. So you see there is some difference, but I'll go to that later. This is very interesting that Peter already showed you also, that you do have a really good tool, even if you're going to, for instance, stenosis, if you have stents which are metal, or if we are using the laser in multiple leads, if you have a dysfunctional lead which you would like to get out in favor of just abandon it, then you don't do any injury to the adjacent leads which are inside of the vessel. The glass fiber arrangement, you see there are some differences. You have multiple layers in the coronary sheath, but we have a single layer in the lead extraction sheath. We have some differences, and you see the sheath shape. This is quite straight in the coronary catheter. This is symmetric, and in the laser sheath for lead extraction, you see there's an oblique sheath tip, which has some impact because for the lead, you use the lead as a rail and you don't have a wire which is just flipping around. So this is sometimes very helpful if you go for curvature. So this is quite different. We do have also some different specifications, which is clear. The coronaries are quite very thin vessels where you have to pass through. And if we are going for lead extraction, you have to pass any of the leads which are on the market so far, and which means you have also several sizes. Even for lead extraction, you have 12F, 14F, 16F, and we all have in the glide light sheath a repetition rate between 25 and 80 hertz. And this is quite something I would also focus about, because if you're going for coronaries, you have an arterial system, and this is quite not true for laser lead extraction. At least if the lead has been not misplaced in an arterial system, you do have to deal with venous systems, which means your calcification is mainly related to the really, I would say very tight lying lines at the side of the lead. You see, this is one of the fibrous tissue which was going around the lead, which was just cut it through, and you see there the most compressed and dense fibrosis is just at the side of the lead itself, which is different to the coronaries, where you have more normally some fibrous layer in between, perhaps also some thrombus and some calcification going down there. This is quite the opposite, and this makes it also a little bit more difficult if you use a laser sheath or lead extraction to pass through calcified lesions. To be honest, if you do have really severe calcification, the laser is not the tool of choice because it's a little bit too soft to crack any calcification. And I will go to the practical aspects now. You see, I put all the patients under general anesthesia, and they are fully prepped for open heart procedure. We have a TE on site. We have an extracorporeal circulation backup. And this is a case where we had a CIED infection. This has been a system which was quite implanted a few years ago. And you see, this is not real time. You can pass through and you don't injure any other lead if you go through the leads. This is first lead which came out here. This is the right ventricular lead. It was taken out. And you can go lead by lead. We placed in this lady first an epicardial lead to maintain the rhythm, and she was having a left ventricular pacing and she had persistent AF. So this was a method of choice. But where we can't pass through, and this is because of the thickness of the laser sheath, we can't pass through the coronary venous system. I would never recommend to pass through that because this is really paper thin, and this may be disrupted if you try to pass through, and you can go and have any injury. So we just stay here, even if we have a coronary sinus lead, which is just really sticking in there very hardly, time by time, and by some movements. In most of the cases, you manage to get it out finally. So these are the main topics of the practical impact of laser lead extraction. I would really recommend also, like Peter already told you, go very slowly. It's no way to really pass very hard or to press or try to put any pressure on the lead, because really the venous system is really paper thin also, and perforation is one of the most frightening complication. You see here how the leads come out after laser lead extraction. And this is also some something which is important to know. If you have externalized conductors or a very fragile lead where you have the insulation already disrupted, then the laser is really a much better choice to any mechanical rotational tool which is on the market, because then you don't disrupt the conductors. And this makes it really a simple and safe procedure in that way. And very dense, and they are directly related to the lead, and they are less pronounced in the venous system. This is one of the pictures just, I think, last week, and you see what happens if you have really dense calcification here. And this was a calcification, you can't feel it. It was really quite hard. It could be just cracked. And this was the largest laser sheath which was available. It was a 16 French. This was, you see it here coming down here. This is a metal coil of an ICD lead. And we just stepped here at the entry of the coil because of a really dense fibrosis. And we were happy just to get out this lead by just simple pulling at that part. But this is really something where the laser does not work very well. And especially in laser lead extraction, it's really important to think about oversizing of the sheath, which is in contrast to the coronaries. But this is really something to think about, because you do have the dense parts of fibrosis or calcifications just around the lead, and they will prevent any good progress. So I conclude many aspects about exam or laser application is similar in laser PCI and laser lead extraction, but we have many differences which require specialized and tailored treatment and application technique. So if you just use the laser for coronaries, don't think about just taking out a lead. It's really quite different. And the laser offers therapeutic approaches otherwise not to be achieved by mechanical or further techniques on the market. Thank you very much for the invitation, and I will be happy to answer any questions if they are. You see, I'm not in Belgium. I am located in Germany. This is Duisburg. This is the city where I do have my hospital in there. But to be honest, at the moment, I call you from the Côte d'Azur in France.
Thank you, ma'am, for your excellent deliberation. We, in our part of the country, require a lot of lead restrictions, but in most of the cases, we are helpless and keep the leads within the heart and go for newer implantations. So what I could gather from your talk is that we have to have hybrid labs for that, where the surgeons should be prepared and we should be well prepared for a bailout surgery. So
definitely, yeah.
So it has to be, as you have said, that it has to be done under general anesthesia and the surgeons around to help us out in a case of emergency. So it is definitely a very good tool that can help our patients who can afford, because leaving no foreign objects within the heart should be our goal. But at times we are compelled to do so. As the technology is involved, we are really looking forward to use this technology.
That's great. And I can really say it's really mandatory also for the patients, because we know meanwhile that if there are more or equal to 4 leads inside, the risk of infection is much higher.
Professor Oswald, look, you can perforate a vein if the vein is collapsed, is adherent. Do you recommend the distension of the vein by making hypervolumic state, like giving a lot of fluids, so that veins are stretched out from your laser zone, the sheath zone, so that the chance of perforation, the laser touching the SVC in RA junction, where the most of the perforation occurs and is devastating. So do you recommend routine hydration, not only hydration, overhydration, so the volume loading of this patient before you go with the laser, or it's unnecessary?
Yeah, unfortunately, many colleagues try to do it, and they just do 1 or 3 cases, perhaps a month. I think this is quite not enough. You should have at least 30 per year in your center. And furthermore, there are some equipments available, like a super stiff wire and a balloon, in case of SVC perforation, which makes it much more easier, even for the cardiac surgeon, to overcome the problem of SVC tears, which is the most common complication. It is about 68% of the perforations occur in the SVC. However, the overall complication rate is quite low. We are talking about 0.4 to 1.5%. And this is really, yeah, but if you have larger series, it's much safer, definitely, because the handling is quite something you have to learn. And this differs from case to case. And therefore, I also recommend not to do just one by case, or if you just have a laser on site, just try to do it. This is not the way to do. You're completely right. I agree.
All right. Thank you very much, Professor. And we'd like to thank you from bottom of our heart for your huge contributions to our small conference. And it has given a lot of message, and many complications can be prevented if you follow the algorithms. And we'll learn with your new technique and new device like laser for lead extraction. Thank you very much once again. So we'll go thank you, sir. Raman, are you there? We'll go to Raman, then we'll go to Dr. Manoj Chopra's lecture. First Raman, sir. First Raman. Raman is waiting. Can you connect to Raman Chawla, please? So Raman is going to speak on role of guiding catheter extension in complex PCI.
Hi, good afternoon. First of all, I'm thankful to Eastern Society of Cardiology for having me here, and Dr. Hazran Akmande and organ secretaries. Today, my talk is basically role of guide catheter extension in complex PCIs. Excuse me.
Next slide.
These lot of guide extension catheter, because as the time has progressed, patient age community is increasing. We have a lot of complex lesions, including left ventricular dysfunction, chip category, and CTO subsets. And these all complex procedures will require special gears, and one of them is guide catheter extension catheters. Believe me today that one of the topmost intervention points in cardiology is one being the guide catheter extension, CTOs, or other complex lesions. The concept of guide catheter extension lies in the increasing guide catheter support, whatever they might be. And to increase guide catheter support, one of the methods is guide catheter extension. It's a simple tool for providing additional backup support, improving access to complex lesions, especially in case of inadequate backup support, difficult coronaries, angulated vessels, or calcified vessels. The common use of guide catheter extension, everybody knows, is distant delivery within a tortuous calcified vessel, or failure to cross a calcified region with a balloon and or stent. Inability to properly engage a guide catheter, especially in case of native aberrant vessels or post-bypass surgery or post-top V lesion. Distal stent delivery without injuring the proximal vessel, and proximal stent distal vessel stenting. In addition, we have to have additional advantage of using catheter extension is maintenance side branch wire during multivessel rotation atherectomy. And not only that, it enables OCT imaging of aorto-osteal lesions, including that super selective injection into a specific vessel for better evaluation, specifically renal failure. And this is that we can do aspinctometry also. As far as CTOs are concerned, uses are basically same as in complex lesion, which can be integrated together. Obviously, integrated means it increases support, initial wiring or initial gear delivery. In addition, uncrossable lesions as in complex lesions. Specific use for guide catheter extension in antegrade is facilitate AGR and stingray balloon delivery for antegrade dissection re-entry. As far as retrograde dissection technique is concerned, it increases retrograde support for gear delivery, for microcatheters, for microchannels, for all microcatheters. Also in CTO and bifurcating lesion, especially in osteal LAD. Suppose you have an osteal LAD lesion and LCX need to be prevented, need to be protected, then we can use this guide catheter extension. It facilitates reverse cart technique. Also, if you want to use a single guide catheter for ipsilateral collaterals, then you can use guide extension in that. Suppose we have 8F guide catheter, and you can use for a 6F guide extension catheter in that to use technique with a single catheter. As we use guide extension catheter, but deeper we go in, that there's an increase in the support so much so that if you go by 15 millimeter deep into coronary, the support is equivalent to 8F guide. Basic concept of basic for this guide extensions are GuideZilla, Gujia, Telescope, Guide Plus, and I'm going to discuss two specific catheters: Expressman guide extension catheter and trap liner. Basic concept of any guide extension is a rod, and then there's a collar, then there's a semicircular and the circular tube, which is flexible guide extension goes into that arteries. Now, Expressman guide extension catheter is a specific extension catheter which has two advantages. One, the circular tube is longer, so that the collar lies either in the subclavian artery, or that it does. If you go for femoral route, it does not lie in the arc of aorta. Second advantage of Expressman catheter is that it has twin hole. It can perfusion holes are there. There are 4 holes at the Expressman catheter, and the other specific extension is trap liner. The trap liner has 2 advantages. One, it has a trap balloon over it, and it works as a guide extension catheter also. In addition, it helps in tapping microcatheters when you're using CTOs. If we need trap line tapping along with guide extension, then best guide extension is use trap liner. If we use only for the support, then we have the guides. The other things that are better than guide trap liner, guide extension. This is how the trap liner works when you inflate a balloon. This balloon is proximal to that semicircular tube. And how to use guide extension. One of the ways either tracking on wire, which is not a good technique because it can cause injury to vessel. Second is balloon assisted tracking. And that is what we inflate a balloon at the top of the guide extension and push it slowly and toto, especially if you're crossing across a stunt. So this is a guide. This is what is called as guide assisted tracking, balloon assisted tracking. The anchoring balloon technique is we inflate a balloon distal to the distal, and then we push the guide liner extension catheter over it. This is called the anchor balloon technique. Specific technique which is very useful and does not cause any harm to coronaries is inch warming. What does it mean is we inflate a balloon at the tip of guide liner, and once balloon is being deflated by an assistant, you can guide liner distal. This is how it's being used. If you see carefully, 2 wires already in coronary, still was not going in, so you needed a guide liner extension catheter. So we inflated a balloon at the tip of the guide liner, and then while balloon was being deflated, I pushed that guide liner into it. This is called as inch warming tip. One of the advantages of using guide extension is suppose you have circumflex artery which has multiple lesions, very tortuous vessel, large vessel, and you need to selectively go into the circumflex artery to see the type of lesions, especially by renal failure. Then you can use guide extension catheter going into a specific branch. Other thing is, this was a patient who had, while the stent was being deployed, when I was trying to inflate the stent, the stent did not inflate, and dye started leaking from the guiding catheter. It means probably there was something wrong with the shaft of the stent. Now I need to take the stent out. I was not very sure that this stent has been expanded partially or not, so I need to protect it for this stent. What I did was I covered the stent and eyeliner over it. So I covered this partially expanded stent or so not expanded stent with the guide liner to push it back into the guiding catheter. The thing is, when you have a lot of tortuous vessel, you see carefully, even if I have used the Amplus catheter for the right coronary lesion, vessel is so tortuous that balloon was not going there. You can see the nerves, you can appreciate tortuosity very well. And this guide liner helped to put the stent in that particular location. The thing is unsheathing the stent. You can stent distally and then unsheath the stent by withdrawing the guide liner back. And you can stent. There will be a useful indication for this extension catheter is suppose you have normal right coronary artery region. When I was doing angioplasty, somehow the guide catheter got disengaged from the abnormal region of right coronary artery. We could not advance the stent and balloon. Then we did was the guide liner deep into the coronary artery. It entered into the abnormal region of right coronary artery, and then we were able to stent right coronary artery this guide liner. This is how the stenting was being done. The swan neck support for the guideline for antegrade CTO. Patient has CTO when you are putting JR catheter. JR catheter was not giving sufficient support. What we did was with a guideliner with the support of balloon, and we put the JR catheter deep into it. That becomes it looks like amplazer shape. It was actually JR catheter. It was called swan neck support for the CTO lesions. Not only that, we can do thrombosuction with guide catheter extension also. This is right coronary artery. It's guide catheter extension distally, and you suck from the guiding. Whatever you're going to suck from the guiding, it also has to come from the guide extension catheter. And this is after suctioning with a thrombus of guide extension. You can use guide catheter extension also for making a snare millimeter balloon at the tip of guide catheter extension. Then you can trap the wire. You can put the pull or push the wire, so you can shape of the it can be take different sizes of the snare can be made. If we have a stuck balloon or stuck rotor, we can cut the hub of rotor and then put the guideliner to that. Now, as far as guideliner support for antegrade CTO crossing is concerned, we need guideliner so your balloon doesn't cross. In addition to antegrade support by the guideliner, subintimal hematoma prevention is also useful when you're using antegrade distal and ADR technique to enter into coronary artery. If you're deep sitting this guideliner, the pressure into that subintimal space is less, and then you can prevent hematoma formation in the subintimal space, and you get entered into the artery again. This is how it's being shown. The ADR technique filled ST wire guideliner deep into it prevents subintimal hematoma. Guide extension retrograde PCI is useful for equipment delivery, whether you're going from donor artery. If you want to put the microcatheter deep into the donor artery and septal branches, you can take that guide extension. Obviously, for the coronary engagement too, and it is very useful reverse scar technique. I'll demonstrate that how to use that. This is how the wire is being in the coronary artery, so that the route and the distance traveled by the retrograde wire to the guiding is less. You put guideliner into it, and wire can be traversed to the guideliner, and the distance to be traveled. How the wire is being into guideliner extension for the technique for reverse scar. Increased port of retrograde guide delivery for the microcatheters. You can use the guideliner so that microcatheter can further via the collateral channel septal to enter into this artery. Special techniques, special reason for using the guideliner is when you have an ostial LAD lesion, and when you're doing retrograde technique, your wire might come into LAD, but it might dissect left main coronary artery. And once your wire dissects left main coronary artery, you're going to occlude left circumflex artery. So what you do is with the guideliner into the LAD and do reverse scar technique, and so that left main is protected, and you don't get dissection, then LCX is protected. If at all you want to use it for a technique with a single guiding, obviously ping pong guiding is the best technique available. But if you want to use a single guiding technique, what you do is that you take 8F guiding catheter. Along with that, you take 6F guide catheter extension into the 8F guiding catheter, and you can trap this wire from the homocoronary collateral into the guide extension. Can be helpful, but it's a slightly more cumbersome technique is ping pong technique. Guide catheter extension have come in two, while it's being advanced or while being withdrawn. So while you want part detection by the guiding, do not advance the guide catheter bare on the wire. It has bare back over the 014 wire. It has razor effect. Always advance guide catheter extension over the balloon shaft for the more support. Especially I told you that the inch bombing technique is best. If you have a resistance in pushing the guide catheter extension, please don't force it. You use inchworm method for the pulling the guide distally. Do not inject via dampened waveform. Obviously, if guide catheter extension in a small vessel, do not force for catheter forward. This is how the guide catheter extension can produce a section of the proximal proximal LAD. Be careful when you are trying to push that equipment on the wire, because wire might wrap around that rod of the guide catheter extension. If you see carefully in this patient, when I was trying stunt into the patient, the wire was wrapped around the guide catheter wire rod, so it did not go forward. You want to rewire, suppose you want to have guide catheter extension, you want to put one more wire for the additional wire balloons, additional support or anchor balloon support. be careful when you take the wire. It might go between the space of guiding catheter and guide extension. The size difference is high. So once you're the wire, careful that your wire is not spoiled at the hinge point, and not only that, your wire doesn't go into space between guiding and guide catheter extension. So once stunt is being pushed into this collar, careful that you can damage this stunt at the collar hinge point. This is what happened in one of my cases. Ischemia is one of the reasons, one of the limitations of guide catheter extension, except in Expressman, which has multiple holes, twin holes that prevent ischemia. Embolism also possible. All conventional are basically because of transitional zone is there, that now the new advancement of this guide catheter extension basically comes in half semicircular tube, and then the tube, and this collar is initially used to be metal collar, now it's a polymer collar. This prevents entrapment at that point. Avoiding equipment damages is retract the collar out of the tortuous vessel. As I told you, the Expressman has a longer circular tube that collar does not lie in arc of aorta, it lies proximal to that. So either you retract collar out of the tortuous segment when delivering the stunt to the minimize interaction, or you introduce the stunt into the guide catheter extension outside the guide catheter, and then you advance both together. Avoid wrapping of this wire along with that rod. Complications are obviously there. Other complication of catheter fracture. The most important limitation and complication is coronary artery dissection. And in spite of sometime this guide catheter extension, you cannot push a distally. Guide catheter extension tips and tricks are: push rod must, once you put the guide catheter extension, push rod must be kept separately. Try to keep it under a towel. And once you are delivering the guide catheter extension, please use inch warming technique instead of bare advancement of the guide catheter extension. And whenever you want to advance any gear into guide catheter extension, please do under fluoroscopy, and do not advance proximal collar outside guide. Trapping is difficult in patient of guide catheter extension, except in patient where you're using trap liner. So proximal release stunt is feasible, and the charges that if you are using this type of guide liner, a balloon stunt can be crossed across this collar. So message is guide catheter extension are essential tools for all complex coronary lesion, especially in the CTOs also. And the new advancement in guide catheter extension of Expressman, which has twin holes that causes perfusion distally, also reduces ischemia. And they are indicated in all complex regions, including anterior retrograde approach, increasing success rate and reducing complications in such complex cases. But we should be very careful that complications do happen in guide catheter extension. You must know each guide catheter extension before you use it, what is limitation, how is the size, and where the long circular tube, semicircular tube lies. So your patient sharing. I'll be here to answer a few questions.
Thank you, Dr. Chaulab, for your extensive presentation. What thing came time and again in your talk is the inch forming technique. So
yeah,
we have a lot of youngsters present in the hall. Can you please demonstrate the sequence of this? Because this might be very useful for us. There are various guide catheters, the Hytrail to the Heartrail to Expressman that you have mentioned, which are not available with us.
Expressman not available.
Not available with us. We are left with GuideZilla and GuideLiner. So at times it becomes very difficult to inch forward this guide extension catheters into the artery. So if you can demonstrate a little bit about the inch warming technique, this might be
see, best technique to advance guide liner is inch warming. We should not advance the guide liner on a bare wire. Sometimes it's very difficult to advance on anchor balloon also. Inch warming technique makes it very easy and very safe. What we do is we take 2 millimeter balloon and inflate at the tip of the guide catheter extension, partly inside the guide catheter extension, partly outside it, into the vessel. So once balloon is inflated, then you tell the assistant to deflate the balloon. Once he is deflating the balloon, at the same time you push guide catheter extension into it. So it basically acts as a dilator. It makes it flexible, it goes distally. So in that way, you can push a guide liner 2 distal inch by inch. You can go 1 by 1 by 1. It might take more time, but it's very safe, and you can push just as much distally as possible, because this technique helps a lot in preventing complication too.
So if there are no questions, I ask Dr. Manoj Chopra to have his deliberations. Dr. Chawla, we will be happy if you stay with us.
Yeah, thank you, dear.
Not that other one. Adha, this is not the presentation. Go down.
So next session will be on robotic PCI.
Hi, friends. I think intervention or angioplasty in last 10 years, there has been tremendous change in the hardware and the software. And as we have shifted from a simpler angioplasty to a complex angioplasty and trying to use a newer technologies, I'm going to present you one new technology that's a robotic arm for the PTCA. It's a CorePath GRX. I think that's been taken over by the Siemens, and that's basically a console where you can sit and do movements of a guide catheter, guide wire, and the balloon and stents. And this is the robotic arm, which is along with the patient's hand or a groin, and that you have to fix. As we all know about the PCI, that whenever we want to do angioplasty, I think we assess anatomy. Here, whenever we are doing a plastic, I think we stand 4 to 5 feet away. Here you are sitting and the monitor is in front of you. Navigation of wires is much better with the robotics. Anatomical measurement, visual, and with robotics, that's really good. Sub-millimeter measurement can be good done. Positioning stent becomes easier. And as guide catheter and wires can be fixed, deploying the stent becomes easier. Procedural automation, I think artificial intelligence is playing an important role in our medicine field. And here, one of the application in rotate on retract while wiring the wire, that I'll come forward about that. And most important, whenever we are talking about angioplasty, it's a robotic precision. So precision, how does precision impact patients? One is the inaccurate lesion assessment, longitudinal geographic miss, or the sizing of the stent or a length of the stent, what we study, and we are missing out on that. As here, there is a sub-millimeter measurement to determine the lesion length and appropriate stent. 1 millimeter positioning of devices in, I think, the ostial stents, it's very important. And guide catheter and wires can be fixed so that the movements of the stent will be less. This is the one case, visual estimate was almost 40 millimeters, but the robotic gave us around 28 millimeters. The size of the stent was reduced. I think the most important thing about the robotic is the protection. We all know about the cath lab procedures. We are doing complex procedures, CTOs, and there the orthopedic problems are more because we have to wear the gowns, we have to bend, and that long standing is causing the almost 60 to 70% cardiologists are having a backaches and the orthopedic problems, increased risk of cataracts. And there is a saying that the neurological tumors also the increased risk because of the high radiation. So 95% radiation reduction to the physician when using a CorePath robotic system. And that's the most important thing which can change the patient management also. And I think about the cardiologist safety. And not only the cardiologist, but along with the staff, their radiation can be reduced. Because once you are trained, our team is trained, only one person can be inside the cath lab and you can perform the procedure. This is the lower patient radiation also, because if you are able to reduce the time of the procedure, and if you are if you learn the techniques and if you can do the procedure in a shorter time, I think the less radiation to the patient also. Radial applications, complex applications. This was the one Cora PCI trial where 108 robotic PCI, 226 manual PCI, and that comparison showed that Complex coronary procedures also can be done very well, which I'll show you what cases I have done. As I talked, radiation exposure, orthopedic strain, but I think that when there is a left radial axis you have to use, I think robotic scores over the manual. You don't have to bend, you don't have to do anything, and you can do a procedure very well. As we talked about the robotic advancement, it was only initially type A lesions. We were doing it. Remote capabilities are there where the intra-city demonstration is there. And most important is the prescriptive analytics. That is the basically artificial intelligence related addition of the wire movements, which has occurred recently 6 months back. And that I think had changed the angioplasty techniques. This is the slide, please. This is a case where you can see that because of tortuosity you are not able to wire it. And here rotate on retract technique has helped us to wire. I'll show it that. This is the artificial intelligence where the different wire movements has been introduced. And this is going to change the CTO management or a tortuous vessel management where you can sit and do the wiring, which is the most difficult part. Or in CTOs, you take a lot of time in standing in a cath labs. One is the rotate on retract, which was a function there. And I think the many times whenever the simple angioplasty, there are a lot of side branches, wire tries to go into the side branch. And here rotate on retract, you just push a button, it will come back, give a different angle, and you can enter the wire and keep it distally. And that reduces the lot of time. Second is the wiggle movements. It will be many times the tortuous anatomy, which I showed you, wire was not going in. Here the wiggle movement will help us to pass the wire in a tortuous anatomy. And basically complex cases and difficult anatomies, we all are using a spinning movement, clockwise and anti-clockwise movement. Now with a button, and once you activate the spin movement, the wire can be moved by a spinning movement, and that helps us in CTOs. In last 3 months, we have done around 14 cases. For 11 cases, we succeeded. There are 3 cases, distal cap, we couldn't do it, where we shifted to a manual. Then again, the daughtering movement. Most of the proximal or distal caps, we have to do a daughtering or a constant speed maintenance. That's a 2 millimeter per second or a 3 millimeter per second can be achieved with these wires. And that is going to be a real changing era for the treatment of the CTOs by a robotic arm. This is how the what wire which I showed you, the wiggle movement helped us to just pass the wire through a tortuosity and kept it distally. This is the one bifurcation lesion which we did. And that was, we can see that the post CABG patient wall replacement was done, and it was a left circumflex, and the OM1 bifurcation lesion was there. Here we used the wiggle movement and the spinning movements to put the wires distally, and it shortened the time, and then we dilated the balloon and completed the bifurcation lesion. See, this is what the spinning movement, what we used for the OM cannulation, and you can see the wire is getting moved and the lesion is getting crossed. And this is just with one antegrade movement of a joystick. Till now, I have done around 325 cases. Initially, we started with the type A lesions. It was a 50 cases because you had to train our team how to use the cassette, how to load the cassette, how to load the guide catheters wires. And I think then we moved on to a long segment lesions, bifurcation lesions, and recently we have moved to a type C CTO lesions, and which is a territory which is going to be a challenging for us. This is the robotic PCI in action. This was a one long stand 60 millimeter, which was put successfully. And this has been reported as a first case in the world, and Asia Book of Records has been reported. This is the cassette which you can see where you can load the wire guide catheters. These are the rotators, what we can see. This is the rotator for the balloons. This is the rotators for the wire. There is a slot to load the wire or the balloon. Because of the age, many times you are not able to put the wire balloon over that. There is a slot given which makes us easier. This you can see a balloon is been placed properly through the rotators.
And this is the Abbott Y connector device, which we use it to attach to a catheter and then put a wires and balloons. So there is a turbo button where once you lower the balloon, you can see the movement of the balloon going from a distal tip to proximal tip in 2 to 3 seconds. These are the 3 joysticks. The green joystick is for a guide catheter engagement. Middle is for the wire, and the third one is for the balloon and the stents. See, you can see it, monitor is just in front of you, and the guide catheter engagement, initially we were right coronary artery becomes very easy. Left coronary, it's difficult, but over the time we have learned about how to cannulate the left coronary artery. This is a long stent robotic PCI, 65-year-old female came with an inferior MI. She was thrombolized, but persistent pain came in the night. And when we did a angiogram, and after passing the wire, you can see a very long segment lesion. I thought that we can fix the catheter and wire very well with the robotics, and long stent, which we had to use, was a 60mm stent, and which we could do it successfully. So STEMI patient coming with a complication, shock on NORAD, and the creatinine on higher side, very minimal dye, and we could deploy the 60mm long stent easily. This is a 46-year-old male, again with an inferior MI, 100% occluded RCA, and that was done successfully. That's not moving properly. Slide down. No, it's not moving. I think it's not playing. No. This is the ostial LAD. As I said, that whenever we are treating ostial lesions, I think again the slides not going to play. This was a LAD ostial lesion. LAD ostial lesions, I think whenever there is no Lepman involvement, Circ involvement, and we want to do a ostial stenting, I think the 1 millimeter movement with a button is very easy. When we do a manually, we do it, lot of views taken, lot of dye injected. Here with 1 millimeter forward or a backward movement, and you can deploy the stent very well, ostial stents. And that's where I think the ostial stenting robotics scores over the manual stenting. This is the time which we took initially, a lot of time for the 50 cases, but over the period of the time, I think the manual PCI comparison and the robotic PCI comparison, many times we thought that the type A, type B lesions wiring was easy with robotics than the manual, and whatever the radiation time, which also decreased over the time. And I think the one is the CTO, which we have started now doing, that is going to be the sore area. This was the one patient, which was this is the CTO lesion, which we did a right coronary artery, almost more than 20mm length. From LAD, there were a lot of collaterals from the circumflex. Actually, patient had come for anti-wall MI. We did a PAMI, and the RCA lesion was taken as after 3 days. See this now, you can see we are engaging the right coronary artery catheter with a robotic arm. It's again the antegrade, retrograde movements, clockwise, anti-clockwise movement. You can all do what we do manually was done with the robotics, and the catheter was cannulated. Initially, it was the BMW wire, and when we tried to push the wire the artery, everything came out, and again we had to re-engage, and we took across it 200 wire. And then you can see very slowly the spinning movement was used by the robotics, and slowly we could enter the proximal and the mid part, and distal part was difficult, where we took a support of a 1.2mm balloon, and we could cross the wire. And this is how it was done with the robotics. Cross it 200 wire. What happens manually, the same way what you have to do is with the robotics, you have to expect the catheter backing, the wire coming out, and again re-engaging that. And this is what we faced in this case. But I think it was successfully cannulated, re-engagement with the robotics done. Then we took a 1.2 balloon dilatation, then 2.5 10mm balloon dilatation. We did a OCT also in this. We have to do it manually because there is rotators which can cause the problem to the catheter. So it's a manual done. You can see that it was a long segment lesion. We did a sizing. It was distally 3.2, proximally it was around 3.8mm. Accordingly, we took a 3.5 38mm stent and positioned it. You can see it is very well deployed. We dilated with a 3.5 12 balloon, and the artery was looking good. Post stent, we did a OCT again. But again, in the proximal part, we thought that the stent was not expanded properly and apposition was not good. So what we did was took a 4O at 12 millimeter balloon, and the mid to proximal part was again dilated, and this was the final shoot. So this was a CTO RCA done with the robotics, multiple balloons, difficulty in passing the wires, but succeeded and completed the things. Yes, this is what the console where you can sit. There are the 3 joysticks. It's like a playing the game. That's a guide catheter, wire and balloon. And then the robotic cassette where you can train our technician nurses for loading the catheters, wires, and you can sit and do the procedures. I think this is a newer technology. Very few centers are doing it. In India, I think I was a second center in India, first in Maharashtra. It was 10th in the world that time. Now I think there are 4 robotic centers in India. 325 cases I have done till today. And one of the most challenging thing which is there in angioplasty is the CTO lesions, longer time, longer stays, and the orthopedic problems. Here, I think it's going to really help us, or it's going to be a game changer for the CTO lesions. Long stents, bifurcation stents, I think tortuous vessels, robotics course over the manual, but I think we'll need more and more people doing this, more data for this, how we can reduce the time, how we can reduce the dye, and how it can be it's a safety for cardiologists is very good, and how we can increase the patient safety, that I think time will tell us. I thank CSI Eastern India for giving me this opportunity. I thank Dr. Hazra. Thank you very much.
And Dr. Chopra had highlighted one thing, that when he started the thing, he started with type A lesion, but the 350 cases, that almost 300 cases are now done by him, is more than type A. So this is a very important thing. We cardiologists are quite energetic, but we don't think of ourselves. That is the last priority for us. None of the labs have proper radiation safety. So we should be thinking about our patients, but at times we should be thinking about ourselves also. The other thing is that Dr. Chopra was saying that there, day in and day out, we face one problem. And we are probably thinking of going for one study there. How many stents are really left at the LAD ostium? In most of the cases, it is seen that it is halfway through the LCX ostium, and this invites future LCX ostial stenosis. So that will be a great way. Robotics become so precise in placing the stents. And the other thing is that, sir, when where we face a guide cath coming out, is the do you have to do it manually by the joystick, or the artificial intelligence senses that how much pressure it is to be given to keep the guide cath engaged at the ostium of the
I think it's the same way what we do manually and what we see visually, that the guide catheter has been fixed or not. The same way you can see that it's been engaged properly or not, wire movements and the guide catheter movements, we can sense that. At present, the guide catheter movement or the wire movement can be fixed, but how much pressure or how much it's moving, it's difficult to tell by the robotics. It's only artificial intelligence, wire movements, they have given us the AI, but for guide catheter and for that, it's not still been given there.
Okay. So it is very important that we are being to be able to negotiate the wire through the CTO lesions as well.
Yeah,
thank you, sir.
I think that's the one new area which is going to be a game changer for the robotic PCI, I think.
Just one moment. I wanted to know, when you pass the wire or pass the stent and inject dye, it is from the console outside, is it?
No, it's not from console. It's from the technician or the nurse who is doing that. She delivers the dye.
She will inject the dye?
Yeah, she will inject the dye.
And how much dye is injected is instruction is given to her, or?
Yeah, I think we need to train our team for that, how to do that, because aspiration of the blood, there is no air inside. That all care we need to explain to them and try to do that with them.
Okay.
I think to learn robotics better, you have to go to his center one day.
Yeah, I think we can have a robotic PCI
Yeah.
workshops, and I
Yeah.
welcome you all. And if you have something, anyone interested, please let me know. Definitely we'll arrange a workshop where we can learn
Yeah,
from
that is the
each
best
other.
way to learn know-hows of robotic PCI. Yeah.
Go there.
Yes.
Yeah, I think I'll call you both for doing a workshop. And last month we had a robotic PCI workshop, and almost 20 young cardiologists came to my center and we demonstrated them. So similarly, I think we can arrange more programs for this.
Right. Manoj, thank you very much. And we have
Okay,
finished this.
right after.
Yeah.
Okay, after having a great discussion on PCI, we're moving back because someone very special, Dr. Arijit Ghosh, is right here. So he will discuss non-crossable lesion. So I would request Dr. Ghosh be on the dais. Thank you, sir.
Respected Dr. Hajra, and I at the outset thank the organizers for giving me this opportunity. I don't want to stand for a long time between this lucky draw and your lunch, so I will be brief. It is basically an illustrative sort of presentation. So when we get stuck and nothing goes through the lesion, that is known as non-crossable lesion. That is, we have wired the vessel, but nothing goes. No additional hardware goes through. This is what is defined as a non-crossable lesion. So many of the things have already been discussed by Dr. Raman Chawla. There are scopes of guide extensions. So I will be just sticking to the basics because sticking to the basic is equally important. So when you have a balloon crossable lesion, the first thing that you should be keeping in mind that the vessel, that the wire is in the true lumen distally. So this is what is to be confirmed first. So when there is a balloon crossable lesion, we have various options. We can improve the support, we can modify the lesion, or change the deliverability of the device that we have. So this is the basic algorithm that we follow when we find a balloon uncrossable lesion. It is not that you have to start from point 1 and end up in point 8. There might be certain modification according to the need. So the simplest thing that we can do when we encounter this sort of balloon uncrossable lesion is to take a smaller profile balloon. So what are the balloons available with us? There are various balloons which have a 1 millimeter diameter, lower crossing profile. The Nick Nano balloon has come up with great vibration. We have Sapphire Pro. The standard balloons that we use in the cath lab are predominantly somewhere between 1.25 to 1.5. So there are various balloons. Two things are important. One is the diameter of the balloon, and the other is the entry profile of the balloon. In that regard, Sapphire 2 is the lowest profile balloon in our armory, followed by the Nick Nano balloon, though it is of a lesser diameter, but the entry profile is better with the Sapphire balloon. So there are various other threader balloons, which has a higher shaft that makes easier for the crossability, but probably we don't have these devices day in and day out in our regular practice. And when we encounter an uncrossable lesion, these things will not be with us. So what if the small balloon does not go? So we have a technique known as balloon wedging or nose diving. That is, you take the balloon, the shorter diameter balloon up to the lesion, then you inflate it and you deflate it and try to push the balloon when it is in a deflated state. So this is known as balloon wedging, which modifies the proximal cap of the lesion. We can rotate the balloon as we do when we use cutting balloons. We rotate the blade and change the orientation. That might be helpful in crossing the device through the uncrossable lesion. We can reshape the balloon even. We can take out the balloon as we do when our wire does not pass. We just change the shape of the tip of the wire. We can do it with the balloon as well. We can take out the balloon, change its shape, and try to go in. Large balloon inflation proximally might change the lesion. You take a 2 balloon, try blow it up at a nominal pressure, try to have some changes within the proximal cap, and then you try to negotiate your smaller balloons further. This works. That is sustained pressure over the balloon. You just be patient, take the smaller profile balloon, have a sustained pressure. At times it works, it crosses the lesion. So you should not be pecking the lesion. It might be a sustained pressure that might play the trick. So what can go wrong? You can have a loss of guide care position. You can have some ostial dissection while jutting your balloon through the uncrossable lesion.
There might be distal guide wire perforation if you are not very aware of the distal position of the wire, and there might be balloon entrapment as well. There is something known as granuloplasty. Granuloplasty is to deliberately rupture the balloon within the artery. So this is usually done with a 1 to 1.5 millimeter balloon. We should be preparing the balloon well, so there should be no air within, because when the balloon will rupture, there might be air embolism in the artery, and that might create a havoc. So that as we have ruptured the balloon, we got to apply suction if required. We should not be using any balloon which is more than 2 millimeter in size. So what can go wrong with granuloplasty? There might be air embolism, there might be coronary contrast dissection, or there might be coronary rupture in the worst case scenario. So this is a short video which shows how granuloplasty is done. Granuloplasty, the balloon is taken, and we've deliberately ruptured the balloon within the coronary arteries. But I feel most of us don't do these things. These are more things mentioned in the literature, but in the day-to-day practice, we don't dare to do all these things. So the customary name of granuloplasty is balloon-assisted microdissection. We invite a microdissection, and that helps us in negotiating the wire or the devices that we are intending to pass through. So if there are, if could not manage by increasing, by passing through a small balloon, we next try to increase the support. The increase in support can be by using the long sheath, the larger bore catheters. We might be having supportive catheters like AL1 or RCA1, AL1 for the RCA and EBU and XBU for the left main. It might be a deep intubation, and we might be requiring guide extension as well, which has been dealt with Dr. Chawla. So these are the various guidelines, guide extension catheters that we use in a day-to-day practice. There might be other ways of increasing the support to the catheter. That is, we can anchor the side branch with a balloon inflated in it and try to increase the support of the guide catheter to the main vessel. There might be power guide extension. These are things that we should remember, because if nothing works, we can take a ping pong technique, take the guide catheter extension to one of the guide caps and take another wire and balloon through the other catheter. Then we can inflate the balloon and press the guide extension catheter against it so that we get some extra support. So this is also one of the rare things to do. We can place a stent at the proximal segment of the vessel, jail the body wire so that it gives us an extra support, and then we can pass our devices through the stented segment of the artery. So if this does not work, we can go with microcatheters. There are various microcatheters that we can use, the Corsair, Turnpike, Mamba, and the smaller profile catheters like the Fine Cross, Caravelle. These are also very useful when we have nothing crossing the lesion. So this is a wire cutting technique where you take two wires and a balloon, and you inflate the balloon over the wire that you have taken. You try to modify the plug. Basically, these are done to modify the plug. You can take two wires, two balloons on each of them, one balloon on each of them, and keep on dilating the balloons one after the another in an alternative fashion. It might also modify the proximal plug, which might help us in negotiating the hardwires that we are wanting to do. Laser and atherectomy. The beauty of laser is, as it was discussed in the previous session, that it can be moved over the workhorse wire. You don't require to change the wire as you need in the various atherectomy devices, that rotational atherectomy or orbital atherectomy. You got to go for specialty atherectomy wires. And the other thing is that if nothing crosses, laser can cross. For the basic premise of using the atherectomy device is that you have to change the wire over a microcatheter. But if your microcatheter also does not cross, it is better that we take a laser to cross the lesion. The other thing is that orbital and rotational atherectomy, this can be discussed later. The thing is that if we are left with no option, then we go for more aggressive form of negotiating the wire, that are the subintimal techniques, which are basically CTO techniques, but at times we have to do it in the vessels which are flowing. So this is the scratch and go. We try to take a heavy duty wire to go subintimally and reach the distal part of the vessel, and then by a microcatheter we exchange it with the regular wire. We can go for balloon assisted subintimal entry as well. This is a balloon which is proximally dilated to invite a deliberate dissection on the vessel wall, and then we can take some micro polymer jacketed wire over the microcatheter to negotiate the distal part. So whenever we have managed to cross the lesion subintimally, we can do two things. One, we can deploy the stent in the subintimal space, or what we can do is we can take a balloon and take a balloon through the subintimal route, anchor the vessel, and through the wire which is in the main lumen, we can take the devices that we intend to take it. So to conclude, I should say again that uncrossable lesions are not very uncommon nowadays because we are attempting more and more complex angioplasties. And the other thing is that we might require combination of the various ways of negotiating the hardware to a non-crossable lesion. And at the outset, I've said that it is not like that you have to start with one and end up with 8. You can just rearrange the possible ways of negotiating an uncrossable lesion according to the necessity and according to your expertise and according to the gadgets available with you. So with this, I end my talk, and if there are any questions, I am happy to answer.
Thank you very much, Dr. Ghosh. I request Dr. Ranjan Sharma to come forward and make a comment on this.
Initially, in my early days, it was quite a difficult problem. Many of the times we passed the wire, we just had to leave the case because the guide extension was not there. So I believe the guide extension remains the number one and the safest technique till now. Changing the guide. So if you have a lesion which is not crossable, you just cannot change the guide because you have passed a wire with a lot of difficulty and then taking another guide. It remains. So for the juniors who are attempting, I will say the guide extension is the safest technique. And the lowest profile balloon is another. We have now 1x5, 1x10. These balloons.
Neck balloons are very costly in that sense. When that is a provision, but it is very costly. If I'm not wrong, it costs around 50,000. That is a major hindrance in our part of the country, and the cath lab is cost issues.
So, do you have the experience of crossing subintimal and then coming back to lumen?
Now, once my wire is through the lesion and then going subintimally, I have never attempted. So these can be discussed.
No, I am not that daring. I haven't honestly tried, but this is the way that we can go forward in dire situation, because this is a CTO technique, basically.
This
in a
can
flowing
be-
vessel, attempting a CTO technique requires a lot of guts.
So this you can do only.
Have you got the laser in your center?
No. How is it possible?
I'll tell you one very funny experience. Young man got an angioplasty done outside. After about 6 months, he came back to our center. I was there in Dishan there with angina, and we did an angiogram. There's total occlusion. It was in the RCA. Total occlusion of the stent in the proximal RCA. So I said I will try and see if I can open it. Crossed the stent, crossed the lesion by balloon, inflated the balloon, but then there is no antegrade flow. Till now, I have kept the CD. Sometimes I'll show you in one of the meetings. And I have tried different balloons, including non-compliant balloons, but there was no antegrade flow. Withdrawn the wire, wired again, and then found that after trying for about half an hour, I said it cannot be done. So I do not know how to explain it.
No. The thing is, once you have passed through the lesion and after dilatation, you are not seeing the flow. Then you should change. You take a microcatheter, take out the wire, inject. You might be all throughout in the subintimal space. That is not very
Maybe.
uncommon. All throughout, you are from the beginning to the end of your catheter, and it is on the wall. So you'll feel that the wire has gone into PDA, is going into the PLV. But it might be that is all throughout the subintimal space. So if you take out the wire with a microcatheter and then inject, and then you can see. Maybe you will be able to know.
This might have been done. This could have been done. But in my wisdom at that time, I thought without landing into complication, better manage him medically, RCA. and left system is normal and flowing well. So I'll bring it maybe this Saturday if I can find
And
it.
the next
The
time
CD.
that you could have done, you take a left shoot also at that point of time. You can see a collateral and then you can see whether the vessel which is filling to the
No, the
collateral.
collaterals are not seen. That was the
If it is there, then it will help you whether you are in the.
neither no retrograde flow, no antegrade.
So one thing to increase even the guide extension support, Dr. Chawla was saying about the inchworming technique and the balloon anchor technique, which is very useful.
Yes,
At times
balloon-
it is very useful.
Yes, yes. Balloon anchoring is really useful, but the problem is you have to take a appropriate size balloon in the side branch. You have a risk of avulsion of the side branch. You should inflate at a 2 ATM only, not a very high inflation. So the side branch balloon should be long, should not be short balloon, so that you have a lot of intima which is being gripped.
But the diameter should be appropriate.
Diameter should be 1:1 and the inflation should be at 2 ATM only. And then it generally helps, yes.
Thank you, Arijit.
Do you have
So
any
conclude your session?
Do you have any comments for the youngsters?
Okay, any more questions, any more comments?
Dr. Mukherjee?
Please, I'm requesting each and everyone for asking more questions and having more comments. Okay, Dr. Ghosh, thank you so much for such a lovely discussion. Okay, we're moving to the next session, which is a Tech Village session and the lucky draw. So obviously we need Prakash sir right here. So he's not here. We'll wait for them.
Call Dr.
We'll wait
Ranjan,
for
sir.
him, but he will be here right in time. Okay, I'm requesting our people to let him know.
ভোজন করে আসছি তুমি চালাও। Dr. Sharma, please come. What is the session? Can you tell me?
Tech Village session, the lucky draw.
Lucky draw.
So right now we're having the right person for the lucky draw. And I'm requesting each and everyone for get yourself comfortable. Please be seated.
So this lucky draw is a special attraction for the people who have registered, got the coupon, dropped the coupon. And yesterday we had 2 sessions and unfortunately all the doctors got the prize. Dr. Panchanan Shahu, Bhaskar Gupta, and I forgot 2 other names. You can come and draw. So this is the what white here. So this is the draw for the people who are present here inside the hall. Okay, those who have deposited. So we'll pick up who has got the Midas touch for the first prize. I think Ranjan Sharma and then Didi. If you're not there, you'll not get the prize.
Most exciting part,
sorry.
exactly.
Sada tolu, sada. ওই কি তখন সাদা আছে, সাদা বা একটু ইয়েলোর ধরে, হ্যাঁ, গুড। 214 is a lucky number.
214.
214.
Who is having the same coupon?
214.
Coupon number 2, 1 and 4.
তোমারটা নেই তো, নিজেরটা নেই, বোর্ড বাদ। So anyway, so Didi will pick up by her golden finger for the first winner. No, white. Take one white. White. One white. I'll announce the number. So she has blessed a number that is 179.
Wow. Lovely.
Lovely. So first prize. No, not this. This one is first prize. No, that is, yeah. I don't know. Yeah, this is the first prize. So Ranjanda will hand over the prize to Arijit. I check the number 179.
Please,
179. 179. Joyce will check it for me. Correct. Okay. So the second prize, Nirmalada will pick up. If Nirmalada fails, then Dr. Singh. Sada. So actor. Yes. So 2, 1 and 9 is the number for second prize. Check your number.
219.
219.
Just check with your coupon, which you have right now.
219. So you'll still get one more chance. Okay. So Dr. Singh.
This is getting more adventurous.
Sir, white one. Check the color. White one. Yeah. Yes. So he has offered a blessing to a number that is 2, 9 and 6.
2, 9 and 6.
Wow.
Woo.
Wow. I'm so happy to see you here. I mean, that is the best moment in my life here. 296. So checked. And thank you. Congratulations. Can you carry this? Wow. That's for your mommy. What's your name, baby?
Aratvika Ghosh Yadav.
You আমাদের জন্য কিছু বলো। আমরা কে?
You're all cardiologists.
Wow. What do you do?
You treat patients with cardiac diseases.
What is the cardiac means what?
Diseases related with heart.
Great. We are so blessed for your blessings on us. Are you blessed with your blessings as a small kid? Your blessings are more than the God. So you are blessed.
I don't know.
Let's say that, my friends, you are blessed. All the cardiologists are blessed.
All the cardiologists are blessed.
Thank you. Thank you. That's the end of our session today.
Such a lovely moment we had.
And just have a photograph with me. Ranjanda, photograph. Yes. Fantastic. And you will remember me? What's my name? Lucky Dipper. Lucky Dipper. Thank you. Please take your seat. So we'll move on to the next sessions and how to treat.
Okay, we're moving on to the next session, which is how to treat. And exactly, I love to call the honorable chairpersons, Dr. Shondhi Banerjee, Dr. Sushavan Roy, and Dr. Soumitra Roy. I'm requesting all the chairpersons to get up on the stage and take your seats. And I'm requesting Dr. Rohit Modi as well to get on the stage and honor us definitely. And I'm requesting all the moderators to moderate the session. So I request Dr. Tridip Kumar Sengupta, Dr. Vijay Sankar Sharma, and Dr. Afiq Ahmed. I request all the people to be here, and we're about to start this session, which is how to treat. And the first topic of discussion is bifurcation live in box. So I'm requesting Dr. Rajiv Bhagwat. I'm requesting Dr. Rajiv Bhagwat to get on the dais.
So Dr. Rohit Modi is all the way from Bathinda. If you really want to know one person from India who has represented India globally, every corner of the globe, starting from Israel to France to US, and many journals of international repute, it is Rohit Modi. And he's doing a tremendous job from Bathinda, and his produce are of excellence and high quality of PCI, complex PCI. And the depth of knowledge really impressed me. His presence is felt not only in journal, by his commentary in our social medias, interactions with the juniors, and helping juniors to know the newest technology, the newer philosophy of treating human beings with Midas touch. Over to you, Rodhi. Rohit.
Thank you very much, sir, for my kind introduction and elaborate introduction. I am really honored to have introduction like that. So I think the first talk is a talk which is virtual. I'll be going with my talk first. That is how to treat calcified lesions, especially focusing on left main 2 LED. Why impact of coronary calcification? Because we all know that calcium is a marker or extent of coronary atherosclerosis, and calcification results in suboptimal stent results due to impaired stent delivery, due to decreased stent expansion, due to malapposition, stent asymmetry, and there can be complications like dissection and perforations. So the prevalence, as you see, mild calcium is more common than moderate and severe. Again, as I said, the clinical outcomes are poorer when the calcium is present. We know calcium is a finally enemy of the interventions, and severity of calcified lesion limit our stent expansion. So there is a discrepancy between IVUS and OCT as we see these with angiographic in measuring the calcium. So while doing a patient of calcified lesions, you should always be prepared for the worst situation. There should be warning to the patients. There should be a strong guiding catheter. You can use a guide extension catheter if needed, and preparation with a atherectomy device or IVL device these days. So these are the guiding catheters which are used: telescope, guide liner, guidezilla, guide extension. This is a patient being done LED left main with a help of a guide extension catheter. You can see the IVUS. The principle of treating the calcified lesion is do not stent on poorly prepared calcified lesions. So my dictum is lesion preparation, and lesion preparation. So this is a 65 years old male. You can see there was a superficial calcium that could be tackled with a compliant and a cutting balloon. So the approach to the calcified lesions can be a high pressure balloon, an angiosculpt or cutting balloon, a rotational or orbital atherectomy, intravascular lithotripsy, and a laser atherectomy. So this is a IVUS post balloon. You can see the fracturing, diffuse multiple heavy. This was a heavy calcified nodule that was treated with a balloon. Then imaging for the calcified lesions, you must ascertain that what is the quantity of the calcium. We label it as mild to moderate, mild calcification, or moderate to severe calcification. So these are the scoring system used in IVUS for the calcium scoring. And then after preparation, you have to check for the calcium breakage. You can see in the IVUS as well as OCT, the fractures produced by the various treatments. Check the calcium breakage. There can be, think of like this patient had perforation while putting a stent because of the calcified lesion. Perfection, because you need not go to the perfection, because perfection is sometimes enemy of the good. And while performing a perfect procedure in a calcified lesion, we may get complications. So the practical approach would be always be prepared for the worst situation. Intracoronary imaging is helpful to plan the strategy, guide the procedure, and finalize the result. Prepare the lesion before stenting with every effort you can. Please take care of post-stent optimization. Safety is first. Do not oversize too much. So these are the ways we detect calcium, not only the imaging, but coronary CT and angiography, IVUS, OCT. These are the representative imaging using dual sensor images. Post rotabulator, you can see post high pressure fractures, and these are the fracture plaque modification of CLA by scoring balloon. The eccentric heavy thick calcium you can see in a LED left vein lesion. OCT findings, even with POBA and stenting, the final angiography. A word of caution while using LCX ostial lesion, two types of coronary perforations by rota you can see in these patients while doing the atherectomy. OS is high speed orbital atherectomy is a modality, high speed modality. If we can pull back, this is the OCT finding low and high speed OS. Then a word about calcified nodule. You can see the type of nodules like eruptive and nodular. These are the two clinically relevant calcified nodules. This is a patient done with a rota in a calcified lesion. This is a distribution, and the calcified nodules are specifically located at the torsional stress. This is generally at the region of dense calcium. They are located at the sites of dense calcium. They occur at the sites of torsional stress and severe calcium. This is the pathogenesis of eruptive calcified nodule. How the lipid plaque forms a calcified sheet and fractures and hemorrhage, and then a eruptive calcified nodule. Erupted calcified nodule, then in an unstable patient of ACS, then a pathogenesis of protruding nodule. Again, the calcific progression occurs and forms on a lipidic plaque with a sheet producing a protruding nodule, and then this protruding nodule is a clinical entity. So this is a protruding calcified nodule. The problem cannot be differentiated angiographically, cannot be distinguished by intravascular imaging. This is the protruding calcified nodule, which is deformable. That is called called marble in pillow, or it can be a marble in rock. When we try to inflate such nodules, they will behave like a rock and not move. And why can't ultravascular imaging method help? You can see both the IVUS and OCT identifying the nodules. So how can we differentiate? You go with a balloon response. If there is eruptive or protruding deformable nodule, you can inflate it with the balloon. But if you get a dumbbell on balloon, this is a protruding non-deformable type of a calcified nodule. So the principles of treatment, we can treat with a balloon, semi-compliant, non-compliant. This is the pattern of expansions. When we put a stent on these calcified nodules, it can give a concentric expansion in a eruptive calcified nodule or a deformed nodular calcification, and an eccentric type of expansion has to be accepted in a non-deformed nodular calcification. This is a flow chart of calcified nodule. I don't go into detail, but the principle of the therapy is again to see whether it is a mild calcium, moderate calcium, or a severe calcium. Then we can apply our various techniques depending upon the severity of the calcium. So this is the calcified nodules. The principle of therapy, calcium-specific therapy, should be selected according to the individual lesion characteristic. Rotational atherectomy can be used as an ablative therapy. It can be a first choice for critical lesion for volume reduction. This is the rotational atherectomy. We must take care of the wire bias. Then orbital atherectomy, where the wire bias is not a problem. It is a less dependent technique on wire bias. This is orbital atherectomy. So this is a patient where both rotational and orbital atherectomy were used, and finally the probably orbital atherectomy was successful. This is a deformed nodular calcium base. IVL Letao can be used for lesions in calcified nodules. There are less restriction, and size to vessel should be optimal. There is no effect on calcium volume. It helps by breaking the calcium. And the calcium nodules are associated with various adverse outcomes. So I can take time, if there is time, I can take some time in explaining this, how we approach the modification. This was a modification given by me in Journal of American of Cardiology, which was published. So I'll slightly emphasize some time on this slide. Once we have to deal with the calcium, we do imaging with either OCT or IVUS to assess the calcium. First, we see whether it is deep. First, we assess whether it is mild, moderate, or severe. Then we can see whether it is deep, whether it is superficial, whether it is nodular or uncrossable lesion. So if it's a deep calcium, I think the balloons in that case, like scoring and cutting balloons, will not be much effective. So in these patients, I think IVL will be the ideal choice. I've kept the IVL first in this choice. The second choice can be orbital or rotational atherectomy. And if it is superficial, any of the modality like orbital or rotational atherectomy can be quite effective, as well as IVL is effective. And for nodular, I have discussed already in detail. We can use orbital and rotational atherectomy in these patients. IVL is an important investigational tool and has been found in number of the patients to be very effective tool in this subset of patients also. The important subsets like severely calcified lesions with a clot. Here the two modalities of laser and IVL. There will be the choice. The laser would be the best choice because when there is a clot, we use laser naturally to dissipate the laser. Laser is the best modality for the clot, and even for the calcium, this is a good combination with calcium and clot. And IVL, the new modality, has a neutral effect on the clot and can be used in situations like acute MI, where rotational atherectomy has been used. I don't say it has not been used, but it is always fraught with more complications in this clinical scenario. Similarly, for the underdeployed stent and which are due to calcification or ISR, where we find there's a calcified plaque, we can treat these patients again with IVL cape as the first choice, and the laser the second choice. And we see the expansion on OCT and IVAS, or we can see the NC balloon expansion, and then deploy the DES. So this is in nutshell, which I have described, that we must look for the treatment, first of all, the quantitate the calcium, and then decide our treatment. So these are the various modification methods which are used in different calcium, like deep calcium, IVL, Huygens 3+. For superficial calcium, IVL is 3+, and as such, the rotational atherectomy and orbital atherectomy is 3+. For nodular calcium, OA is 3+, and still the IVL is coming up with 2+. Still, the indications are to be explored. So similarly, in ISR and clot, the IVL and laser are the treatment of the choice. So to conclude, lesion modification by atherectomy would be recommended if imaging devices could be passes through the tight could help us to pass through the tight lesion with severe calcification. Confirmation of the plate fracture by imaging modalities should be done. Calcium plate fracture can be obtained after high pressure ballooning, following step by step calcium ablation by atherectomy or by IVL system. Calcified nodule demonstrated poor prognosis compared to non-calcified nodule, even after ablation under the guidance of the intracoronary imaging. Thank you very much.
Thank you. Thank you, Rohit. Please take a seat. We'll take a question later on. So we have Dr. Rajiv Bhagawat waiting for us from Bombay. Can you connect to Dr. Rajiv Bhagawat? Dr. Bhagawat is one of the founder member of Bifurcation Club in India. And you'll be delighted to know he's my friend, and he has treated Sushmita Sen. Recently, Sushmita had myocardial infarction. He is the physician to Dr. Sushmita Sen. Also, many other celebrities, Silva Setty's mother. So that is not what Dr. Rajiv is. Rajiv is very elegant operator, and he has taken the Bifurcation Club to the national, not only to the national level, to the global level. I welcome Dr. Rajiv for the conference, and thank you for your participation and contributions. So he'll be speaking on bifurcation, live in a box, live in box. Over to you. No, live in box is waiting. He said he's waiting. He called me, just call me this. No, he's here only. Call him. ये बात करो, I just speak. Check the other room. राजीव, आप विक्टोरिया में कनेक्टेड to Minerva? No, you have logged in Minerva. I think your lecture is Victoria's. I'm checking. Okay, Victoria. We'll reconnect to the Victoria. Yeah. Okay. Just give me a minute. And so, how many people you know that Sushmita Sen has got a heart attack? No. So Sushmita had a heart attack, I think 2-3 months back. Yeah, she recovered completely by grace of God. So if you're a smoker, if you have high cholesterol, whether male or female, you still have a chance for myocardial infarction. So please take care of your habits, regular check. And you may be a fittest person on this world, but if you are living with risk, it's better to take some cholesterol lowering agents, hypertension control, and stress management, proper sleep, water. See, he has to connect through another link. Huh? You know his number. Send him the link, na? Amake pati kiya bhai. You send this link to this number. Pandey, speak to help Rajib to get connected. He is connected to the other hall. No, he was connected to Minerva, and that's his number. Okay, so before he connects, so Rohit, a beautiful lecture, and in calcified lead paint LED, you know how much modification of calcium is ideal. Like, is it a quantum? Is it a morphological change? Or it's something else?
With ideal.
No, overall, in general.
In general. In general, actually, the aim of calcium treatment, the first we have to quantify the calcium, whether it is mild, moderate, or severe. Most of the times, the modifications, non-balloon modifications, which are required, are generally required in patients who have at least moderate or mostly severe form of the calcium when we image. And the modifications which we see, like in rotablator, it is an ablative therapy. It ablates. It may cause microfractures, and when we assist it with the help of balloons, it ultimately causes fractures also. But the basic mode of treatment of this ablative therapy is ablation. If we see IVL for its mode of action, the mechanism goes by fracturing. So it will produce fractures, and eventually when we balloon, it becomes softened structure, and we can expand our stent on that. As I told you, in any calcium, it's my practical view. Some may agree, some may not agree. I have shown one case patient also. It is my practical view that we need not be perfect in our result when we treat a calcium patient, because perfection is sometimes the enemy of good. Sometimes while attaining a very perfect result, we may lead to complications like perforation or other dreaded complications on the table. So do your modification. If you feel it is good enough to put a stent, as the stent will expand, put it. Get your results of imaging, like you don't have to get a perfect result of 90% expansion and all that. If you have a MLA in a reasonable range, I think we must accept the result and go forward.
Right. So Rajiv is waiting for us, and I've already introduced you. So you say this is my duty to reintroduce him again. He is a person who has taken the Bifurcation Club of India not only to national level, different corners of the country, also to the international level. He is a friend of mine, and he's a celebrity doctor, I tell you, as I have repeated, that he has given his Midas touch to heal Sushmita Sen and many other very important personality in this country. And we are lucky to have a friend like him, and lucky to have an operator like Rajiv Bhagat in our community. So he's going to talk on bifurcation live in a box. Over to you, sir.
Sir, you need to unmute.
You are on mute, Rajiv. Yeah.
Thanks, PK, for those kind words. Now, I would present a simple case, relatively simple, I would call, if you compare today's standards. But this is an angiogram. Now, the angiogram is shows a calcified left system right from the ostium. So would somebody like to comment on the angiogram as far as strategy is concerned, just by seeing the calcium? Or shall I go ahead? Chairpersons, somebody wants to comment on this angiogram, just looking at the picture?
We could, can we see the angiogram? We have
No,
not seen.
No. Sorry. Does somebody want to comment on this plain fluoroscopy or cine angio? That's it. Looking at the calcium. So here is the calcium right from the ostium.
Yeah,
the left
okay,
vein, and
it appears a calcified. Yeah, calcified.
So some people would like to formulate a strategy just by seeing the calcium. Maybe today, since Rota has become such a common thing, somebody would strategize and say, okay, Rota, I have it on the shelf. I would use a Rota. But this case was done in the end of 2019, just before COVID struck, and the 85-year-old gentleman. He was, I'll give you a brief clinical history. He was basically due for a lap cholecystectomy, and they could not do it because they found that the patient at night had severe chest pain and did an angiogram. The angiogram showed a significant
Calcified left.
Yeah, no,
calcified.
Yeah, this is the angiogram. They showed a calcified and a very ghastly looking picture in the left main. So the hospital where the patient was admitted, they insisted on bypass surgery. This gentleman was a little lean and thin gentleman, hardly weighing about 45, 48 kilos. And so they consulted me, and I said, you get into my hospital, we'll try to fix it up with an angioplasty. This is the picture. So any comments on this picture? On the cine angiogram? This is the RA caudal view.
Yeah, this any other view? Can you share
No, I have just given you one important view. One view that gives you the most information.
So, okay, this is a calcified tight left main disease with Medina 111, and the critical lesion more appears towards LAD side, and it appears to be heavily chunk of calcium there. So the approach can be we cross both the lesions towards LAD and LCX and try to palpate the lesion with a balloon, because we won't be able to pass imaging right away. So what did you did, sir?
Yeah. So now, since this is an acute coronary syndrome, it's very obvious to think that there is calcium because it appeared so on the fluoro image, but this is a plaque which is a mixed plaque. So I would base my strategy here on the way my wire goes. If my wire goes very easily, if I get a feel of calcium or a thrombus or a soft lesion on the wire, I would base my strategy on that instinct. So this is a mixed, for me it was a mixed plaque. Means I thought since we should have acute coronary syndrome, this could be a calcium and a thrombotic mixed plaque with a possibly a trifurcation, a very common origin of the circumflex in the ramus, or a very early OM can call it. And so we wired this. The wiring was a little tricky, and in this situation, I would suggest that your wire should go just in the direction where it goes in any branch. At least just anchor the guide, at least secure one passage. So here the wire went in very easily into the ramus, and then wiring the LED was really tricky. And I will see the LED goes from just under the plaque. And once the LED was in, not very difficult. So what we did, we just did some dottering with the balloon just to have a feel of the lesion. And the balloon was not very easily moving forward, but yes, there was a passage that we could try to create. So any different strategy that anybody adopt there in the audience or chairpersons, any view?
Yeah, we can see the balloon passing from the left main into the LAD. Did you dilate the balloon to palpate the lesion?
No.
Okay.
I didn't dilate this balloon.
So what was your next strategy? Because
Yeah. So
if the
the-
balloon passes, you wanted to
Yeah.
pass a imaging modality, or what was your next step?
No, we didn't use imaging here since this is an acute coronary syndrome. Patient had borderline pressures with a very mild LV dysfunction. The patient is EF for about 45%. But I thought we should do a quick procedure. I would rather image the patient later once I finish stenting. So what we did was we just dotted this, got a feel of the lesion, and then we used, I think the wire had just come out. Lucky for us that we didn't dilate, there was no dissection, and we could just ease in. So this, the wire should not come out. That's another one basic learning here is wire shouldn't come out. I think the wire just came out with the balloon or somehow. I don't remember exactly why, but this wire should not have come out. Now, this is a cutting balloon, and you see a cutting balloon is a little larger profile. And the moment a cutting balloon is in, there is slow flow. So we knew that we had to be quick with the slow flow all around the global ischemia that we're trying to create with a cutting balloon. So we just cut this as quickly as possible. And that is how we could restore TIMI3 flow post-cutting. And then there's a reasonable cut. If you see the left vein and the trifurcation, there's a reasonable cut that we have been able to give. Any comments?
Yeah, my first point is that if you felt that the lesion was a soft lesion, like which is a ruptured plaque or something soft like that, so the idea of putting cutting balloon in that may cause slow flow. What do you say about?
We already had slow flow, but the strategy here was we knew that it is calcified on the fluoroscopy. But it was not only calcium, it was also a soft plaque. So it was a mixed plaque, soft and calcified. And since it was an ACS, there was no question of me using a rotablator. So I thought the cutting balloon was the best choice. And as
I think you got a very good result after the cutting
Yeah,
balloon. We
so
can
we
see all
predicted,
the
yeah.
three vessels very well flowing there.
Yeah. So
And we-
basically, it was a plaque straddling the ostia of the circumflex and the ramus,
Yeah.
but the plaque basically, the lesion was basically in the left main LED segment.
Yeah.
Yeah. So
After opening that, the ostial lesions look less severe.
yes, yes. So then we went ahead and setted the large ramus. There was a significant lesion there, and there was some difficulty the stent pushing through, but yes, we could get it across with some pushing, and then we came to the LED stent. It's a long 3.5 millimeter stent, and that was the result. So this was just post deploying the left main LED stent, and then of course we what happened is we first did a dilatation of the ostium of the ramus, and then when we got a reasonable flow there, we thought we should wire the circumflex and do a kissing balloon here, because we really wanted to push the struts here. So this is a very important part of the strategy. I just want to know what people, they would do the same thing, or there's some different strategies, because if you see, it's practically a common ostium.
So you are asking about the opening of the strut for
Circumflex,
the circumflex
ramus,
where we
yes.
have yeah. So this is actually a controversial question, but imaging with OCT can help us in deciding the answer. If we find a strut in the ostium of the circumflex and the lesion is less than 50%, but if there is a strut, some people say that we must clear the ostium of the LCX from the start. So that is the dictum.
My question was, see, I had a wire in the ramus, and the ramus is a little larger vessel in the circumflex, but circumflex also is important.
Right.
So whether you do a kissing balloon in a ramus left main or the circumflex left main, the way I have done it, What we
Yeah,
did was we first dilated the ostium of the
Yeah,
ramus.
definitely. It was a good choice because your ramus appears to be subtending more area than the circumflex.
No, but
itself.
you see, the reason here is the carina is towards the left main
Acute
ramus.
also, acute. It is acute,
Left main ramus
acutely
is the
placed
carina.
for the, yeah.
Yeah, so this is a common ostium, practically, as you will see in subsequent images, but the carina is towards the ramus. So we first ensured that there is a good dilatation of the ramus left main, and then we wired this, we removed when we were sure there is a reasonable result on the ramus, we put one more stent proximal to the first stent. There was a small dissection there. For the want of time, I thought I will just cut down the images. And then we did this kissing balloon, and then the pot. And then we did an IVUS on this gentleman. Unfortunately, I don't have the IVUS picture. We could not retrieve them, but the IVUS showed good expansion. Very, very happy with no strut across the common ostium. So that was a very rewarding result. And here is, we don't have an IVUS, so I thought I'll just share this image with you. This is a stent boost image. And if you see the, there's a very clear cut sort of, one-dimensional picture of this stent gap. This is the carina, and this is the proximal part of the circumflex. And you see, this is a pretty big hole here. So we were, and this is what was corroborated on the IVUS. So we're very happy with the result, as I will show in the few films. So this.
Yeah, that's a wonderful, wonderful.
Yeah.
result.
So this was a very telling picture. It shows an excellent result, and it's actually a very large circ ostium, as big as a LED, and a very early OM or a ramus, as people would try to classify this. And that's it. Thank you. Any comments from the audience?
Yeah, any comments from the audience? Yeah, seeing the angiogram in its initial stage, it looked like to be a very complicated procedure, maybe requiring 2 or 3 stents, but very well done. And we could see how you made the things very, very simple and could get away by stenting from left vein to LAD, and a wonderful result. Congrats to you.
Yeah, so this gentleman, we are trying to get him for a re-angio. I just spoke to him yesterday. Unfortunately, he lost his wife during COVID, but he is now nearly 90 and he is fit and fine, though has a mild Parkinson. But since he's fit and fine, obviously his left hand has not recurred. There's no clinically, there's no recurrence. We'll try and get him for an angio sometime and maybe show it later. Thank you.
Thank you.
Thank you.
Any other presentation? This is the only one, or any other, sir? Case? Any other case you have, or this is the one?
No, this is only one. This is only
This is
one.
only. Oh, okay. Thank you very much. Any
Thank you.
questions from the audience? Okay, we will thank you, sir, and we'll close the session.
Thank you.
Close the talk here, and we will go to the next talk. The next speaker.
Okay, thank you so much, Bhagwat sir. And I love to invite Dr. Amrita Paul for her session, Thermobiotic PAMI. So Dr. Amrita is about to reach the dais.
Good afternoon. I am Dr. Amrita Pal. Good afternoon to my seniors, my colleagues and juniors. I'll be speaking on this topic, the thrombotic primary angioplasty, which is, as we know, dangerous terrain to traverse. It is a place where we all are scared that this may not be good news. And nevertheless, we do encounter it in our daily practice. And so I'll go on with what we may encounter and how to tackle it. So the first thing is to identify the thing correctly. Are we dealing with a thrombus or is it calcium, or is it a mix of both? So a thrombotic lesion looks like filling defects or haziness in an angiogram. Unfortunately, there's only 26% sensitivity in recognizing a thrombus, and everything has a classification, and there's been a score, thrombus score, suggested by this cardiologist, Hainos et al. And they've given 5 grades: 0 for no thrombus, 1 for possible definite thrombus, less than half of the vessel diameter, grade 2, less than half to up to 2 times the vessel diameter, grade 3, more than 2 times the vessel diameter, grade 4, and TIMI 0, or inability to judge thrombus burden, is grade 5. So we may use imaging. It should not be done routinely, but we may use imaging, and that will give us a very good idea. Are we dealing with a thrombus or is it something else? It will also help us recognizing whether it is a red thrombus or is it a white thrombus. I'll go into that. So these are OCT and IVUS images of the same, and we can see some mass hanging, and that's how we identify a thrombus. So where should we use imaging, if at all? So if there's a mismatch between the angiographic appearance and the clinical presentation, we are not certain, and we need to know the exact burden of thrombus we are dealing with. So those times, not regularly. Now we come to few facts that we should know. So there's one study which tells us that 91.6% of primary PCI cases have thrombus in them. Angiography sadly underestimates them. 6 to 18% is the distal embolization rate we deal with, and that distal embolization depends on, will have a negative prognostic factor. It affects the success rate, it affects the post-procedural LV ejection fraction, and a larger enzymatic infarction. So it's good to be prepared. We should know how bad the thrombus is. Not only a thrombus can be a bad thrombus, it can be a not so bad thrombus. So we need to know the composition of the thrombus, and I'll tell you, I'll discuss how. The size is obviously, more the size was the case. The pre-PCI TIMI grade, larger vessel diameter and length. Target vessel length is more and it's full of thrombus, so it's a bad case we are dealing with. So the pathology of a thrombotic lesion. So it has been found from the thrombus aspiration catheter studies that an early presentation will have a platelet-rich thrombus, but a late presentation will have an MPO-rich and a more erythrocytic thrombus. So that is a bad thrombus. So the later the presentation, it's a more red thrombus, more erythrocyte and MPO-rich thrombus, and we need to be careful, more careful. It's a harder thrombus, it's prone to distal embolization, and it will give a worse result. So these are some of the pictures. The white thrombus we see down below. These are softer ones, easier to deal with, and the upper ones are the red thrombus. So what are the methods we have? Firstly, imaging, if we at all use it. Then wiring. Of course, we have to first insert the wire, pass the wire. Let's do it with workhorse wires. And if we cannot, then maybe the hydrophilic ones with a good trackability. If you are encountering that there is some hardness, there's some calcium, then we go for the hydrophilic ones. Next is drugs. So this is where we start with the GP2B3A inhibitors. We'll go more into the details. Then we go into the devices. That's the mainstay of dealing with a thrombotic PAMI. In spite of what the trials tell us, devices are important and they really help to get out, to get away with the thrombotic PAMI. And lastly, intracoronary thrombolysis. So what are the drugs? We all know eptifibatide, tirofibran, and nab-sirolimus. And it can be delivered intracoronary, intravenous, or a mixture of both. And it's difficult to say which is more effective because reports vary. We have intracoronary adenosine, nicorandil, nitroprusside, diltiazem, and in certain resistant cases, epinephrine. So what are the evidences in support of using GP2B3A inhibitors? There's this Clearway trial, which showed some improvement of the coronary flow and reduction of thrombus burden. And then this Cicero trial, which shows with the use of Abscisimax that the myocardial blast was improved and the smaller enzymatic infarct size was found. The thrombus aspiration remains a great debate whether to do or not to do. So what are we having in our hand? Multiple devices with dual lumen catheters. It should be passed along the culprit lesion and with a smaller lumen consisting of the guide wire and a larger lumen to basically aspirate by creating a negative suction. So two characteristics we need to remember: the deliverability. It is something which is a measure of the pushability and the trackability of the catheter, and the speed of aspiration. So whatever the devices that are in the market will tell us will claim better trackability, better pushability, and lesser and better rates of aspiration. So the Export AP and Export AP Advanced were the first ones used in the earliest trials. We have better, more improved, efficient catheters, like the Thrombustor 2 being used. QuickCat, they say, has the best features of all together. There's Eliminate and Pronto devices, and this CAT-RX, these are which was presented in 2019 and ACC, and it claims of a very good deliverability and trackability and faster clot retrieval and 0 stroke rate. So what does a safe and a successful thrombus aspiration involve? Firstly, we need to have a well-engaged and supportive guides. Then, while we are crossing the thrombus, we should aspirate so that there is no distal embolization. We should multiple time pass through the vessel, through the clot. And while aspirating, while removing the catheter, we should again aspirate so that there is no proximal spill or spill into the aorta, causing stroke. And lastly, the guide catheter should be completely cleared of any debris, remaining debris by back bleeding. So this is a image we all see, and this is a macro thrombus that has been retrieved by a thrombus aspiration catheter. So these are a few of the common devices. And so what are the support? What are the points in favor? They decrease the thrombus burden, we all know, the lower rates of distal embolization. We get to see the actual landing zone for the stenting. We get to see the exact stenosis size so that there is no underexpansion. No reflow rates are reduced after stenting. We have lesser incidence of no reflow and improve microvascular perfusion. So better clinical outcomes in long term. So the original supportive evidence was provided by the TAPUS trial. So it was it consists of 171 patients, and the myocardial blast score was actually the primary endpoint, and it showed absolutely successful results. And the thrombus aspiration was hailed as to be routinely done in every case. But however, today with the 2000 as we stand in 2023, we have a class 3 indication of using aspiration thrombectomy, but this is not true. They're talking about routine aspiration thrombectomy. So what it says is routine aspiration thrombectomy before primary PCI is not useful, but that means clearly that in selected cases it can be done and possibly it should be done. The JCS also gives a similar standing, and so does ESC. So it's a bit of a dismal result, and that is derived from the TASTE and the TOTAL trials in 2013 and 2015, which are large trials involving many patients, 7,000 and 10,000 patients. And it showed that there is no reduction in mortality and MACE. And in fact, there is an increased incidence of stroke at 30 days or 1 year. So that's when it became less popular. But if we look closely, we will find that these studies, there is some problems, like the patient selection between the TAPUS trial and the TOTAL and the TASTE trial were different. There were more comorbid patients were chosen. The timing and delay of reperfusion was never documented, and different devices were used. So with the newer devices, the results may not be as dismal. So this is the TAPUS trial, which showed very good results with thrombus aspiration, and the TASTE and the TOTAL trial, which completely reversed the scenario. So it is the judgment of the operator whether to use or not use aspiration thrombectomy. We next have the intracoronary thrombolysis. This is a old concept. It was used routinely back then, but now in case of failed aspiration thrombectomy, we may use this. So marinade technique is a newer version of this, where we put a distal occlusion device, a small balloon inflated at the end of the thrombus to use to marinate the drug, that is streptokinase, altiplase, or tenecteplase. These are the doses used, 10 milligram, 6.2 milligram of each, to selectively dissolve the thrombus. So that is the way it is used. And there's another newer technique I have found in the internet, which is from China, university in China, where they use a second wire along with the guide wire. They twisted the wire and they pulled the wire which had hinged the embolus within it. So this is how it is done. The second wire is rotated continuously in one direction, and the entire thing is twisted. The twisted material is totally taken out altogether. Next, we have direct stenting. That is, once the thrombus burden has been reduced by aspiration thrombectomy or reduced thrombus burden from the beginning, we can stent without predilatation, and this is called as direct stenting. It's better to use slightly oversize the stent in these cases, and post dilatation better to avoid. If we have got a good TIMI score after the stenting, it's better to avoid it. So no reflow is something we find after relief of the coronary obstruction if the TIMI flow grade is low and the myocardial blast score is less. So what do we do in case of that? We use an IVUS to confirm. To prevent it, we avoid aggressive stent inflation, use a microcatheter for delivery of vasodilators, and use multiple vasodilator agents for refractory no reflow. So these are the agents used, and adenosine is a very good agent. Apart from that, the GP2B3A inhibitors, epinephrine in refractory cases, and we can come back to thrombectomy again, aspiration thrombectomy. So to sum up, my time is up, and I'll sum up with a flow chart. So let's cross the lesion with a wire. If a TIMI3 flow is achieved, good, we go for a aspiration thrombectomy if there is a high burden, thrombus burden. If not, direct stenting. If still the thrombus aspiration is not good, we can go for a direct stenting, or if not at all, then we go for a triple therapy and a deferred evaluation. Not recommended, but sometimes nothing can help. And if the TIMI3 flow is not achieved, again, thrombus aspiration. If not, go for the marinade technique, or if it is achieved, direct stent implant. So the takeaway is tackle it early before the clot thickens. There are so many ways, but there are no real guideline support in any of the methods. New technologies are coming up, and thrombus aspiration may not be as bad as it sounds. Intracoronary thrombolysis with distal occlusion may be a useful technique. Is there a role for laser? Yes. A new study called the Carmel study showed that higher the burden, it can be used. It gives good result, and operator skill and nerve is the last and the final thing that we need.
Thank you, Dr. Amrita, for a very illustrative talk on high thrombotic burden lesions in primary PCI. Any comments or question from the audience is welcome.
Tells us that we should routinely do thrombus aspiration if you follow the chart. Is it so?
No, sir. The chart does not say routinely, of course not. But if there is a high burden,
say your LED is totally occluded,
yes,
and you wire the vessel,
yes,
still you have zero flow. What next?
I would then say thrombus aspiration in that
Thrombus.
case.
So this is basically routinely. As you know, 90% of the STEMI, you will get total occlusion. So
Yes.
almost in 90% of the cases you are suggesting, but the practice is otherwise. Why not pre-dilatation with a small balloon and do a direct stenting if you get a landing zone? What is the harm in that?
So if there's a total occlusion and the wire passes and we pass the balloon, and if we get a landing zone, if we see a landing zone, then of course we'll go for
No,
a.
suppose after the wire passing pre-dilatation, I got a landing zone, but your thrombus burden is say grade 3. Then whether to do direct stenting or to do aspiration.
So if in that case, I will see what is the presentation time. If it is a late presentation, and I know this is a dangerous thrombus we are dealing with, the type of thrombus might we might consider.
So less than more after 4 patient is here after 6 hours.
I would, sir, if we have the newer devices, the safer devices, as they say, it may be a good option.
So I'll do a direct stenting.
Yeah, that's true.
If patient is in say 3 hours, probably I'll do thrombus aspiration because it is easier. It's not easy to get thrombus out in 1 pass, 2 pass, 3 pass, and more you fiddle, more danger because you don't have a control. Sometimes even after 6 passes, your thrombus is same as it was.
Yes. Then
Whereas if you do a direct stenting, if you get a thrombus, thrombectomy could be as a bailout procedure, not the routine according to your chart.
Yeah, what I see for role of aspiration in a PAMI patient with a high clot burden is, as you said, we get a thrombus load, and after crossing the wire, we are unable to see the distal landing zone. So if we are unable to see the distal landing zone, in that case, direct stenting will be not
a good option.
Not feasible.
Not feasible.
Not feasible.
Not a safe
Unless
option.
we see the distal landing zone, the direct stenting is not feasible. If on finding the distal landing zone is not visible, I would have 2 options. Either I just make a passage with a small balloon. My aim is to fiddle with the clot as less as possible. So there are 2 ways to that. As you said, thrombosuction can be done in these patients so that we remove the not vigorous thrombosuction, but just a pass, keeping the precautions you have told, to just see the landing zone. And as soon as we see the landing zone, we are fit to do the direct stenting in that patient.
Absolutely, sir.
So that will give a tremendous good results. If we do thrombus suction, practically I am talking to you, if we fiddle more with thrombosuction and keep on doing passes of thrombosuction so that the clot is removed till end, then the problem is the more of the clot goes into the microcirculation. The results are not as good as direct stenting, as you are also experiencing it, and I second that opinion.
Right, sir. So thrombosuction once, if at all.
You have to take it as a friend, not like it is a.
Yeah.
It is your.
Not totally depend on it.
Yeah,
Yes.
not totally dependent on.
Yes,
That's
sir.
all. And second point, I think you have not emphasized the role of intracoronary thrombolysis.
Sir, I have mentioned.
Okay, that's
Yeah, I
fine.
have mentioned.
You have just mentioned it. I think once a balloon, we can do it with a balloon inflated. Otherwise, also without balloon inflation, we can sometimes if there is a large thrombus burden, sometimes theoretically we can use, if a low bleeding risk patient, if it's a low bleeding risk patient, then we can think of taking the help of the intracoronary thrombolysis, and that too as a friend. Not.
Second question, always after the stenting, what is your threshold of leaving the thrombus inside the stent? Will you always make it thrombus free, or sometimes you got a small thrombus hanging on the one border of the stent, or will you chase it till it disappears?
Of course, sir. We'll leave it as it is and let heparin be our friend in this case, and maybe do a check angio later on.
Thank you.
Thank you so much, Dr. Paul. And we're now closing the discussion on thrombotic PAMI. So we're moving to the next speaker, Dr. Ashok Parida. I request you to be on dais. His topic is IVL Exotica. So we'll discuss over this topic. Thank you, sir.
Good afternoon. My topic is IVL Exotica. So I'll present some slides on IVL. So there lots of discussion on IVL in today and live cases on IVL. And but I'll show some slides followed by some case presentations. Advancing age and presence of comorbidities like diabetes and chronic kidney disease, they predispose to coronary calcification. Moderate or severe calcification is frequently present in patients undergoing percutaneous coronary intervention. And calcification border is the region of stent under expansion, which leads to increased major adverse cardiac events, including increased rate of ISR and TLR. And regarding calcium modifications, so many techniques are available. Starts with non-compliant balloons, including OPNNC balloon, cutting balloon, scoring balloon, and rota, orbital atherectomy, and ELCA. Now coming to coronary intravascular lithotripsy, this is now very user-friendly and no training is required. So this use acoustic shock waves in balloon-based system for treatment of concentric and eccentric vascular calcification, that emitting elements that are integrated within a semi-compliant balloon filled with mixture of contrast and saline. And this IVL system has two emitters that integrated in a rapid exchange balloon-based system and is available in diameters from 2.5 to 4 millimeter and is 12 millimeter in length. The IVL balloon is selected in 1:1 ratio to the reference diameter. And it delivered 10 pulses in sequence at a frequency of 1 pulse per second for maximum of 8 pulses per catheter. And the mechanism of action is axial splitting of compressive circumferential forces, generation and violent collapse of cavitation bubbles by shock waves inside the saline contrast filled balloon that impact the surface of the calcific plaque. And that causes fatigue mechanism involving progressive expansion of the microfracture and leading into macrofractures. And this causes no damage to the non-calcified soft tissues. And we usually dilate the balloons at 4 to 6 atmosphere and usually at 4 atmosphere. And this is high-speed sonic pressure waves created safely inside the integrated balloon. An advantage of IVL over rota or orbital atherectomy is that no specific training is needed and risk of atheromatous embolization may be lower than free debulking devices. There is no guide wire bias as compared to rota, and circumferential modification calcium atheroma is possible, and there is low atmospheric pressure balloon inflation lasting less than 2 microseconds, minimizing mechanical vascular trauma. That side branch protection using guide wires may be easily performed using IVL. And this scoring system helps us to decide regarding lithotripsy or rota. And the IVAS or OCT assessment is by calcium mark is 1 to 270 degree, it is 2 points. Calcium mark more than 270 degree, it is 3 points. Calcium length more than 5 millimeter, 1 point. And if it is more than 5 millimeter, but more than 270 degree in IVAS, then it is 2 points. And thickness, if it is more than 0.5 millimeter, that is 1 point. And thickness only can be measured by OCT. And it is 1 to 2 points, then there is high or very high pressure NC balloons can be used. And if there is suboptimal result, we can go for lithotripsy, followed by stent implantation and optimization. If it is 3 to 5 points, then we can directly go to lithotripsy. And if it is doesn't cross, we can't cross, then go for rota. And if suboptimal balloon expansion, again we can go for lithotripsy, followed by stent implantation and OCT and IVAS guided optimization. Coming to some cases we have done recently. This 64-year-old lady presented with complaints of chest pain for last 2 days. And there is ECG, there is only LVH and no ST, major ST changes. And EcoShort, that is RWM in LED territory. And we did the angiogram. We showed there is calcified lesion from the origin of the D1 to covering almost mid segment. and extending up to distal segment. So we did the IVAS, and this IVAS run showed there is more than 270-degree calcium, and the point it was around 3 to 4, and that's why we planned for lithotripsy in this case. We pre-dilated with 2 into 10 millimeter SC balloon. Then, as it was previously planned, we IVL balloon was used with 3 into 12 millimeter, followed by the stent was deployed. It is post-dilated with 3 into 12 millimeter NC balloon, and post stenting the IVAS post dilatation, the IVAS run showed that is not properly opposed. So it was post dilated with 3.5 into 8 millimeter NC balloon. And this is the final IVAS run, and the stent is well opposed in the severely calcified vessel. And this is the final result. Another 74-year-old female presented with complaints of dyspnea and exertion for last 3 to 4 months. Ejection fraction was around 50%, and ECG was normal. Echo was also normal LV function. This is the angiogram. We showed there is a calcified vessel starting from the proximal segment and extended up to distal segment. Even angiogram is showing there is severely calcification. We did the IVAS, followed by we planned for lithotripsy, and is pre-dilated to 3 into 10 millimeter OPN balloon, because with NC balloon it was not opening properly. So we used OPN balloon, and this with the OPN balloon you can see there is it is not with 4 atmosphere also it is showing there is it is dog bone effect. And after that we put the stent, and you can see the distal segment it is not properly opposed. So we dilated to 3 into 12 millimeter NC balloon. In spite of this NC balloon, still there is residual stenosis in the distal segment. And after that, we dilated with 3 into 15 millimeter OPN balloon. And now you can see this OPN balloon helped us, and is now the stent is properly opposed, and post IVAS was done. It has shown that is proper apposition of the stent, and this is the final result. So this is the calcified vessel. It was possible only with the IVL. Another 78-year-old frail lady, around 30 kg, and she presents severe chest pain. We had previously planned whether to go for angiogram or not, but she was complaining so much chest pains, we planned for an angiogram. And this angiogram showed there is calcified lesion in the mid and distal, in the proximal and mid segment, the origin of D1. There is a lesion. We did the IVAS. After that, we dilated 2 into 15 millimeter SC balloon, followed by IVL catheter 2 into 15 millimeter. And after that also there was the lesion was not, we were unable to open it, and we dilated with 2.5 and 10 millimeter OPN NC balloon. Then we put the stent proximal and distally, and there was a pinch in the diagonal, and we did the kissing, and this is the final result. So this is the 80-year-old lady. So it was possible only because we did the lithotripsy, otherwise it would not be possible to dilate the stent. So nicely dilated. And this is one case where we did the IVL in case of RCA, and this is a calcified lesion in the mid segment, and it's calcification starts from the proximal to mid segment. That's a very simple lesion, and we did the IVL and post stent synergy 3.48 and with NC balloon, it is well opposed. So these are the cases we can do with IVL, but the challenging lesions are severe tortuosity and angulation, critical lumen reduction, where we may not able to cross the balloon, and a vessel with a diameter of more than 4 millimeter or plaque eccentricity precludes appropriate IVL balloon apposition to the vessel wall and may reduce the efficacy of the therapy. More data on the safety, efficacy, and clinical outcome of IVL used for treatment of stent under expansion are needed. The conclusion, the coronary IVL system is a promising new treatment modality to tackle moderate to severe calcified coronary lesion with a high rate of success and low risk of complications. Larger studies and long-term clinical data are needed to confirm the safety and efficacy of this technique with special attention to the effects on cardiac conduction and vessel healing response. Randomized controlled clinical trials are required to evaluate superiority against currently available calcium modifying devices. Thank you.
Thank you, Dr. Ashok, for presenting a nice overview of IVL use in calcified lesions with your good cases. Any questions from the audience? Any questions? It was a nice elaborated discussion. Actually, I wanted to know, in your first case, I think you did what is the size you take, IVL size you take for modifying the calcified lesion in your patient? What is the criteria for taking choosing the size of the IVL?
With the IVS, as per the in diameter, we take 1:1 ratio.
Yeah, that's what I think. In your
We
first case,
3 into 3 millimeter size. I have taken the first case.
yeah, probably the vessel was more than 3.5. I have seen unsized IVL also work well.
Yeah,
but
around, it was around
mostly
3.25.
I think we should target about 1:1 ratio.
Yeah.
Because later on you did it with 3.5 stent and then post dilated high. Also, maybe you have taken the vessel to 4 millimeter size. So I think probably you did a very good job, but ideally the choice could have been better
with 3.5.
Yeah. And secondly, the importance of IVL in clot lesions, like in a setting of acute myocardial infarction, where we have calcium also. So in these cases, I think rotafibrillator is fraught with complications.
We have done in acute cases.
So that case
in RC, it was almost
acute with a clot.
Thrombus, yes.
And under expanded stents, when especially the calcium is the culprit in these lesions. Sometimes there is under deployed stent initially, so we can go away with IVL only after fully expanding the stent with the IVL. We need not put another drug-eluting stent, and we may go away with the IVL only in our restenotic patients.
We have seen we are opening the OPN balloon before putting the stent. We are not able to open it.
Yeah,
but after
we can take the help of cutting balloon, OPN balloon. That is true. That is true.
Post IVL, it is the stents are getting well opposed with OPN.
Yeah, that's. Thank you very much. Thank you. So nice.
Thank you so much, Dr. Ashok. And we're moving to the next discussion. For this, I love to invite on stage Dr. Suchit Majumdar. The topic is infected CIED. So now over to you, sir. Thank you.
So thank you, sir, for giving me the opportunity to present in this August audience. So thank you, Chairperson. So the topic today is about CIED infection. That is, CIED means implantable devices, that is the pacemakers, CRT, ICD, those are included under CIED. So, so CIED infection is dangerous. Why it is dangerous? Because not only it increases the morbidity, that is, you have to undergo a device explantation and maybe reimplantation of the devices. Not only that, it increases mortality. That is very important. In one study, the incidence of infection was around 4.82 per 1,000 device years after a primary implantation, but it is much higher after a replacement, that is around 12.12%. So, not percent, per 1,000 device years. So in the lexicon study, it was shown that the all-cause mortality in infected patients was 3%, and the highest mortality was observed in patients with a device-related endocarditis. So device infection kills. That is the most important thing we have to understand, and we cannot take it lightly, just another infection like that. Second, how do they present? So mostly it is actually almost distributed. So early device infection occurs in around 25% of the patient, that is within the first month. Then up to the 1 year, it is called as late device infection, which is 33%. And delayed device infection is 42%. It is more than 365 days. So most important to understand that device infection doesn't mean that it will be presenting immediately after device implantation or within 1 year also. Most of the patient, if you see, 42% occurs late. And there has been reports that occurs 2 to 3 years after device implantation. So it has to be suspected. That is the most important thing. And if you go to the microbiology of the device infection, mostly it is staph related. So staph aureus, then coagulase negative staph, both are there. And if we see the bacterial type based on early device infection versus late device infection, we can see in the early infection, the staph aureus is more than in the late infection. But in the endovascular infection, like in case of device endocarditis, we see the staph is more even in early and often in late infection also. So the most important mechanism of device infection is contamination of the leads and the pulse generator during implantation or subsequent manipulation. And device erosion late after intervention may be due to or result in pocket infection. In either case, contamination and subsequent bacterial colonization is the important things. And the other mode, so one is a contamination and bacterial colonization, biofilm formation. The other one is a direct lead seeding, occurs due to bacteremia caused by distant infectious focus. So these are the risk factors of CIED infection. There are certain patient-related risk factor, procedure-related risk factor, and device-related characteristics. Some are modifiable, some are non-modifiable. Patient-related risk factors, end-stage kidney disease, corticosteroid use, diabetes, malignancy, these are important, and also anticoagulant use. Procedure-related risk factors, procedure duration, post-operative hematoma, that is very important. Reintervention, early reintervention rather, that is very important. And temporary pacing, that is also a very important thing. And in revision or replacement, the device infection is more. And device-related epicardial lead, abdominal pocket, then CRT, ICD, these has higher risk of device infection than a pacemaker. So these are the modifiable and non-modifiable risk factors. And we can modify it by postponing the procedure if the patient has a fever, treat any comorbidity, continue the OAC uninterrupted. That is very important. If the patient is on warfarin or NOAC, it is better to continue it rather than bridge with heparin, because different trials, including the bridge trial, have shown if you bridge with heparin, the chance of hematoma and subsequent infection is higher. Then number of persons in the operating room, all these are important, number of IV lines. Administer pre-procedural antibiotic prophylaxis as recommended. I will come to that, how to administer. So delay, so these are all same thing only, avoid temporary pacing wire, central venous line, and perform in a operating room or suite with complete sterile environment. And pre-procedural Staphylococcus aureus decolonization, this has some role, like a nasal mupirocin and all these things. Pre-procedural skin wash, and that too the skin wash should be given by a chlorhexidine rather than a povidone. And antibiotic prophylaxis, that is very important. This should be given within 1 hour of incision. That is not that you have to give in the morning and do the procedure at the afternoon. It has to be given 1 hour before, within 1 hour of incision, and the infusion should be complete before you give the incision. So that is very important. And Peri-procedural, I have already discussed. I'm not going into detail. Hemostasis, antibiotic envelope. This is a rapid study. This has shown that in high-risk situation is recommended. Tyrex envelope. Then, so this has not been shown to be beneficial. What is not been shown? Using local installation of antibiotic and antiseptic in the pocket. This has not been shown to be beneficial. Use of braided suture for final skin closure. Use of post-operative antibiotic therapy. There was one trial, PADIT trial. This has shown that if you give post-operative antibiotic therapy for 2 days versus a single antibiotic before procedure, it has not shown any benefit, in fact. So post-operative antibiotic therapy is not recommended. Most important, you have to keep the dressing uninterrupted for 2 to 10 days. So don't touch the dressing maybe 7 to 10 days once you put the dressing, okay? And patient instruction, these are all okay. Hematoma drainage or evacuation is almost always a no-no. Never drain a hematoma or infection. Even if it is a big hematoma, just see if it is compromising the suture, then only go for this thing, evacuation. There is no role of aspiration of hematoma. Evacuation also, it has to be only when it is that big hematoma. Otherwise, don't do it. Just put a pressure bandage and watch. So role of hematoma that I was just coming, any hematoma increases the risk of infection. So you can see on the left side. And in this rapid study, it has been shown that if you use a Tyrex envelope, the chance of hematoma causing infection is also reduced by that envelope. So there are 3 types of CIED infection. One is a pocket infection, localized pain, swelling, erythema, drainage, or erosion, device endocarditis. This often presents with an asymptomatic patient. You can have a pulmonary embolism due to the septic embolism, and patient may present with a pneumonia or something. And recurrent bacteremia may present as a fever of unknown origin. So this is the thing. The leftward picture, you may think that is nothing there, but this slowly turns out to be an infection and device erosion. So this is the earliest sign of infection if you have puckering or skin adhesion. So I'm not going into detail. So this pocket infection is mostly by biofilms. These biofilms are caused by staphylococcal bacteria mostly, and glycocalyx is coated. So this renders the antibiotic and the immune system to be ineffective on this infection. And another last line is very important. Infection or erythema involving only the skin or superficial erosion, incision, should not be treated as infection of the CIED and does not warrant extraction. These patients should be treated with antibiotics and or local debridement and followed closely to prevent or identify progression to a deeper infection. So this is device endocarditis. Recurrent bacteremia, if it is a gram-positive persistent bacteremia and you don't have any other source, it is recommended the device should be removed, including the lid. In gram-negative bacteremia, you can be less suspicious because gram-negative persistent bacteremia due to device is less common. So, and you have to take 3 sets of blood culture, just like an infective endocarditis. Only samples from the pocket should be cultured if acquired during removal and not passed to the sinus. So don't take a sample of the fluid which is coming out. Often it will not be helping you. What you should take is a pocket tissue while removal of the device. That will give you an ideal culture for that infection. And cultures of extractive CIED should be performed. I'm not going into details, these things. So imaging, transthoracic echo is less sensitive than a transesophageal echo. You can see the transesophageal echo is 30% more sensitive than a transthoracic echo. And chest X-ray should be performed. Chest CT is important to detect pulmonary septic embolism in a suspected device infection. Whenever you are not finding conclusive proof, you can go for a PET CT scanning with radio level WBC scintigraphy. This can help you to prove CIED infection if you don't get otherwise in echo. So this is the novel 2019 International CIED infection criteria. Again, just like an infective endocarditis, there are different criteria. I'm not going into detail. So diagnostic algorithm, I'm not going into details. So we have to understand if it is a definite CIED infection, the lead and the device has to be removed and antibiotic therapy has to be given. If it is a possible CIED, you have to repeat the blood culture echo, consider other imaging methods, and another is a rejected CIED infection. So definite CIED infection, when we isolated pocket infection with a negative blood culture or a systemic infection. If it is a negative blood culture with an isolated pocket infection, go for removal and extraction and antibiotic therapy for 2 weeks. Now, if there is a systemic infection, but vegetation cannot be seen on valves or pocket infection, then antibiotic therapy is 4 weeks. And if you can see vegetation, then the antibiotic therapy should be 4 to 6 weeks. Now, very important is removal of the CIED. The key aspect, because the biofilm which is there, you can never treat it unless you remove the device. Unless the biofilm is removed from there, you cannot treat it by antibiotics and all these things. So the key aspect to successful treatment is complete removal of all parts of the system and transvenous hardware, including the device and all leads. That is, the patient may have other leads also. There can be an abundant lead, there can be an epicardial lead. Everything should be removed if the patient has a infection, CIED infection, and also the vascular ports or permanent hemodialysis catheter of the same patient. The treatment concept applies to systemic as well as localized CIED infection. So if you find an erosion, the thing is same. It is an infection, you have to remove everything is possible in the body. And the most important thing in a retrospective study of 416 patients with CIED infection, antibiotic therapy without device removal was associated with 7-fold increase in 30-day mortality. That is very important. So don't be hesitant to remove all the device component. You have to go for a lead extraction if required. There should not be any compromise because you are looking after mortality. That is very important. And there should not be any unnecessary delay after the diagnosis of device infection. There are different studies which proves that if you do it early, the results are better. And wherever applicable, percutaneous device extraction, lead extraction are the methods of choice. And if the vegetation is more than 20 millimeter, then only you have to go for a surgical removal because there is a chance of vegetation embolization while going for a percutaneous lead extraction. So reimplantation strategies after device extraction, reassessment of indication of reimplantation has to be assessed. It is not that you have put a device, now again you have to put a device. We have to assess at that point of time whether the patient needs a device or not. Wherever possible, reimplantation may be avoided or delayed until symptoms and signs of local or systemic infection are resolved. Now, if the patient is dependent, what you can put a permanent lead and you can connect the lead to a pulse generator outside the body and on the same side of the pacemaker infection. Preferred access site for replacement are the contralateral side. So that is a temporary site. The temporary site has to be the site of the infection. You have to keep the contralateral site clear so that you can reimplant the device. And temporary pacing who are not pacemaker dependent should never be done. So I'm not going into details. So this is the novel strategies for infection prevention. That is the biofilm formation. If we have something, we can stop the biofilm formation, then we can prevent the device infection. So the biofilm adhesion is more with a polyurethane and least with a titanium. So this is the biomaterials. But this maintaining sterile environment, systemic or local antibiotic or antimicrobial pocket irrigation has not been shown to be effective in prevention of biofilm formation or after biofilm formation. So this is coming now. So this is in the research mode. I think it will maybe coming in 3-4 years. So it is a nitric oxide coated leads. So anti-biofilm properties of nitric oxide is that in low doses, it acts as a signal molecule promoting the dispersal of biofilm. High doses, it destroys the planktonic bacteria by free radicals. It is an anti-fouling surface and degrades and prevents biofilm of even multi-resistant bacteria. So this is the left side, if you can see, it is the pacing lead which is coated by this material. This is a polymer containing the NO release. So it releases NO and this prevents biofilm formation and biofilm reduction. So in a study, it has shown that it significantly reduces biofilm formation on the lead. So this is going to come up, NO-coated leads. I think this is one of the important things. Second is modulating the extracellular matrix, because extracellular matrix is a 3D scaffold with bioactive proteins and peptides with angiogenic, chemotactic, antimicrobial growth and signaling molecules. And if you have a decellularized matrix bioscaffold, which causes tissue healing, that is one of the things that is going to come up in the future. So these two are not there now, but these are going to come up and research is needed on this. So to conclude, CIED infections can cause death if not recognized and treated early. Be aggressive in the treatment of CIED infection. Any device adhesion, erosion is device infection. There is no doubt in that. And whole system should be explanted. There is no role of only taking out the device and keeping the lead. Lead extraction percutaneously should be done with device removal, as most pocket infection have associated with lead sleeve contaminations. Lead should never be cut and removed as a removed. So it should be removed as a whole. Otherwise, what happens is that whenever a second person wants to extract the lead due to unhealed infection, the lumen will be gone if you have cut the lead, and you cannot pass a lead locking stilette into that and remove the lead. So never cut a lead in a device infection. Hematoma should be prevented and almost never drained and aspirated unless absolutely needed. Thank you.
Thank you very much, Dr. Majumdar. Very elaborative talk on infective AICD is a very common problem we face in our very like difficult problem which we see in our patients. Thank you very much for your elaborative talk and the newer things you have told. Have you used them in your practice, like that sleeve you told and the Tyrex? And
Yeah, Tyrex is important because in the rapid study, it has shown that it reduces this thing. But there are few studies which came after.
have you
rapid.
used it practically?
Not frequently because of cost concern. I
Cost
think.
concept is there. So another is matrix you have told.
No, that is coming up. I think that those two are translational research. So one is a NO coated lead that is going to come up. So it will slowly reduce, the polymer will reduce NO, that will prevent the biofilm formation. And second is modulating the extracellular matrix. So if the infection is within the 90 days after implantation, that is mostly due to the contamination at the time of surgery. Now, if it is more than 90 days, it is due to improper healing. So unless there is a proper healing, there is a chance of contamination later also. So that healing part is affected by this ECM modulation.
Right. Thank you very much. Any other questions or inputs? Yeah.
Excellent talk, Suchit. I think I will make some comments which may go against what you have said. I found some of the things very theoretical because in my practice, I always give antibiotics pre and post implant. And whatever I have seen, most physicians, most cardiologists would give antibiotics. I'll find I have not seen those who would not give antibiotics. Number one. Number two, you have said don't touch dressing. Dressing.
No, dressing not. I told that the initial that so you the
don't
pressure
touch dressing for 2 to 10 days.
Pressure bandage can be removed after 1 day. That is okay. But other than that, the dressing which is put on the site, that don't touch for 2 to 10 days. That is the recommendation.
You do not mean that dressing.
No, not pressure bandage. Pressure bandage
No,
is maximum.
I am not talking about pressure bandage. I am talking about dressing.
Dressing is
Routinely,
not open.
generally, I discharge my patient after 2 days, maybe after 3 days.
2 to 10 days is
2
recommendation.
to 3 days.
You can.
And before discharge, I make it a point to open, see the wound, dress again, and send the patient home.
Yeah, means that is, I think, because that is not
That is-
always necessary because
There is
people
number
don't-
2.
People don't keep admitted means the outside in
And
for 2 days. The next day
Number
they discharge.
3, that the infected pocket, you don't have to remove the whole implant always. You have recommended that it has to be removed
Has to
always.
be removed.
It is sometimes very difficult to remove the lid, extract the lid. It is not that easy.
No, I know
And
that.
the
I know
cost
that.
involved is also sometimes enormous if you want to use, say, laser or something like that
No,
to
no,
remove the lid,
what I personally feel is that
And-
lead should be removed if possible. That is the thing.
if possible.
Obvious.
Okay.
Obvious.
So, but you said that it has to be extracted.
Correct. That is the recommendation.
Somehow, 1 or 2 cases I have managed without removing the lead. I have pulled it gently and was unable to remove the lead and explanted the generator, what we call disinfected it, incubated over a period of 48 hours and implanted in the other side with a new lead. That lead remained in position because I could not remove it. There's 1 or 2 cases.
If in an
And-
elderly patient, frail patient, malignancy and all these things, often these things are acceptable without
And-
going for aggressive things.
And the other thing, about pocket. I was lucky and I am surprised myself that I have managed patients with infected patient went home after about a month. After that, she came with infection and I was horrified. Infected, pocket. But luckily I could manage her with antibiotics intravenous for 7 to 10 days. So these are certain instances I am telling.
I think these are all, whatever I said, this has come up from different studies and significant number of patients has been considered.
Unfortunately, we never compile our data and we do not make a study of say 400, 500 cases, and mortality I have never seen.
I have seen mortality.
You have seen,
Yes.
because you are
I have
doing
seen
more
mortality.
number of cases maybe.
I
But
have
I
seen
have
mortality.
seen patient, who had repeated implantation and patient moved from CMC Vellore to IMS to Calcutta, most of the centers, for 10 years.
Yeah,
And he is having infection repeatedly. And ultimately I said, I can't do anything. So things are
So
like
that
that. I
depends on
just
the
wanted to
organism.
share
That
and make a
depends on
comment.
the organism.
Okay, thank you very much for the practical points, and thank you, Dr. Majumdar. Next presentation.
Thank you so much, Dr. Majumdar. And we're moving to the next discussion. So I love to invite Dr. Rakesh Sarkar on dais, and the topic is case-based discussion on sudden cardiac death. Thank you.
Yeah. Good afternoon, everybody. At the outset, I would like to thank the organizing committee and the scientific committee to allow me to present in front of this august audience. So today, my topic is on sudden cardiac arrest, case-based discussion. So without much theoretical discussion on sudden cardiac death that everybody is aware, whoever is practicing cardiology, and I'll straight away go to some cases and take you through some cases which will portray some of the clinical situation which might come across as a situation of sudden cardiac arrest, may be revived or may be not saved. So my first case will be on a 57-year-old lady who presented initially as anterior AMI. Her ejection fraction was 45% with hypokinetic hereditary thrombolysis, followed by revascularization was done by stenting and LAD, but presented with sudden onset of collapse after going to home. And theoretically, she didn't require any kind of device before discharging from the hospital, but somehow she was managed to be saved and resuscitated at home and finally brought to hospital. So in the year, the team found to have some white QRS tachycardia, and clearly it is showing something called ventricular tachycardia that everybody is very much cognitive about. And finally, she received shock, which terminated the tachycardia and came back to sinus rhythm. Finally, she was taken up for EP study and ablation because she was getting this kind of VT again and again. Fortunately, there was some clue why the patient was taken for the ablation and EP study. This case was actually done when I was doing my fellowship in Hyderabad. So that's why I wanted to show that case, because most often post AMI, post revascularization patient who doesn't come under the guideline of getting any device still may have some kind of ventricular tachycardia or arrhythmia, which may warrant some device or kind of special management with regards to arrhythmia. So this is the 3D mapping was done by CARTO system, which is showing some scarred area, which as you can see, the non-purple area, which is actually a scarred area surrounded by the borderline zone, and the purple area is presumed to be the healthy area. Not going into detail, the ablation was done at the borderline, which is the run-of-the-mill strategy for ablation. But surprisingly, which was the driver for this VT for this particular patient was the PVC, which was coming as a Purkinje potential firing. As you can see, interestingly, there was some signal, sharp signal, which is just coming before the onset of the QRS and presumed to be culprit for the Purkinje fiber firing, which is also present just before the QRS onset in sinus rhythm. So that was actually targeted, and finally the patient could be saved and finally sent back without the device. So PVC in patients with EF more than 40% after myocardial infarction sometimes can be fatal. That is the whole idea of showing the case. Maybe sometimes medically managed if it is possible to be managed aggressively, especially if the burden is more than 30 PVC per hour, taken from some study by Garzoulos et al. In European Heart Journal in 2019. And this need to evaluate multiple risk factors along with the ACD risk before consideration for ablation, unless and until it goes to that kind of situation. So the second case is 40-year female, structurally normal heart and recurrent syncope. From the ECG, which we actually could be able to collect when the patient didn't present with the syncope, showing very narrow QRS PVCs, which are very interesting, and sometimes you can see some variable coupling interval with regards to the sinus QRS. So these sort of PVCs are actually thought of culprit for sometimes R-on-T phenomena, and that was showed later to generate the VT, or to trigger the VT. I would rather say to trigger the VF straight away. And this lady was getting recurrent shock because of the VF, what actually was being triggered by that PVC as a very short coupled, rather variable coupled PVC. And this PVC was finally targeted again by the ablation strategy, and finally the in fact the presumed area was left posterior fascicular area, and finally the patient could be able to be managed by ablation itself. So this is a third case. This also happened, this case was also managed during my fellowship days. I felt this is little interesting, that's why I try to showcase it. So this is a 17-year-old boy who was admitted with fever and recurrent seizures, and sometimes back he got some IV phenytoin as a part of management of the seizure. In past history, there was no such major illness and no such family history, nor any sudden cardiac death in his family. So the first ECG which we could be able to obtain, that is showing not much abnormality along with the normal echocardiography. But later there was some dynamic changes in the ECG which drag our attention to some special entity of the problem, and surprisingly that degenerates into something called very fast VT degenerating into VF or polymorphic VT, which required shock for saving the patient. So clearly from the ECG, what will be the first kind of presumption for everybody as a practicing cardiologist, that is the Brugada syndrome that all of us thought about. And accordingly, we kept the patient on antiarrhythmic, because in Brugada, most of the antiarrhythmic are contraindicated. So we put the patient on isoprene infusion along with cold saline, because importantly, beta blocker cannot be given in this patient. So finally, after some physical examination, getting some lymph nodes in the cervical area, we thought it could be something as an inflammatory cardiomyopathy, and we actually advised for PET scan, which showed some intense uptake in the mediastinal area. And there was some intake at the same time in the myocardium also. So cardiac MRI is also done. Finally, the patient received implantable cardioverter defibrillator, but that was donated device because he was little poor, and lymph node biopsy showed actually no granuloma, which we found to have something maybe related to some inflammatory disease. So again, the patient got admission after 1 month because of some syncope, which we actually saw at ER. And finally, we saw that there was some PVC which are coming as very short coupled one and degenerating into VF. So the patient was managed throughout the night on the same day with isoflurane infusion, again with hypothermia, cold saline, and received almost 80 shocks at night. I mean, 110 defibrillation shocks from ICD along with the external defibrillator, because after some time the ICD stopped working. But this is not the end of the story. He was again put on steroids, silostazole, theophylline, because quinidine was not available at that point of time. Finally, the patient was taken on one Sunday morning for ablation. The pericardial puncture was done to access the epicardial space. And finally, the radiofrequency ablation was done at the RVOT area, which was showing some scarred area, along with some signals, which was actually the driver for PVC from the same site. So finally, the last case which I try to show, that is again one 45-year quite young patient to present with syncope. Almost this patient also came as a sudden cardiac arrest patient, resuscitated at some time at home by his relatives, having EF of 45% with basal septal thinning. And interestingly, there was some VT which was having some special features of pleomorphism, that means bit to bit variation. So these markers of inflammation in the ECG was prominent as a part of pleomorphism, which was initially described by Panda et al. In PACE in 2015 with regards to sarcoid or any inflammatory cardiomyopathy. And the diagnosis was also made for this patient as cardiac sarcoid, which showed the lymph node biopsy also as a non-caseating granuloma, along with the PET uptake in the left supraclavicular and cervical lymph node. So the risk stratification of SCD in sarcoidosis, if we just want to look at, there will be a lot of risk factors with regards to cardiac sarcoid in terms of sudden cardiac death. But the most common and consistent finding would be the lower ejection fraction, which is always a notorious thing for sudden cardiac death in this kind of inflammatory cardiomyopathy. So as recommendation, it is not always less than 35% of ejection fraction, which we actually presume for normal ischemic or non-ischemic substrate, but it is little higher on the side for which we might actually require the ICD implantation to mitigate all this problem. So does location and quantification of the FDG uptake also predicts SCD risk? Yes, sometimes it is having incremental information and benefit over the qualitative, qualitative information, that is the location. If it is increased focal RV FDG uptake, that is one of the surrogate for increased risk for SCD. At the same time, quantity of uptake is also sometimes matters a lot, because that can actually give the idea of the inflammatory status of the patient. So predictors of future device therapy may actually depend on like patient with syncope, lower LVF and third degree or complete AV block patients always at risk for sudden cardiac death. So to conclude, the sudden cardiac death often occurs in patients without known pre-existing cardiac pathology, which is the main concern for getting rid of this kind of extreme situation. This is prudent to identify the symptoms, but often we miss the symptoms because there is actually no symptom beforehand. We actually detect the patient as sudden cardiac arrest. So it is important to identify the substrate if possible, just to pick up very minor findings of HCM or sometimes LV non-compaction or sometimes some ARVC also should not be missed to identify this substrate, and the action taking is important and paramount to get rid of this problem. Thank you.
Thank you, Dr. Rakesh, for very good presentation. And from your presentation, we come to know that the sudden cardiac death not only occurs in coronary artery disease patients, there are various electrical substrates, other reasons which a specialist can find out it is difficult for normal interventional cardiologists to foresee these things without the need of super specialists like electrophysiology specialists. For the sake of time, I think we move ahead.
Sure.
Thank you very much.
Sure. Thank you.
The next speaker.
Okay, thank you, Dr. Sarkar. So we'll move to the next discussion, which is wireless ICD. And for this, I'd love to invite Dr. Sanjeev Mukherjee. So, sir, please be on dais. Now it's over to you. Thank you, sir.
Respected Chairperson, I thank Scientific Committee for giving me this opportunity. So in the next few minutes, I'm going to talk on the given topic of wireless ICD. So let's understand the concept. So the moment you see something like a wireless ICD, you think I'm going to talk about subcutaneous ICD, but answer to that is it's not. It's something more than a subcutaneous ICD. So now we are moving towards something called as modular cardiac rhythm management. And like our modular kitchens, I think this is a newer concept that is coming up as far as rhythm management is concerned, where treatment will be kind of personalized for patients based on what kind of disease they have. Because we are slowly, as Dr. Suchit was talking about, a lot of pocket infections, a lot of mortality, and that is a truth and something we should move away from. So subcutaneous ICD and leadless pacemaker is something that we are looking as a combination where these devices will communicate with each other in a very safe and reliable way. So that is what we are moving forward with. And what does it do and what help it does is it takes away the lead from the entire system, because as we know that this lead and the pocket, these are the two main things that are main concern for all our devices that we put. So it will probably take away that and add ATP into the leadless pacemaker system. So you have a system where subcutaneous ICD is there, a leadless pacemaker is there, both are communicating, and your leadless pacemaker delivers ATP, which is not there in a subcutaneous ICD as of today. So what are the limitations of present day devices? As I said, transvenous pacemaker devices all have got leads which can get infected, not just infected. Over years, we find a lot of lead related issues. The leads stop working, they get fractures, they have, kind of conductor fractures. Sometimes you have got, surface degeneration. So those kind of things will happen, which has to be removed. Device infections have been discussed quite in detail. So in today, do we have a system? Answer to that is yes. Subcutaneous ICD, Boston has come out with something called as an emblem platform that they have. They have got a subcutaneous ICD as emblem, and they have also got a leadless pacemaker. So what is a leadless pacemaker? It is a rate responsive single chamber pacemaker, which has got its own battery and has got nitinol tines to fix itself to the myocardium, as we see with Micra. So how does it communicate? At this moment, we have got only a unidirectional communication between a subcutaneous ICD and a leadless pacemaker, where the subcu ICD gives command to the leadless pacemaker. The leadless pacemaker cannot communicate with the subcutaneous ICD as of today. So and what is the kind of language that they use? So as we all know that most of them use radio frequency. When we see ICDs being evaluated in a device clinic, they communicate with radio frequency energy. So same here, subcu ICD communicates with radio frequency, while the leadless communicates with what is called as conductive communication. Now this is something I'll spend a minute on it. Conductive communication is the new thing which we will discuss in a minute. So how do we implant? Obviously, an ATP-enabled LP or a leadless pacemaker is implanted using a 21 French introducer sheath, a transfemoral venous access. A leadless pacemaker is deployed at the apex. So it is important when we will be implanting this device for the purpose of communication. It is very important to implant the device in a particular way, because you cannot implant the device on a free wall because it will perforate. And second, it is also the angle of the leadless pacemaker, which is essential, as I'll show you why. Now, subcutaneous ICD, as we all know, is implanted on the left lateral aspect. The PG is there on the left lateral aspect, and the lead is there on just close to the sternum, as we all know. So this is what is going to the configuration. Now, I just want to point a minute on this thing about this the leadless pacemaker that you see. This leadless pacemaker angle is going to be very, very important. The leadless pacemaker must remain parallel to the PG and the lead, then only it will be able to communicate. So that is what will be important when this device system come into use.
And the one I was talking about, how are they going to communicate? They are going to communicate with a language called conductive communication, where this is called as galvanic coupling. That is how they're going to communicate. The devices that have been used in animal studies and also in human studies, what they have done is they have done the standard programming. That is, you have got a conditional shock zone when you put a subcutaneous ICD between 170 to 220. So you've got a conditional shock zone. You have got 3 ATPs. So 3 ATPs followed by shock. And you can also program a shock while the device is charging at a rate of 220. So this was the usual programming that they did. And this is one of the examples in an animal model where they have clearly shown that the patient develops a VT, the device is able to sense it, deliver an ATP, and terminate the tachycardia. Now, the question would be how much of energy or battery life I'm going to lose. And from data, they say that 1,000 bursts of ATP per year will take away about 1.5 weeks of the battery life. And whereas your telemetry of about 1 hour in a year will take about 2 months of battery life. So we are not going to lose a lot of battery life as with this technology. Is the technology coming? Answer to that is yes. This is what we have. The trials have started, and they are going to enroll about 300 participants, already started, and started in 2021. The trial will be over by 2025, and probably we'll have results by 2030. But human trials have started. And just quickly, the point about communication. How are these devices communicating? Now, this is something which started quite late in about 1990s. They started working on this technology, and they call it galvanic coupling. And what it means is that your body tissue is being used as a conductor. So there are low voltage electrical signals, AC current signals that are generated in the PG, and they are sent. And while this, as I showed you the device, when you send those signals from PG to when there is an arrhythmia going on, it will be sensed by the shock coil. And when they communicate, the leadless pacemaker will fall in between, and that is what is going to sense this galvanic coupling or the information that is being transferred from the coil to the PG. So advantages is, why have we not used RF energy, which we always had? That is kind of communication between a PG and a programmer that we all see. The reason is that it is going to take more battery life, one, and two, most of this energy is lost while it is kind of traversing in tissue. So therefore they have come out with this new form of energy called galvanic coupling. The only problem is, as I said, if your device orientation is not proper, then it probably might, the information might be missed. So that is the only concern. So when these devices will come, you implant, make sure that the device, the leadless pacemaker, is kind of parallel to the PG. Because as we all know that the sub-Q ICD uses a vector. So the vector is between the shock coil and the PG. And therefore, again, saying the same thing, that it has to be parallel to the PG. And this is how it is going to deliver the signals. So what happens is, when a VT comes, the shock coil will sense it and ask the leadless and command the leadless pacemaker to deliver ATP. And it sends two such simultaneous commands to the leadless pacemaker, and they all are synced with the R wave, so that the information, there is no oversensing, it doesn't affect the device functionality. So that is what was important, and they have taken care of in this system that they have produced. And this is what I was saying. And this is an animal heart. The angle, this is called the angle that we have to keep in mind. This alpha angle is what will be very, very important when a leadless pacemaker will be implanted. So in a human heart, they're saying an angle of roughly about 50 degrees is what you're going to get, and that angle should be perfect to kind of deliver ATP if the patient develops a VT. What is future? So what they're looking at is, can we have devices which can have bidirectional device-device communication? That is, leadless pacemaker communicating with sub-Q ICD communicating with a leadless pacemaker. If that happens, then the diagnostic certainty will be more, because both leadless pacemaker and sub-Q ICD will identify the rhythm better. You will have less of T-wave oversensing and inappropriate shocks. So over time, probably we'll have devices which will communicate in both directions rather than what we have now, where they are communicating in only one direction. So what is a take home about wireless ICD? So probably this modular cardiac rhythm management is an idea, and that is, it's a tailor-made therapy for a particular patient. Suppose a patient needs an ICD, you put an ICD. Over years, when he develops, requires a pacemaker, you put a leadless pacemaker. So that is what we are looking at. We're looking at a therapy where part of the therapy can be done now and rest can be taken care of later. At this moment, what happens is if I think that my patient is going to have pacing requirement, I am going to put a transvenous lead because I think that he will require a pacing. So let's put a transvenous lead. So the idea would be to take the lead away and make sure that there are less of complications. So throughout the lifetime of patient will have devices based on the requirement at that particular time. And that is what probably modular therapy is going to help. So I'll end it here. Thank you.
Thank you very much, Dr. Mukherjee. You have enumerated I think a new thing. I think it's not right now used beyond trials in human beings. I think the technology increased as we used leadless pacemakers, now coming with these devices.
Yes.
It is really a good thing. Just a quick comment from audience.
Yes, sir. IVL with a subcut IC.
Because sometimes you get a more of a catheter or a pacemaker. But if you have only subcut ICD with inability to pace, is it safer to do intravascular lithotripsy?
So you are talking, so at this moment, whatever sub-Q ICD you have, they do not have any ATP facility. So you cannot deliver. So that is why this new thing has come in. So that is not. And I think they are not able to do it. That is why they have come with this concept.
Thank you very much.
Thank you.
So the next.
Thank you so much, Dr. Mukherjee. Thank you so much. So we're moving to the next discussion. So for this, I love to invite Dr. BP Pandey, sir. And the topic is Guide to Guidelines and Algorithm for LDLC. Thank you.
Okay. Right. So from very high tech to lower gear, but we'll tell you something. So let's start with the case. This gentleman, 58-year-old, who had a stem in the past, he's obese. CT showed diffuse disease in the LAD and RCA. He's a known diabetic, well controlled on a smaller dose of metformin. His blood pressure was also controlled with the ramipril. And his LDL was 160 and he was on 40 milligram atorvastatin because he could not tolerate 80 milligram. And at this point in time, he had a LDL of 85. So telling you about this, whether we are treating him to target. So definitely we all know by current guidelines, even Lipid Association guideline, we are not to the target because target is less than 55, anyone who had got atherosclerotic cardiovascular disease. And if you believe in Lipid Association guideline, it is probably closer to 30. So how we can ensure the correct attainment of the goals? So what are the options? What do the guidelines recommend? And how we can escalate is my topic for next 8 to 9 minutes. So what is the amount of reduction of LDL with different modalities we have? We all know if we use the highest dose of statin, either Rosuva or Atorva, it is around 50-55%, not more than that. If you use ezetimibe and bempedoic acid, it is to the tune of another 20%. If you use evolocumab, probably another 60% reduction. If you use a combination of statin, ezetimibe, and PCSK9, probably closer to 70 or 75. So it's like a mathematics. Once you know what is the baseline LDL, when I see my patient in the clinic, I fix up the target for this particular risk factor. I need to attain this. And then you take what percentage of reduction is required and you tailor-made your medication. There's no whims involved. So if my target is to reduce from 160 to 55, I know neither statin nor combination of statin with ezetimibe, nor probably 3 combination is going to bring 160 to below 55. It's like mathematics. But every time mathematics doesn't work, we'll also discuss that. Because what we presume when we see, because there are so many lifestyle modification, once patient gets MI, he sticks to the diet, he starts exercising at least for a few months to a year, and then he forgets. So what was the Western guideline? 2019 guideline. This is, I think a lot of jumbling there will tell you there was a sea change. Like when we were doing graduation, the guideline was to keep LDL around 130. When I post-graduated, it came down to around 100. When we passed DM, it was still 100. And then 10 years down the line, it came around 70s. And last 5 years after 2016, we moved from 70 to 55. So there's a difference. Even 2016 European guideline target was 70, and 2019 it became 55. And by 2022, we have Lipid Association guideline of 30. Lower the better. We'll also discuss even ultra low LDL level, how it is helpful. So this is the Lipid Association. If it is projected right, you can see you have an algorithm. Still we see in Calcutta, no lipid profile done to STEMI patients because patient is not fasting. I'll not name the hospital, I have worked there. The guideline Lipid Association non-fasting sample must be taken at the point of first contact, and then you take forward. So once you decide your goal, choose the therapy and start remeasuring every 2 weeks. So that's the guideline. Then you'll be able to escalate from statin to ezetimibe and bempedoic acid and PCSK9. Difference in Lipid Association guideline is that once you encounter ACS, STEMI, NSTEMI, we start nowadays with high intensity statin with ezetimibe. That's the first thing. And if the LDL is more than 140, sometimes we give even PCSK9. So we strike quite hard. Later, always we can de-escalate. There's no harm because these medications do not have much of side effect. And sometimes we see LDL 230 at day 0. And when they come for first follow-up 2 weeks, LDL has come down to 30, just one shot of evolocumab and ezetimibe high intensity statin. And later on, you may not repeat every 2 weeks according to the guidelines. So we can tailor-made in our system where cost is the constraint. So that was the whole. So algorithm for ACS is totally changed nowadays, not only on angioplasty, but also on a medical therapy, who will get guideline mandated therapies. If they have a heart failure, what is the guideline mandate for LDL level? And this is important study, Da Vinci study, because in the European world where the healthcare is taken care by the government, once the guideline from 2016 was changed to 2019, they found that only half of the patients are meeting the goal. In fact, for secondary prevention, even in 18 European countries, they were giving only 50% of the population high intensity. So what we can talk of this subcontinent. And similarly, they could not achieve the result when the target was very steep according to the 2019 guidelines. So this is in nutshell the Da Vinci study. And Indian data also says that 80% of the patients with established heart disease, they do not achieve even European guidelines, what to talk of Lipid Association guidelines. So main problem is not in the application of the knowledge. Adherence is a big problem because adherence to the guideline, what we recommend, patient forgets after a few weeks. And most important is not the cost, is the will to understand and to take so many tablets daily. That's another problem because all STEMI, NSTEMI at the time of discharge, you'll not find less than 10 medicines in the discharge slip. So it's very difficult to take for years together. We'll discuss how we can tailor that also. So compliance is a problem, and adherence and persistence to stick to the medication. What are the most important factors? Why patients do not pill burden is one of the important things. So in this, you can find that the MI level is, event rate is much, much lower if you have got good adherence and good target level, vis-a-vis if you are not able to adhere to the medication. Say someone who has got adherence more than 80%. On the gray bar, you can see the event rate is much, much less. So the continuations, discontinuations are various causes, but the pill burden and the cost is most important one. So what is the way forward? Once we got a PCSK9, we probably thought we'll give 2 injections in a month and get away even without statin, but no trial has suggested that, because all these trials are on top of statin, what we call the tolerated doses of statin. So what else we can do? If there is some injection which you are able to take every 6 months, will it be all right? Probably yes, why not? If my LDL is down by 3 injections in a year, I'll not be bothered about the LDL. So the compliance rate is much, much better. So it all depends on the cost and what are the newer therapies which will be available shortly. Something has been approved in the Western world already. So the more intensive lipid lowering therapy is important to get this ultra low level. When the child is born, our LDL cholesterol is closer to 30. And the nowadays goal is you try to keep what was the LDL at the time of birth. If that is also not important, you can't get lipid profile every 2 weeks, at least try to achieve LDL at the level what your HDL was. That's the cheapest way out. So on day 1, if your HDL was say 32, I'll try to get LDL down to 32, simple thing. So you may not go lipid profile every 2 weeks, you may do it every 6 months. So there are ways and means to reach the target, but the fact is the ultra low level LDL we have seen on the Fourier trial, we have seen in the Odyssey trial, those patients who are the lowest or ultra low tertile of LDL, they fared much better. The event rates are much, much lower. So the aggressive therapy helps in achieving lower LDL target. And unless we try to do it while the patient is in hospital, it is difficult because patient may not come to the follow-up. He may drop out and you have no chance to escalate your therapy. So the combination therapy is the way to go forward. And nowadays, at least in ACS patients, we are using 2 drugs, high intensity statin and or ezetimibe or bempedoic acid, plus minus PCSK9, depending on the baseline LDL level. Once you get these silencing RNase injections, which is needed only 2 injections in a year, probably the adherence to the LDL target will be much, much more. So I'll stop it here. Thank you very much for the patience hearing.
Thank you very much, Dr. Pandey. We had a very good information about how to lower LDL, how much to lower LDL, and the role of newer agents like PCSK9, drugs like that. I agree with you fully, and this has been very well shown in your the recent guidelines you are showing. But there is at least there is a like mind block in even in mind of cardiologists, physicians everywhere in the world, that these new agents which are coming, because there are some reports that the mortality issue is not yet clear. As we know from trials, the very large trials from statins with other lipid lowering agents, that at least they don't, there are many controversies which always float, many WhatsApp messages, social media messages, which will float that it is all unnecessary thing and all these things happen. But the physicians don't seem to hear it. But for PCKS inhibitors, you see even I as an interventional cardiologist still have a reservation in using it. One point is the cost of it, and the second point is that there are some studies in the literature which say that the safety of these drugs have not been yet completely like cleared. So what do you say? What do you have to say about these studies, which say that some studies says that PCKS inhibitors might increase the mortality risk? So when these studies come, even as an interventional cardiologist or as a core cardiologist, we still have reservations in starting such therapy till we get the clear evidence in the trials.
Yeah, so regarding the safety, now we have got the 5 years data. So there is no issue with the safety or the side effects of the molecule, particularly these Repatha, Evolocumab, or else other one in the ODC trial. You have to use your personal judgment, particularly if you are dealing with patients with severe LV dysfunction, very frail patients, or with history of hemorrhagic stroke. I think bearing these 2-3 situations, there has been no adverse report, and we have now got 5 years safety data.
Or how do you feel like using these molecules in primary prevention?
Yeah, as I said, that is the far dream. So for primary prevention, I think the role of these injectables or monoclonal antibodies will be kept only for the homozygous or heterozygous familial hypercholesterolemia with at least one more risk factors. So it will be there for homozygous mostly.
Right. Any other questions? Yeah.
Yes, Dr. Nath.
Yeah, but the statins benefit patients in acute coronary syndrome irrespective of LDL level.
Yeah.
So that brings a question whether the LDL levels are directly proportional to the event rates, and whether we will be able to reduce this by adding other molecules like, say, bempedoic acid. Ezetimibe does not alter the event rates. That we know, if you agree with me. Bempedoic acid, there is some evidence that if statin is not effective, maybe. PCSK9, I am not sure. Please, your comment.
So we have got the compelling evidence with ezetimibe and statin combination, no doubt. Now we have got a clear outcome data with the bempedoic acid. So there is no doubt, not only the events, even mortality reduction. For these monoclonal antibodies, if your LDL level is on the upper tertile, say someone who has got more than 70, you have got mortality benefit with the alirocumab, because Fourier was not looked at. So mortality benefit is there if your LDL is above 70 with established heart disease on top of statin and ezetimibe. Is there a mortality benefit if your LDL is less than 70? That has not been shown, as Dr. Modi was saying.
Of course, for this point, we know that statins have a pleiotropic effect, pleiotropic pharmacology, and it has more effects. It has other effects rather than LDL, lowering of LDL itself. The newer drugs which we are approaching are not that effective. So in therapy, the statin is the mainstay. There is no doubt. Even if anything is there, the statin is the mainstay.
Everything will be on top of statin.
These things we are taking as an add-on. That is always there.
I think post this.
Thank you very much.
Thank you, Dr. Pandey. Thank you very much. And we have reached at the discussion point, which is the last discussion. So before that, I'd love to thank each and everyone who have gave their valuable comments and valuable, delivers. So thank you. But now the session will happen like when, why, and how. This is the point of discussion. So I love to invite Dr. Indrani Sham, Dr. Imran Ahmed, Dr. Neeraj Prasad as a chairperson. So I request all to get up on the stage, and Dr. Rohit Modi as well. So sir, please get on the stage to chairperson the whole thing. And of course, the moderators, Dr. Bishwarup Sarkar, Dr. Hemant Kumar, Dr. Satyajit Samanta, and Dr. Shaumen Nandi to moderate this session.
We'll be starting with an interesting session. When, why, and how. So,
Ma'am, we have our guest online actually, Dr. Sanjay Chawal. So I request technicians to connect him. The topic and the point of discussion is tips and tricks of a radical. Sorry,
Hi,
apologies.
hi, am I
Apologies.
audible? Am I audible? Hello? Am I audible? Hello, am I audible here?
Hello, Dr. Sanjay Chugh. Good evening.
Yeah, hi,
You are-
good afternoon. Am I
you are-
audible?
You are very well audible. I am Dr. Rohit Modi. How are you?
Oh, hi, I'm good, thanks.
Yeah,
We
please.
meet again.
Yeah. You can please continue with your presentation, please.
Okay, so I'll get started here. So it was about tips and tricks for radial, and so I sort of made that a little different by saying tips and tricks for chip TRI. I'm just going to presentation view. So my slides are visible, right?
Yeah, you can continue.
Yeah. So this is a must-have book being launched in July. It's a handbook of transradial interventions by Oxford University Press. I edited the book, and it's going to have a whole lot of tips and tricks and everything about transradials, which we've actually been working on, got delayed because of COVID. And look out for CHIP TRI, which is now 18 November. Just give me a call. That's my number and that's my email, and hope we can pull it off together. We all know these are the CHIP factors which are associated with increased in-hospital MACE. 7 patient factors and 6 procedural factors. This is from the JAC 22 paper. And if to that we add the radial factors for CHIP TRI, then they include the smaller diameter radial arteries, the radial artery sheath mismatch, and anatomical challenges, as we all know. So the first tip is actually to size it right, to cut the CHIP TRI radial factors, to minimize radial artery sheath mismatch, and thereby to minimize spasm, procedure failure, and subsequent radial artery occlusion. By doing a pre-procedure ultrasound of arm arteries, it does help. It's not mandatory. For the beginners, definitely it makes a difference. These are the various radial artery sizes that we studied, radial and ulnar artery sizes. This was a large study of almost 6,000. You can see the sizes in our patients are below 1.8. If this was the sheath sizing protocol, which we put forward and was published in Cath Cardiovascular Intervention, based on the radial artery sizing, if one actually uses the appropriate sheath size, where the radial artery sheath size is 1:1, then actually one can reduce failure, spasm, and crossover. So using this, using the sheath sizing protocol, we did the country's first transradial rotablation. This was way back in 2003, using a 7 French sheath. And in those days, radial 7 French used to be a very difficult challenge because hardware was very limited. And subsequently, we've done the world's first 4 French transradial angioplasty outside of Japan in 2013 at FMRI Gurgaon. And that was the first Slender Club workshop. So this was the country's first transradial rotablation. The important thing was we did 7 French using a because this was a 2.3 millimeter radial artery, 7F guide, XB 3.5. There was a cone of calcium in the LAD, and so it wouldn't give way with balloon dilatation. So we used a 1.5 burr, and then still the waste wouldn't go with even a 2.5 balloon, 2.75 balloon. So we used a 1.75 burr. And after that, we were able to get rid of the waste, subsequently stented with a 4x15 vision stent. It was a bare metal stent in that era, and then post-dilated with a 4.5 millimeter balloon. And this was the final result. But then calcific arteries don't always meet femoral axis. So these days we're finding that people use all kinds of technology for calcific arteries, but most, in fact, all of that can be throughput the radial arteries. And this is an example where we had calcific LAD, and of course there are cost limitations. We looked at this and we thought that we would do a dilatation with a balloon, see how it goes. And after dilatation with the balloon, this is what it looked like. And then we tried taking a stent in, it wouldn't go because of the angulation there. And there's a calcium there. You can see there's 2 lines of calcium, which means that it could be actually more than 270 degrees. But then it's actually a bend there. So what we did was we used a guide liner and we were able to get the stent in, and that was the final result. So again, you don't have to go femoral just because it's a CTO. And I'm actually showing a case. This was done live at Apollo Hospital, New Delhi, February 2008. And this was the case, a post-CABG guy who was continuing to have angina. And this was his anatomy. And we were able to cross using a intermediate wire. At that time, there were not so many hardwares available. And he had double bifurcation. We were able to stent both were bifurcation lesions. And we stented with good result. And this is the India's first slender 5F CTO series, which we performed and was published in Indian Heart Journal. This was done using 5 French catheters. And as you can see here, to improve guide support, we actually used a JL 3.5 instead of a 3 to get better guide support. Now, this is another example of a patient who had heart failure, presented with heart failure. He had severe aortic regurgitation, dilated aorta, and he had severe MR. And he was a post-CABG guy. So we decongested him, did his angiogram, and we found a bifurcation lead in the circumflex. So obviously we weren't offering him DVR. It would have been too high risk. And then we thought that it was probably ischemic mitral regurgitation. So the tip here is that we used the AL2 guide because this was a large aorta and we had to do a circumflex intervention. So you see, this was a AR2 guide. And then we were able to dilate the proximal and the bifurcation lesion. And we stented the bifurcation lesion, did a kissing balloon using 6 French. This was all done using 6 French, then stented the proximal and good result. And this ischemic MR actually disappeared. So the other option we have, if the radial artery is actually smaller, then you could actually use a 6-7 GSS for 7 French guide. And this is an example of a patient who had tortuous subclavians, had a LAD D1 bifurcation disease. And so this was a 011 Medina. We did a SKS using 2 stents together, and then this was a post-kissing balloon, good result. Then this is another case, a DK crush. Again, this was done using a 6-7 GSS. The radial artery diameter was only 1.6 millimeters, very difficult to take 7 French in that. This was done via distal radial access, a lot of tortuosity, 360-degree loop. And this was the LAD D1 bifurcation. And side branch also had a 90% osteal stenosis. And so here, this was a DK crush, and so we put a wire in the main vessel, side branch pre-dilated the main vessel. Then we put a stent in the side branch, balloon in the main vessel, stent in the side branch, balloon in the main vessel, and then this is the side branch stent deployed. Then subsequent to that, we checked for good result, and then recrossed the wire into the side branch. Did a kissing. That's the first kissing. And then this was the LAD, which was then second option was to stent that, took the wire out from the side branch, stented the LAD, then we recrossed and did a kissing balloon again. And this was the kissing balloon. And this was the final result. So, all kinds of patients can actually be done complex, even if you need 7 French, or a lot of them can be done 6 French. But this was a DK crush done using 7 French, so we use a 6-7 GSS. There is another technology available. If the radial artery is small, you can go sheathless using a sheathless guide. The railway system by Cordis, which is actually 2 French smaller than the sheath. And this is how the railway system works. You can use any guide catheter, and the dilator actually goes inside. And as you can see here, it's going sheathlessly. And this was an osteal LAD stenosis, which was stented. And this was the final result. So it's not the strongest of the species that survive, not the most intelligent, but the most responsive to change. And this is quoting from my own publication in Indian Heart Journal. And 10 years later now, the femoral operators have become more meticulous with femoral access. And we too have also become more meticulous. And we've now also moved to distal radial access. And this is how distal radial access is. It's from the anatomical snuff box. Puncture success in our series was 88%. Less than the standard radial puncture, where it was 98.5%. And what we found was that the access takes more time, but the radial artery occlusion is same. The biggest advantage is that the risk of having a compartment syndrome is less. And we published this in Indian Heart Journal as the Data Star study. And this is how the access is done for distal radial artery through the anatomical snuff box. And the hemostasis is so easy that it can't bleed. And the risk of having hematoma is virtually nil. And there's no risk of a compartment syndrome either. Now, this is an example of a takeoff of the LAD, which is virtually at 90 degrees from the left main. And the Judkins guide won't sit there. So what should we do? Should we cross over? And the answer is no, we don't need to cross over. The simple solution is that you wire whatever comes first. So in this case, we had the wire going into the ramus. So we took that, and then we were able to gently move the guide towards the LAD. And and this is just Judkins, and Fielder XT was used, and that was used to cross the lesion there because we put a bend on that. And then this ostial LAD was stented, and that's the So we don't need to cross over. If you have difficulty engaging, there are various techniques of doing it. And now this is an example where, again, the LAD is coming off at an angle from the left main. And this is a pretty short left main. So it's very difficult to use an XB to get into that Judkins. So these are situations where we recommend using a JL3. But then again, when we used a JL3, the support was not good. So we had to use a guide liner. There's some problem with the quality. So you can see the guide liner there, which we used to get the result after the stenting. So what kind of guide? You can actually use any guide of your choice, as we have a very large experience even using Judkins. You can use any guide of your choice. And then, of course, there are techniques of improving the guide support by using buddy wire, balloon. Now, this was a Shepard-Crook RCA, primary angioplasty. There's a lot of tortuosity upstream. And so we used wire and balloon to enhance support, to cross the occlusion, and stented it. And this was a successful result. So there's no need to go femoral just because of tortuosity, complexity, or anomalous origin. This is an example of anomalous RCA, which was very tortuous and which was done actually using AR2. This is vein grafts. Again, AR2 is a good guide to use. AR2 was used in this case. This was done for a vein graft to the OM2. And we dilated, stented. And after stenting, of course, there was a dissection. So we used you again use the buddy wire to enhance support. And we were able to take the second stent in. And finally, this is the dissection after the first stent. So again, used buddy wire, took the second stent in, took out the buddy wire, and then stented. And that was the final result. So guide wire can be used to enhance support. Balloons can be used. Guide liner can be used. Again, if you have to do a left radial in an obese, particularly post-TBG patient, where we always go left radial because that's easier and easier to hook grafts, then it's best to go distal radial access because you can keep the hand on the belly. It's comfortable for the patient, and the operator doesn't have to lean across the patient who's obese. So that saves the back of the patient also, very comfortable for the patient. And this is a tip if you have a very severe loop in the subclavian called an alpha loop, then just use an angioplasty wire to cross that. And with the angioplasty wire, such loops can be crossed. Now, this is a situation where it looked like an occlusion of the subclavian, and but this is not actually an occlusion. So the way to test that is to use an angioplasty wire. And so you see here, we've just tested it with an angioplasty wire. We're looking for the entry because it's just tortuous, and the origin is at such an angle that when you do a retrograde injection, it didn't fill. But you see, there was a bit of a tortuosity, and the angioplasty wire goes in. So on top of that, you can take your diagnostic and the guide, and you can work with that without any problems. Now, this is a situation where the aorta is rotated, or if it's a right-sided aorta, then your wire will keep going into descending. Just deflect your wire off the knuckle, and you're able to enter the ascending aorta. The same happens for Shepard-Crook when you can use the same technique to come to the ascending aorta. And this is an example of this patient had a acute MI and the circumflex was occluded with a retrofiscal RORSA, a retrofiscal right subclavian. And in this situation, we always use a small Judkins or an XB. So we used a JL3 even for a circumflex lesion, and it was comfortable. We were able to complete the case. Again, this is an anomalous RCA and a RORSA, retrosophageal right subclavian. You can see the course of the catheter and the wire. It's a retrosophageal right subclavian. These are very difficult to do, but we used the AR guide, and this was a primary situation. So we were able to hook the the RCA and complete the case successfully. That shows the stent. There's some problem with the image quality here. There you can see the completed case. This was an anomalous origin RCA and a Shepherd crook. So in conclusion, distal or radial access. The distal radial access takes more time, fails more often, but there's no risk of compartment. You can do all kinds of complex cases through the transradial or distal radial access. And a PTCA wire is very useful to traverse anomalies, be it cubital, subclavian, or sometimes, if you have a high region of radial from the brachial, then the origin is small. So you can actually downsize your guide catheter to 5 French and complete the case. And you can actually use any guide of your choice, enhance the support using buddy wire balloon support guide liner. And in a RORSA, you can use a JL or an XB3, and these are easily negotiable and all kinds of cases can be done. This is the Handbook of Transradial Interventions, a must-have for anybody wanting to learn and sharpen their skills with tips and tricks for transradial. This is going to be launched in July, and look out for CHIP TRI Radial Life, 18 November. It's still in work in progress. Just give me a call and let's team up and hope we can pull it off. Those are my contact details. And I'm also, you can follow me on LinkedIn, Instagram, Twitter, and that's my connect address. Thank you so much for your attention.
Thank you, sir, for the nice elaborative talk on all radial interventions. Anything to ask from anyone?
Dr. Chok, very nice to listen to you. I want to ask you a question about, suppose you start an angiography, coronary angiography, radial access, and you find radial artery is uncrossable due to obstruction. What will be your next choice?
Radial artery is obstructed due to obstruction, meaning what? Because if you have, see, when you start, you actually feel the radial artery, okay? So if it is palpable, then the next thing, because a lot of people are doing radial and ulnar accesses these days.
Radial artery may be palpable because there is collateral circulation, radial artery may be palpable, but when you try to cross with a wire, you find wire is not crossing, it is obstructed.
No, it doesn't happen like that. If it is occluded and filling by collaterals, then it is filling by ulnar. So whenever you take a case, you have to, we don't do Allen's, but then this is actually like an Allen's, where whenever you start a case, you feel the radial and you feel that the pulse is there. Just occlude the ulnar here, where it enters the palm, and then feel the radial again. If it is palpable, meaning that it is not being filled by ulnar, then there's no way you're not going to be able to puncture or cross that radial artery. If you find it occluded, means you were not careful enough to actually, before starting the case, just occluding the ulnar and then feeling the radial, you would know that this is filling by collateral. So
we nowadays do not do Allen's test because it is no longer recommended.
You have to think before.
It is no longer recommended. Allen's test is no longer recommended.
It is not. No. Then this is what will happen. Then this is what will happen. Allen's test was done just to make sure that the ulnar was patent. But if you think, you see, these days what is happening, a lot of people are doing ulnar access, a lot of people are doing radial access. So you don't know what's happening. So, and the patient might not be able to tell you. So you must always feel the radial, then occlude the ulnar. Just, you're not doing Allen's test. You are just compressing on the ulnar at the point where it enters into the palm, then simultaneously feeling the radial.
Do you do it routinely?
Then this thing will not. I do that all the time. Yes.
Okay.
I do it all the time. Every case.
Suppose
everybody
you find,
should be doing it. That's the basic. This is the basic thing for getting into radial. For radial access.
No, with the permission
look, I
of the
get
chair.
calls at 11 o'clock in the
Suppose
night.
you find there is evidence that the radial artery is not flowing antegrade. By pressing there.
Not playing antegradely, you would know because the pulse would not be palpable, or if it is palpable, then it would not be when you compress the ulnar. So obviously you're not going to get into it because you don't have flow in that artery. That's an occluded artery. Why waste your time on that? So radial is all about thinking beforehand before jumping into it. So when a patient walks into the lab, then only you start your planning. If it's a short statured guy, please let me finish. Please let me finish. Let me put radial into correct perspective, sir. When a patient walks in, you need to know if it's a short statured guy, you know already that his aortic arch may be small. You already know that the radial artery may be small. So you're already preparing yourself rather than getting into it and then saying patient has spasm.
So now you're thinking, his arteries may be small, I need small hardware. Am I going to use 7 French? What am I using? Is this patient good enough for this? So all that thought process starts before. And the least you can do is when you start the case, when you go into the recovery in the pre-cath area, feel the radial, and then you occlude the ulnar and feel the radial. So easy. And you know that you have antegrade flow.
Okay, so
So
you
easy.
find that
What you might say is a different way of putting your question, is that if you go radial axis and you find a loop which is uncrossable, because that can lead to complication, it can lead to extravasation,
that is not
then
my
what do you do?
question.
My answer is very simple. In that case, you can cross over to the other arm. You can go ulnar on the other side or radial on the other side. And when we did 6,000 of these studies, we took 6 minutes to check the radial, the ulnar,
Okay,
and the cubital
suppose
fossa to see if the
you have
origin,
checked-
the
you have
bifurcation was at
checked
the normal place.
radial and you have found the pulse is stable.
Sir,
and-
excuse me. Actually, we are running short of the time. Thank you, Dr. Sanjay Chok. A nice discussion from the, I would say, genius and the person who has done a lot of work in radial angioplasty. I hope you continue this. Thank you very much for joining us. Thank you very much.
80% people are doing radials now, but we need to put it into right perspective. That's why we need these discussions and meetings, because radial is about pre-planning and a good thought process. You can do everything successfully because all we are trying to do is something good for the patient. And I can tell you this after doing 20,000 radial procedures, of which maybe 9,000 were angioplasty, remaining were probably angiograms and other combined procedures. So this is how we've gone ahead, and we've had very low rate of failure or problems in that. And that is because you always think ahead and you got to plan your procedure like you should do for every case, not only radial. So then these questions don't just come up. Thank you so much for your time.
Thank you.
Thank you, sir.
Thank you, sir.
So we are moving to the next part of discussion, that is tricuspid valve repair, when and how. So for this, I love to invite Dr. H. Das Mohapatra on the dais. Thank you, sir.
কোনটা দিতে হবে এখানে? Tell me which one. Okay. Good afternoon. It is too late. Long session. Like tricuspid valve area is a neglected valve in adult cardiac surgery. I'd like to thanks to the organizing committee for asking me to deliver this talk. You know the heart valves. I don't have to tell you. It has got 4 valves. And you must be amazed to know that who described first in probably 14th century during Italian Renaissance that all valves should open and close completely. Otherwise, the heart will not function adequately with the regurgitation of blood in the atria from the ventricle. This person who described this was born in during Italian Renaissance in year 1400, Leonardo da Vinci, and we cardiac surgeons and cardiologists will remain indebted for his initial observations. He's an universal genius and multifaceted talents, and you know all about him. Actually, the William Hunter, 300 years later, he defined Leonardo as the greatest anatomist of his time and probably his all times. And he managed to observe and to study the anatomic drawings and annotations of Leonardo. Now let us come to the point. tricuspid valve repair. Why? I've been asked very specific questions. Why and when and how? You all know this tricuspid anatomy is very complex anatomical features. You can go through, and this complexity, the cardiologist may find difficulties when they are trying to do transcatheter interventions. As you know that this is the largest and the most apically positioned valve of the four valves, and the normal TV annulus is D-sepate and 11 ±2 centimeter, and a diameter of 28 millimeter. As I mentioned earlier, the tricuspid valve was, especially in adult cardiac surgery, was very much neglected. Earlier, tricuspid valve function was thought to be the less important than the aortic and mitral valve. And moderate to severe tricuspid regurgitations, we thought that can be managed clinically. But now the scenario has changed, and if uncorrected, the left-sided heart failure can progress to right-sided heart failure. Why tricuspid repair? You can see that 5-year survival with severe tear and of LV ejection fraction of a heart failure ejection fraction of 34%. The tricuspid regurgitation, the marker is annular dilatation greater than 34 millimeter in diastole or less or greater than 32 millimeter in systole. Tricuspid valve repair, when and how, that depends obviously upon the etiology of the tricuspid regurgitations. Let me talk about something about it. The primary tricuspid regurgitations with abnormal valve morphology. First comes is the Epstein anomaly, and the acquired tricuspid regurgitations. You can go through this series of causes: myxomatous, degenerative endocarditis, carcinoid, rheumatic heart disease, and chest irradiation. And lastly, the iatrogenic. That is, you will come across, or you have come across, the pacing leads, transvenous pacing leads causing severe tricuspid regurgitations requiring interventions. And the second thing is functional tricuspid regurgitations with normal valve morphology, which can be ischemic or non-ischemic, cardiomyopathy, aortic and mitral valve disease, pulmonary artery disease, and pulmonary vascular disease. These you all know the algorithm of the pathogenesis of tricuspid regurgitations in mitral valve disease. I don't have to go through. I will go through quickly the causes. The functional tricuspid regurgitation is highly dependent on annular dilatations, and which is different from the mitral valve regurgitations, where they require 75% annular dilatation needed for severe mitral regurgitation. In contrast, only 40% can do tricuspid regurgitations. That you all know is that. Now, I cannot go through all the how we repair all types of tricuspid regurgitation, but I will go through first. I have to touch it. Epstein anomaly, which is a very common congenital anomaly. You know, it is the origin of the septal and the posterior leaflet are displaced downwards into the RV, and the leaflets are usually deformed. Actually, the anterior leaflet is becoming cell-like, and that you all know, and it can be associated with atrial septal defect. When we repair Epstein anomaly, only in symptomatic cases with severe right heart failure and cyanosis, it can be mild in children. They do not require any kind of surgery. In my early years, I did repair a couple of young adults here, and but I am now following a patient now also at the age of 55 with a Epstein anomaly, but she's doing fine. So I don't think she will require any surgery. Now, the goal of surgery in Epstein, as my Devasis is here, he's doing this routinely to mobilize, to normalize as much as possible the position and the function of the tricuspid valve and to reduce the atrializations of the right ventricle. But what is the reparative technique? There are two types of techniques, you know. One is Danielson technique, which can be Danielson modified with a ring. Danielson technique is the application of the atrialized portion of the RV. And another is Carpentier repair, which is much more aggressive than the Danielson. I prefer Danielson than Carpentier when I used to do congenital. The pacemaker lead induced severe tricuspid regurgitations, which is very common. And in my personal experience, I have repaired a couple of tricuspid valve with cardiopulmonary bypass. Is a resection. It may require resection of the leaflets and repair of the resection of the deformed tissues and repairing the leaflets, the pericardial leaflet reconstructions, or it may require Gore-Tex cord replacement. Lastly, we have to put an epicardial pacing lead for pacemaker function. The surgical repair of tricuspid repair when we require functional tricuspid regurgitations, which is annulus is greater than 40 millimeters in diameter or 25 meter square is preferred treatment for functional TR. This is the AHA, ACC, and ESC guidelines. You can go through this, and we all know that the tricuspid valve, first point is that it is highly recommended that during mitral valve surgery, in case of severe tricuspid regurgitation, they should undergo left-sided surgery. And you can go through, and nowadays, I think cardiac surgeons are much more concerned about leaving the tricuspid valve unattended, which I do, and also mild to moderate TR, I normally repair it with mitral valve replacement. And I have seen that postoperative progress is much better in those situations. The principles of all surgical TV repair is that restore the full leaflet mobility, correct the leaflet prolapse, and establish large leaflet coaptations and the reduce and stabilize the annulus. Now, what type of surgical repair surgeons consider? In general, the ring annuloplasty of the tricuspid valve is preferred over direct suture annuloplasty because of decreased incidence of residual or recurrent TR and the need for reoperations and increased patient survival. Now, that varies from surgeon to surgeon. The ring annuloplasty requires much longer time, at least half an hour to 40 minutes cross-clamp extra time. That you have to consider. Now, earlier days, surgeon used to do suture annuloplasty, which I mostly do. First, suture annuloplasty and De Vega technique, you know all, the De Vega suture annuloplasty, but I personally prefer quick operation is the K bicuspidization technique, where you obliterate the posterior leaflets of the tricuspid valve, and it does function very well. It's very quick, only take 5 minutes job, open up the right atrium and do the job. It does very well. Or the annuloplasty ring technique. This is the De Vega technique. De Vega described this for long ago, and it is still a very, and there are lots of modifications of the De Vega technique. Every surgeon, they modify the technique. They put Gore-Tex strip, they put partial De Vega technique just in the posterior leaflets. So it does well actually, and it does not take that much time in doing the ring annuloplasty. This is as you know, that because I have not put any videos or something which is very time consuming, and in this short talk, it is better not to put video, keep the thing simple. And this is just the tailor-made annuloplasty ring, and all surgeons who are familiar with that, it is very easy to implant, and there is nothing in it. Let us talk about the functional tricuspid regurgitations. Now the transcatheter repair, that is very important, because I cannot finish my talk without saying how the cardiologists, they are venturing in this field of cardiac science, because they have already captured a lot of things, and I have to, and this is for cardiologists, they'll be feeling very much happy to note that in times of change, the learners inherit the earth, while the learned find themselves beautifully equipped to deal with a world that no longer exists. You see, I have to keep the cardiologists very happy, because because the cardiologists, they have already, capturing, they are leaving no stone unturned in the cardiac science, and they have taken out the coronary artery disease, the aortic valve disease, and a lot of other things. So this tricuspid is very important, but you have to see whether this quote, Eric Hoffer is a fantastic man, and he is a quote writer, and he was awarded by the Presidential Medal of Freedom. He writes lots of quotes, and I thought this is very much important in this meeting, and you will say, yes, it is appropriate or not. Transcatheter repair of functional tricuspid regurgitations. It is an emerging therapy. In patient with functional tricuspid regurgitations with left ventricular ejection fraction less than 40%, severely impaired right ventricular function and pulmonary hypertension, where the surgery will carry high risk. So these are the cases we should go for transcatheter repair of tricuspid regurgitations. The primary challenge, however, in the development and utilizations of transcatheter devices, the complexity of the anatomy and the closeness of the AV node, coronary sinus, right coronary artery, aortic valve to tricuspid valve. The patient selection is important, which is done by the CT and echocardiography for deciding the appropriate procedure and device. Am I late? Going late? Okay, 1 minute. Transcatheter repair is ace to ace using MitraClip or TriClip, Abbott Vascular, or the Pascal clip, Edward Life Sciences, and the Forma special device for leaflet coaptation, and the Tri-Align or cardio band devices designed to decrease the TV annulus dimension. the Mitra clip is the most commonly used device in 80% of the cases and can be repositioned or removed. I don't have any experience. I am a cardiac surgeon. Cardiologist will help me to say which device they use. Additional clip can be implanted for adequate tricuspid regurgitation reduction. Recently, Mitra clip has been modified to tri-clip to facilitate the bending maneuverability of the device in RA and RV cooptations. So you are the best judge. The tri-align technique is the replication of the surgical K bicuspidization technique. Here, the devices, they occludes the posterior leaflet of the tricuspid valve, making the tricuspid valve bicuspid. However, this requires a lot of clinical trials and safety and quantify decrease in severity to tear severity, its efficacy and outcome on the patient's outcome quality of the life. Recently, I was reading in the New England Journal of Medicine, it came out in 17th of May, and you may know the Soibal Kaur, who is the son of Sisi Kaur, and he was the investigators, and they have found very excellent results of this transcatheter technique. Lastly, I would say that a multidisciplinary team approach is needed. A cardiothoracic surgeon, interventional cardiologist, echocardiographer, anesthesiologist, and the patient's primary physicians. That's the way we can go forward. Thank you.
Thank you so much, sir. So any question or comment?
Sir, good to hear a surgeon in an interventional cardiology meeting. And you were saying that cardiologists are taking everything away. That's not true. Rather, we take cardiac surgeons as our very good friends. And whenever a interventional cardiologist is in trouble, I think it is the experience of every interventional cardiologist in a cath lab when he does not need a cardiac surgeon when he is in trouble. So I think this science of cardiac surgery is a science which I feel the interventional cardiologists themselves should promote it, because it is ultimately the combination of the two sciences, which ultimately it is the patient who is to benefit, and it is to the utmost importance that patient gets the maximum benefit out of our treatment. And it is always good if we work in a combined manner, in a team, in a positive manner.
I fully agree. I just pointed it out. This was just as a joke.
Yeah, that's
and nothing serious.
That we understand.
I just mentioned
and
it.
Rather,
I just mentioned it
that
because
rather we appreciate your gesture to come here in the interventional cardiology and give a talk to us. Thank you, sir. Thank you.
You're welcome.
Thank you. Thank you, Dr. Mahapatra. So our next speaker is Dr. Devashish Das. I request sir to get on dais. The topic is virtual reality.
Well, good evening, everybody. First of all, thanks to organizers, especially Dr. Pandey and Dr. Hajra, for giving me this opportunity. I understand this is the last talk. I'll try and keep it crisp and brief. I also happen to be a cardiac surgeon, and so my talk might have a bit of more surgical angle to it, but I have tried to include all sort of structural diseases. What we're going to talk about is role of virtual reality and advanced 3D imaging in current cardiac sciences. Why is this technology important? So There is actually a indexed Elsevier journal called Annals of 3D Printed Medicine. It is as important as that. That itself suffices to say that this science is progressing and is already matured. So why do we need it? We need it to anatomically understand the heart in a completely different manner when we are dealing with complex diseases. We deal with a lot of wide spectrum of complex pathologies in structural heart disease. As surgeons, we encounter redo situations far more than what we would encounter, say, 5 years before. It is also a very good tool for training purposes and shortening the learning curve of complex procedures, as well as these can be used for patient counseling and education. So there are a whole lot of terminologies like virtual realities, mixed reality, augmented reality, and 3D printing. We're just going to touch a little bit about that. Anybody who's interested to know this thing, there is a very good paper in JACC Cardiovascular Imaging, which encompasses the entire review of current status of cardiac 3D printing and the future directions. So look at this. We've got in structural heart disease, we've got a whole lot of nomenclatures, classifications, different. If there was any way to visualize the heart much more than a 2D image, how easy it would be to repair the defects. And that is where this technology comes in. The echo planes are highly subjective. The images which somebody shows might have missed a current particular plane. And our surgical repairs at times involves complex baffles, complex routing of outflow tracts, which requires a 3D understanding. But there is a paradox. Most of the technology that we currently use would give us a 2D image, whereas we live in a 3D world. And our human eyes view everything through stereoscopic vision. So depth is of paramount importance, but we don't get that in our current images. So what this technology does is this basically simplifies the entire process. This obviates the need for mentally reconstructing those images in our mind, whether you're doing a transcatheter technology implantation of a valve, or I am doing a very complex biventricular repair of a double outlet right ventricle. It takes away that mental reconstruction bit, and you can actually visualize it and plan it much better. And that is where this comes in. So we will just touch upon briefly as to what is virtual reality, augmented reality, mixed reality, and ultimately when we print a heart, that is a 3D printing. So in virtual reality, you're dealing with an image. You're completely disconnected from your current environment. You have the image in a 3D reconstructed fashion with which you can interact. When you also have a recognition of the room you're sitting in, where you're that is an augmented reality. When you can actually interact with the image, you can rotate it, you can actually get inside the heart, you can see it from different angles. That is mixed reality. And when this particular image is using a software which has a 3D format, printing friendly, is actually put into a 3D printer and printed out, that is 3D printing. So it is a process. The core of it is a DICOM image. It can be most commonly is a CT scan or an MRI, or it can be even a 3D echo. Based on that, it would be 3D rendered into multiple segments. Then it would convert it into a virtual image or 3D image, which then when given into a printer, it will actually print the same CT scan in exact dimensions, replicating that heart. So you basically have a heart in your hand. And that is the advantage that, it is not like a generic heart you're holding that particular patient's, that particular heart with exact dimensions, with exact deformations in structural heart disease. And you can plan your interventions or our surgeries much better. So you'll require certain devices like headsets, controllers, base stations. And these days now the technology has even advanced that you can actually add haptic systems. So it can, as surgeons, our tactile feedback is very important, but you can virtually even have, if you have haptic systems integrated into your virtual reality model, you can get a tactile feedback as well. So this is just an example. I visited the Amrita 3D lab, and there is a patient who was taken up for a univentricular line of repair, had a previous surgery with a PA band. And this was a situs inversus dextrocardia with a tetralogy with a complete AVSD, which we had to repair. So we actually gave them the CT scan of the patient. They reconstructed it because the image was too high, and I actually wanted to see the lab. I went there. And I could actually enter this heart with wearing a headset, knowing the entire intricacies inside, and then we could repair it very well without any problem. So that degree of understanding, I don't think I would have had if I just used a echo to understand, to plan the surgery. So just that when we take it to the next level, AR uses a real world setting and where virtual reality is completely virtual. When we have an option of interacting with the image, like in this previous image where you're wearing a headset, you are holding a hand, and this will actually, you can rotate it, you can cut across into segments and then look at the heart at various angles. Obviously, there are different technologies. Setup is different. A 3D printer is required for 3D printing, whereas the other two are only images. So you can only interact with, like, it is a fixed model that you get in your hand, whereas in other virtual reality or augmented reality, you can repeatedly visit the images and interact with it in a different manner. So as I said, I explained to you what is the process of 3D printing. So the possibilities are endless. In clinical settings, it is hugely helpful for surgical decision-making and planning, also for your transcatheter planning, for surgical simulation, and certain times you can tailor-make a baffle, you can tailor-make a patch, patient-specific, based on that particular heart. It has also a huge educational potential for simulation training, for morphology teaching, and also for patient and family education, especially when in, say, congenital heart surgery domain, when we have to perform multiple procedures, you can explain to the patients as to the parents as to why do we need it. So this is just a very busy slide to explain that name any structure in the heart, and there has been a study on it with a 3D printing model, whether it is an aortic stenosis, whether it is a mitral valve, whether it is a heart tumor, in addition to normal congenital world, where this has already found a huge popularity. This is how a printer looks like. This is from the picture I took at the Amrita Institute. So, and this is how it looks like. So this is a transposition preoperatively. This is a post-op transposition which has been treated with an arterial switch. You can have other models printed like this to understand it better. This is the flow process. So CT images, segmentation, then a 3D reconstruction, ultimately printed that particular heart from a printer. The materials are different. It can be a hard resin. Most of the Indian companies would print the heart in a hard resin format. But now you also have silicon printers in which you actually have a soft model which you can interact very well. We will just show you certain pictures about sort of structural heart diseases. So this is an ASD. Imagine if you know your ASD device preoperatively like this, if you know where are the margins, where you would place your device, it just becomes a whole lot simpler. You can rotate it, you can put the device, you can see how it occludes, how far it is from other margins, whether it is sitting there nicely, and then do it. So you already have done it before proceeding to your cath lab. If you have a flow loop model, once this is an aortic stenosis model in which it is connected to a flow loop, and you can see that it replicates. So this is a Doppler of the patient, and this is an echo Doppler of the model, and it exactly replicates. So it is not only a structural, but also a functional replica of the same heart. And that is where it comes into play. So this is the aortic stenosis model. So let's say somebody is planning a very complex sort of TAVR. And if you have this preoperatively in your hand, your planning would be of a completely different level, especially if you have associated other abnormalities. So you can cross the valve, you can cross where you would deploy, how far are the coronaries, whether you will have any particular challenges because of a coronary anomaly. All this can be tackled. Even in aortic interventions, endovascular, whether it is adult coarctation which is being stented, whether it is a EVAR or a TVAR that is being planned, 3D technology has got its own usage. So this is another example where there is an infective endocarditis mitral leaflet perforation, which is occluded with a device. And it has been done on a model beforehand, before proceeding to the patient. Plus transcatheter mitral valve. So as sir was saying, transcatheter tricuspid valve. So all these, even coronaries, you can actually print the coronaries if there is an anomaly. You can put them into flow models to assess them. And especially in cases where you're implanting a valve and you're concerned about that the patient has had a CABG, has got a patent proximal or a coronary origin which is abnormal, which you might impinge while putting in a transcatheter valve, you can actually know it beforehand much better than your current 2D imaging or just a CT scan. So the scope is immense. You can plan your complex biventricular repairs in congenital heart surgery, transcatheter valve or device planning. In reduced sternotomies, we can actually see what is beneath the sternum before we enter, which makes our life much more easier as a surgeon. It is a very good tool for teaching. We conducted a DORV workshop recently in which we gave these models to trainees, and trainers actually trained them on 3D printed hearts. You can tailor make devices for patients like patches or walls just with that particular patient. So the future is already here. There is a mixed reality hologram. Microsoft has a Microsoft HoloLens, which a trainer can wear. So this is one of the maxillofacial cranial surgery reports in which trainee and trainer are on a different cities, and they could see the same images and guide the other person for the same procedure. So that is the power of technology. So in this particular, this is what is mixed reality model. So this particular person is wearing a headset, so he can, before entering the chest, he can again revisit the image, flip his headset back and wear his surgical loop, start his case. In the middle of the case, he again wants to see what was it like. He can put back his headset and he can visualize the heart and again go on to repair. Is there any evidence that this fancy technology helps? There is, so this is like a patient who underwent surgical VSD closure for multiple VSDs, then had residual, had some devices. Ultimately, it was 3D printed, and then all the VSDs could be got rid of. Even in adult world, there are multiple papers. As I showed you, there is a complete dedicated journal for it. So there are multiple adult cardiac structural conditions in which 3D printing has its own technology. It is not limited to congenital world only. This is one particular very important paper in which they had complex DORV repairs from Mumbai, in which they printed all the hearts. And as a result, 4 of the 5 patients actually ended up getting a biventricular repair rather than a single ventricle repair. There is a whole lot of complex planning that we have to do at times as congenital heart surgeons, and it also helps us in that manner. As I said, this is a video recorded in our own hospital where we were actually training our trainees for a complex thoracic beam repair, along with an arterial switch and an arch repair. And the main trainer was actually sitting in Canada and directing us. So that it is all possible because of integration of technology along with an open human mind. So as a teaching aid, especially to people who are not sort of even in undergraduate teaching, it has a huge potential to be used as a teaching aid, because you can get inside the heart, rotate it, explain each and everything to its minutest detail in a manner which was not available before. It has its own limitation. It costs around $3,000 to $5,000 for a printer. But the most important thing is you don't always need to print it. If you have a 3D reconstructed CT image, which you can interact with, that is sufficient for most of the times. And that is what we are harping on. So to conclude, advanced 3D visualization in cardiac sciences, it will find its usage increasingly as structural heart diseases become more and more important. It has a potential to be used as training tool, both in transcatheter procedures as well as complex repairs. The planning can be taken to a different level. It is also a tool to flatten the steepness of the learning curve for complex repairs. And there is already a soft evidence that doing this reduces the complication rates and the operative times, be it catheter interventions or surgery. So we as cardiac professionals, I think we should not shy away from this technology, and we can contribute to its further advancement by getting involved. There are a couple of Indian companies. One of them actually had a stall in your exhibition area where they had printed models of 3D hearts. This was there in there. I took these pictures from there just before I entered the room, and they actually had printed an entire aorta till the bifurcation. And these white spots are the calcific portions. The arch had some calcium, and now you can plan as to how do you want to enter this aorta to put, say, a transcatheter.